Your what?
Ayubowan.
A very good morning, ladies and gentlemen.
It gives us great pleasure to welcome you this morning as Vision Care celebrates Optometry Day and 12th annual scientific session. I am Viranga.
I'm Darunya. This significant in our calendar enables you, the most reputed experts in the field of optometry, to converge at a focal point in order to share your invaluable ideas and opinions with each other, while gaining momentum in the rapidly evolving world of optometry.
Vision Care has gained a reputation as a forerunner in the optometric sphere of this country by servicing an entire nation with a new vision in terms of eye care, and we wish to pledge our continuous aim to provide the best solutions which are on par with global standards. We wish to manifest the concept of change being the only constant, which is the mantra behind our endeavor to keep on changing with the time, which in turn provides our customers with the most current trends and methodologies in our field of expertise.
We value the wealth of knowledge and support given by every ophthalmologist and optometrist present here today, as it has paid for us to garner a wealth of knowledge in constantly evolving field of eye care. Ladies and gentlemen, let us rise for the national anthem. Please remain standing for a minute of silence to pay respect to our war heroes and past VC departures.
Thank you. Let's light up this elegant occasion by lighting the traditional oil lamp. We are delighted to invite distinguished chief guest, consultant eye surgeon, Dr. Mrs. Manel Pascual. Guest of honor, Chairman, Tertiary and Vocational Education Commission, Mr. Udeni Vikramasinghe. Senior Consultant Eye Surgeon, Special Advisor to Vision Care Academy, Dr. Upali Mendis. Consultant Eye Surgeon, Special Advisor to Vision Care Academy, Professor and Madhuwanti Disanayaka. Consultant Eye Surgeon, Dr. Aruna Fernando. Dr. Pabasara Costa, Dr. Dimuthu Gunasekara, Registrar at Karapitiya Teaching Hospital, Dr. Saman Basnayaka, General Manager, Mount Lotus Hospitals. Mr. Dasanta Fonseca, Chairman and Chief Executive Officer, Vision Care Optical Services Private Limited and Vision Care Group. Mr. Janaka Fonseca, Managing Director, Vision Care Group. Mrs. Kumari Fonseca, Director, Professional Affairs, Vision Care Group. Mr. Prasanta Fernando, Chief Operating Officer, Vision Care Group. Mr. Harsha Maduranga, General Manager, Vision Care. Representing General Management Committee of Vision Care and entire branch network. Mr. Srimantha Vevalvala, General Manager, Flagship Cluster. Mr. Vidya Jayaratna, Head of Academy and Head of Optometry. Mrs. Hiranti Fernand Pereira, General Manager of Finance Department. Mr. Sudarshana Vikramarachi, Head of Human Resources and Administration, Vision Care. Mrs. Asika Vasana, Chairperson, Optometry Day and 12th Scientific Session 2022. Chatura Madhushan, representing all academic students.
Thank you all. I would like to invite Mrs. Asika Vasana, Chairperson of Optometry Day and Scientific Sessions 2022, to welcome the gathering.
Good morning, everyone. I am very delighted to see your shining faces today. We are making our Optometry Day and 12th Annual Scientific Session. Today, I am privileged to welcome you all. Day by day, new innovations and technologies are emanating and playing significant role improve the optometry field. Because of that, we line up this year Optometry Day and Annual Scientific Session under Innovative World with Better Focus. For Optometry Day and 12th Annual Scientific Session, I warmly welcome our chief guest, Consultant Ophthalmologist Dr. Mrs. Manel Pascual. Our guest of honor, Chairman, Tertiary and Vocational Education Commission, Mr. Udeni Wickramasinghe. Special invitee, Senior Consultant Eye Surgeon, Special Advisor to Vision Care Academy, Dr. Upali Mendis. Consultant Eye Surgeon and Special Advisor to Vision Care Academy, Professor Madhuvanti Disanayake. Consultant Eye Surgeon and Vitreoretinal Surgeon, Dr. Aruna Fernando. And Senior Consultant Ophthalmic Surgeon, Dr. D.R.R. Kodikare. Special Consultant ENT Surgeon, Dr. Mrs. Sanjeevani Rupasinghe and Senior Optometrist Ms. Ananta Lakshmi as keynote speakers and judge panel. Senior Registrar, National Eye Hospital, Dr. Pabakara Costa. Registrar at Karapitiya Teaching Hospital, Dr. Dimuthu Gunasekara as member of judge panel. Special invitee, General Manager, Mount Lotus Eye and ENT Hospital, Dr. Saman Basnayaka. Also, I warmly welcome Mr. Dasanta Fonseca, Chairman of Vision Care Group of Companies. Mrs. Kumari Fonseca, Director of Professional Affairs, Vision Care Group of Companies. Mr. Janaka Fonseca, Managing Director. Head of Academy, Mr. Vidya Jayaratna. members of Ceylon Council Optometrists and Orthoptics, Sri Lanka Optometric Association and School of Ophthalmic Technicians, member of General Managers Committee, cluster managers, head of departments, committee members, staff members, and all presenters. I not take much time here because my colleagues are waiting to share the outcome of their researches with you and all. I wish my best of the competitors. Welcome you all again, and let's begin Optometry Day and 12th Annual Scientific Session. Thank you.
Thank you, Asika. She obtained her MBBS degree in 1985. Following this, she began her internship at the Peradeniya Teaching Hospital as an intern medical officer. Having successfully completed her diploma in ophthalmology in 1990 with 1 year of surgical experience, she was appointed as the acting eye surgeon to the base hospital Puttalam. Afterwards, she joined the National Eye Hospital Colombo as a registrar in ophthalmology. She was awarded the Master of Surgery in Ophthalmology by the University of Colombo in 1996, from 1996 December to October 1997. She served as a senior registrar at the National Eye Hospital Colombo. Then she completed her overseas training in 1997 at the Prince Charles Eye Unit in Windsor Hospital, United Kingdom. After the return, she served as a board-certified eye surgeon at the General Hospital Mathura, Kaltara, and Negombo. During this period, she was able to complete the 3-month fellowship of pediatric ophthalmology at L.V. Prasad Eye Hospital, Hyderabad, India, and training in small incision cataract surgery at St. Joseph Hospital, Trichy, India. She had the privilege of presenting papers on microphthalmus, chemical injuries of eye, and DULC at Annual Congress of the College of Ophthalmologists of Sri Lanka. Since October 2006, she has been serving as a consultant eye surgeon at the National Eye Hospital, Colombo, and has been training many undergraduates and postgraduates in ophthalmology. Also, a member of the Board of Study in Ophthalmology of Postgraduate Institute of Colombo, an examiner in MD Ophthalmology examinations, and also has been the chief examiner at several examinations. She has served the Council of Ophthalmologists of Sri Lanka since 2004, including being its secretary and advisor. She was the president of College of Ophthalmologists of Sri Lanka in 2011 to 2012. Currently, from October 2006, she has been serving as a consultant eye surgeon at the National Eye Hospital, Colombo. We are privileged to welcome our honorable chief guest, Dr. Mrs. Marnel Pascual, to address the gathering.
Thank you for your introduction. Good morning. Good morning. I must thank Mr. Dasanta Fonseca, CEO Vision Care Group, and Managing Directors Mrs. Kumari Fonseca, Mr. Janaka Fonseca, giving me this opportunity of joining 12th Annual Scientific Sessions and Optometry Day. I also appreciate Dr. Upali Mendy, Senior Ophthalmologist and teacher of my training also, and all other ophthalmologists present here, and Vision Care Academy staff and Vision Care staff and all the invited guests. And I welcome Mr. Udeni Vikramasinghe, who is Chairman Tertiary Care and Vocational Training Commission. And also I thank Mount Lotus General Manager Dr. Saman Basnayaka. I thought to discuss few important roles that optometrists can play in ophthalmic practice. There are many optometrists practicing in this country. They perform very well in this field. This kind of academic session will boost their knowledge so they can change one's life daily. Optometrists meet two types of patients, walk-in patients as well as referrals by ophthalmologists. The walk-in patient may ask for spectacle or contact lens, or sometimes they come for annual checkup. The referred patients already undergone examination by ophthalmologist, and they may come for spectacles, contact lenses, OCT, visual fields, or else for low vision management, or else for orthoptic management. But there are two differences. Walk-in patients has no, they have not undergone proper examination. If you optometrist is wise and smart, may find very obvious thing or very subtle thing which affect his life for lifelong. So that's what I want to stress, that the second group you have not much responsibility. First group, educated optometrists will do good job. There are many optometrist practices in Sri Lanka. That may be the reason most eye surgeons refer to vision care, because some by missing obvious and critical thing in a patient may affect his life, and sometimes we can save their vision. That is the point I want to stress. I thought to give some examples which we meet day to day in working practice. 85 years, at home, nicely living, no problem, watching TV, having all the day-to-day work. Suddenly, my son brings to optometrist just to change glasses. Not much of complaints, okay, managing well, bring for changing glasses. Then you do the refraction, you get very good vision. No problem, you can give the glass and send off. But someone will think twice, 85 years, never checked, seen ophthalmologist, or never dilated and seen, just managing well. You can ask about diabetes, hypertension, and whether she has undergone surgery. Sometimes they haven't never done any cataract surgery, whatever. Then you have to think twice. This patient may be having good vision, but may be having advanced problem, advanced glaucoma or cataract. That is the place where good optometrist will help to the patient, and actually it is helpful for the eye professionals to manage the situations. Sometimes optometrists write retinoscopy shows some lens opacities, and they refer, most of the time they refer, and sometimes the patient may not interested to see better, but when you see the patient, you can, if you see with the slit lamp, you may see the cataract, or when you see the fundus, you may see the cupping, then you can refer. But some situations, very elderly, small pupil, very small pupil, with the direct ophthalmoscopy, you may not see the fundus. And in those situations, dilatation will help. Then in a case like this, patient is happy, no complaints, but when you refer to ophthalmologist, you will dilate and see the fundus. You can see brown hard cataract, but with good vision with refraction. And by again she is changing glasses and waiting another 2 years. Then by the time patient reach to us, we can't do the phaco-emulsification and good surgery. Actually this type of patients day to day we meet. And actually then in that case we have to do extra capsular cataract extraction, and we meet lot of problems, and sometimes lens implantation is not possible, and vision actually sometimes after surgery not better than what she had with the refraction. That is the trouble. So we can't perform good surgery in advanced cataract. So that is where optometrists will do good work, good service to the patient. There are many more different cataracts, and you all familiar with. And white cataracts, generally patient come because visual loss is early. Brown cataracts, visual loss is late. And those patients on their own also they present, and surgery is successful. And even the hypermature cataract is difficult. Now white cataract also mature in this level need very good expert eye surgeon to operate, because any eye surgeon can get problems with very hypermature cataracts. That is also one place optometrists can advise. When there is little bit lens opacity with good vision, better to have assessment with the eye surgeon and see whether your cataract is needed to do surgery. Every cataract doesn't need to do the surgery, but meeting eye surgeon and with comprehensive eye test will help to plan your surgery. The other situation is patients with good vision, 6/6 vision, and complaining several times blurred vision and going to many surgeons, and vision 6/6 fundus okay, but the patient is not happy. Fundoscopy also, direct ophthalmoscopy possible, and with the blurred vision with sunlight due to glare. And driving, they complain most of the time driving difficulty, and indoors vision also good. Then these patients also very difficult to detect whether they have a problem. Then if you dilate and see only, you will see very tiny dot like posterior polar cataract. Actually it's necessary to dilate as well as see the slit lamp examination. Generally these patients have bilateral posterior polar cataracts present in young age. Generally we get the patients around 35, even 20s, some patients coming with bilateral posterior polar cataracts. They need early surgery. Surgery is difficult due to posterior polar cataract. Sometimes you meet with problems because posterior capsule there are defects. These patients also sometimes go doctor to doctor and detect later. Optometrists can suspect these cases need dilatation. Now this is another example. Patient coming to refraction to you, to the optometrist, and good refraction, no problem, we can give glasses. But good optometrist will see the fundus and detect cupping and refer to ophthalmologist, and it will help to diagnose lifelong problem. When you see when you check your patient's eye pressure, visual fields, you may take these photos, OCT, and you can come to a diagnosis of glaucoma, or you can exclude glaucoma. Sometimes you can see cupping like large disc with large cup also. You may think glaucoma, it's difficult to diagnose, but still you can diagnose very important disease or exclude. So this is very important place where optometrists play a big role. And we meet still, already we say in Sri Lanka we have good health practice, good optometry practice, but in eye hospital and private sector both sides we still get advanced glaucoma patients where we can't help much, and they think they don't never go to an eye surgeon. Sometimes they go to spectacles, but they haven't checked properly, and later they come with blindness. They want to do cataract surgery, but glaucoma, advanced glaucoma, by doing cataract surgery doesn't give good vision. So those still happening. This daily our clinics we meet patients undiagnosed glaucoma. That's why we should have good optometry practice so that we can give early detection of glaucoma. So another example where drivers mostly 40s 50s come with blurred vision. They go to refraction, then they get good vision. Sometimes they get glasses and drive, and they drive school buses and private buses, but their vision is not good. But if an intelligent person see the direct ophthalmoscopy, even if you see some hemorrhages or whatever, then you have to think twice whether we will give the glasses or think we have to examine the fundus. Sometimes undiagnosed diabetes with retinopathy, we can have glasses and go away. So that is important thing. We get daily basis in eye hospital with diabetic retinopathy, undiagnosed diabetes. So wise optometrist will help to prevent blindness in Sri Lanka if you advise to check fasting blood sugar and dilatation and fundoscopy, detect diabetic retinopathy, treat early, may need laser, any other treatment, but the time they come to us when they can't drive or when they fail to get the license, that the time they will come. Like if they have only cataract, yes, of course we can do the surgery and give vision, and then they can get the license and start working. But unfortunately, we get with patients maybe have cataract and diabetic retinopathy both, and they can't get the license. Then losing license means the family income will be affected. Their children cannot get educated. So this is important place where we can do some work through optometrist. And good diabetic control will save their vision for lifetime. Those some things even optometrists can helpful, because they have, when they discuss, sometimes patients understand also. Sometimes when we advise, when we rushing in the hospital and we advise them to go to diabetic treatment, sometimes they come again for surgery without any treatment. Some people about diabetes, they have a lot of misunderstanding. They don't like to accept whether they have diabetes. So they do some Ayurvedic, some treatment, whatever. They think then they, more than that, they advise to us also. Doctor, something like this you have very good to prevent diabetes. Then when we ask, they have 120, 130 sugar, that they think it's normal. I think that is one place where we have to work, because it's every patient is having diabetes. The time I have started practice around 80s, out of our operation list, one patient diabetic. Nowadays, the whole list is, all the patients are diabetes. We have 30 patients are diabetes. At that time, when we were working with Dr. Upali Mendis and Dr. Veer Singh, we have one diabetic patient, then we are very extra careful. Always consultant will do the surgery, we don't give to anyone else, and like a VIP like. So nowadays, for the trainees, earlier when we were training, we didn't get to do the surgery diabetic patients, 1 or 2, we don't do. Nowadays, if we avoid diabetic patients to give in for trainees, then we can't give anyone to trainee, because everyone is diabetic. Because we are worried if a diabetic patient trainee does the cataract surgery, and if you get a posterior capsule rupture, more problem than normal people. If you rupture posterior capsule, posterior segment problems get worsened. That's why we don't want any posterior capsule rupture in a diabetic patient. And that's why we don't like them to be given for the trainees. But we can't avoid now, because everyone is having diabetes. So this is just to explain for academic students. Normal retina you can see. Diabetic retinopathy, at early stages you can have some microaneurysm only. Even this will help for you. Sometimes we diagnose diabetes by seeing fundus, because that is should not be the way. Normal people should check their sugar every year. Even children. This won't happen in our country. Other countries, they go for annual examination and annual health checkup. There they check sugar. Then if they are sugar, they go for annual eye examination. Our country, they don't check sugar. Even we advise them to say, they say, no, my father, mother got diabetes when they were old. Now I am still young. They think young people doesn't get diabetes. Now in eye hospital, we do surgery most of the time, 30, 40 diabetic patients for cataract surgery. They are coming for laser. That's very not unusual thing in now. But they don't accept. That's why optometrists can help sometimes, because they are friendly with the patient. They come for glasses. They have a little bit friendship with them than us. So I think this is one point. You can work more and will help to prevent problems occurring, and they can work lifetime. Otherwise, losing vision means not only losing vision, the job and the family future, everything affected. We see day-to-day life. The example I like to stress, there one man came for getting vision, whole vision is completely lost. And when I asked why you are coming alone, wife has died recently. When he was a bus driver, diabetic, lost the vision and can't drive. He is the sole breadwinner in the family, so that he can't work. Wife went to become a maid for a house, daily work. Wife got dengue and wife died. Because wife couldn't go to daily work, no, so wife didn't go in correct time to the hospital, and wife died with 3 children. Now 3 children in a home, whole family is disturbed. Then husband came to we admitted to do something. He had advanced renal failure. He transferred to general hospital. He also died. All 3 children in a home. This is day to day we meet. We have no time to raise them, but the 3 children in a home, because we know that father can't see. The eldest came to the hospital to stay with the father, but eldest child is only 10 years. So this is happening, so you can help in these situations. Other thing is proliferative diabetic retinopathy. You can see new vessels at the disc. These kind of patients also you may detect in refraction. The new vessels are normal vessels are not bleeding. New vessels are friable and fragile. Anytime it can bleed, then you can lose vision due to vitreous hemorrhage. Now patients with advanced diabetic retinopathy with vitreous hemorrhage may need further surgery with vitreoretinal surgeons. Now, if we detect in timely, we can give laser and avoid going for further advanced surgery. Advanced surgery is very costly. Plasmapenia, vitrectomy and things very costly, and waiting list is long. We don't have many retinal surgeons, and government hospitals have limited facilities. Then they are in the waiting list. By the time waiting list, patients are completely blind, inoperable. That is the one reason. In a retinal unit waiting list, this vitreous hemorrhage patients, actually no time for them to go for surgery, they can get blind. And one other thing is, when they get advanced disease, they have renal problems as well. With the renal problems, they can't go for under general anesthesia. So surgery is sometimes impossible. This is another fundus picture, proliferative diabetic retinopathy. This type of cases easy to diagnose, but important is early diagnosis. This is diabetic maculopathy. Those patients come because diabetic maculopathy, people will lose vision early because macula is affected. Proliferative retinopathy, sometimes macula is already spared, then they have good vision. These patients have reduced vision. But I can't understand why some patients with reduced vision also they don't come. They come very advanced maculopathy. So we have to educate people to annual or 2-yearly checkup. Then we can detect. This is another example. And young patients come with suddenly reduced vision. When we examine, sometimes we get minus correction, and but patient had good vision in young age. I have seen several cases in my practice, and to see patients is already diabetic patient doesn't know. Young patient, when I got this patient, because he had recent refraction, another refraction by another surgeon with another glasses. Then I thought, why recently 6 months ago he had glasses, and again coming, and again it comes to correct vision, but you can't change 6 month time different refraction. Then I sent him to get the sugar. It was around 400, and he doesn't know anything. Then we treated him for diabetes. Then his refraction completely changed to normal, plano 6.6. So that kind of changes can happen with high sugar levels, which we should be aware. Those patients need referral to endocrinologist. And change of refraction due to high blood sugar is not uncommon thing presenting in busy practice, we give glasses without thinking. But young patients, we don't bother also to ask whether diabetes. So it's very important keeping in our mind, though it's correcting, we have to think twice. Few take-home messages. Although some elderly patients may improve vision with refraction, they can have very hard cataract. Every patient needs fundoscopy to exclude glaucoma or diabetic retinopathy, even if they improve vision with refraction. Recent fasting blood sugar report is important as refraction can vary with blood sugar levels. Even they don't know, good practice is give the prescription, ask them to check fasting blood sugar next day and see whether your sugar is below 120. Otherwise, we can't ask to come again and show us the report. No, let them check sugar and see whether they are diabetic. And then one point we get their health status to know. Otherwise, other thing is without knowing getting glasses and now spending a lot of money, and after 6 months you detect diabetes means another time you have to change the glasses is costly. No, for the even optometrists it's costly. They are coming and complaining we bought these glasses and no vision and all. So it's trouble for both parties. I feel in my opinion, I don't know others will agree, generally adults need eye examination every 2 years. So that a lot of people in our country think only cataract. They think when they get poor vision to go for cataract surgery, that's all. But there are many more diseases can affect patient's eyes now, so too early checkup might detect something important. Patients with diabetes mellitus needs dilated fundoscopy every year. And in this point, diabetic child can get diabetes. Nowadays, we see a lot of children. Diabetic child need eye checkup after 5 years of diagnosis of diabetes. Or else, if they come to puberty, at puberty we have to start examining every year because they get lot of hormonal changes at puberty. Whatever comes first, that means 5 years of diabetes or puberty comes first, means then you have to start annual checkup after puberty, or else 5 years of diabetes in children. And nowadays, earlier we didn't get pregnant diabetic mothers many, but now we get lot of pregnant mothers having diabetes. Those pregnant mothers need every 3 months eye checkup with dilatation, because in a pregnancy they have a lot of changes of blood pressure and hormonal changes, so they can get diabetic retinopathy. So that reason every 3 months we need to do the fundoscopy. And more than that, after we get a lot of referrals from gyn and obs hospitals, but I have noticed they have seen 3 monthly and no problem, they have gone. After childbirth they don't check their sugar. They don't come to eye surgeon after once child is bigger. When their problems are sorted, when only they are coming. So after delivery also they need annual checkup and careful about diabetes. They think only pregnancy they have some high sugar levels, then they forget about that. Thank you.
Thank you very much, madam. Kindly please remain on the stage. And thank you very much for your informative speech. And I would like to invite Mr. Dasanta Fonseca to deliver the token of appreciation to Madam Consultant Eye Surgeon Manuel Pascual. Thank you, Madam.
Now it's time to award certificates for the students who have successfully completed the courses. Certificate in Dispensing Optics, Certificate in Vision Therapy, Certificate in Audiometry, Certificate in Ophthalmic Assistance, and Diploma in Optometry from Vision Care Academy.
I would like to cordially invite Senior Consultant Eye Surgeon Dr. Upali Mendes to distribute those certificates, and he will be accompanied by our chairman, Mr. Dasanta Fonseca, and head of academy, Mr. Vidya Jayaratna. First, we deliver certificate in dispensing optics. Miss Minel Zenilda Buljans. Miss Sanduni Udeshika Sandarenu Lokusuriya. Miss Dimuti Oshini Kure. Miss W.D. Malki Anushika. Mrs. Malika M. Heva Vitarana. Miss P. A. Lakshika Samudi. Miss R.P.A.D. Yugani Tashmi. Thank you very much, sir. And I would like to invite Mr. Dasanta Fonseca to deliver his special appreciation to Dr. Upali Mendis. Sir. Thank you very much. Thank you very much, sir.
Now, I please to invite our guest of honor, Mr. Udeni Disanayaka, to distribute certificates.
He will be accompanied by Mrs. Kumari Fonseca.
Sorry, sir, Mr. Udeni Vikramasinghe. Certificate in Vision Therapy, Ms. Rashmi Navoda Abesena. Ms. Dinumi Chamatri Madhuvanti. Ms. Roishyani Ashka. Please remain on the stage, sir. Next, the students. Next, the students from the certificate in audiometry will receive the awards. Certificate in audiometry, Ms. Ramakrishnan Sindhuja. Mr. Lakshita Madhushan Pereira. Ms. Sharmila Bandara. Please remain on the stage, sir. Following, the students of certificate in ophthalmic assistant will receive their certificates. Certificate in ophthalmic assistant, Ms. W. Udani Diluka Fernando. Ms. Davina Navaratnam. Mr. K. Rajakaruna. Miss Indunil Anuthara Vitharana, Miss Vatsala Manohari Karunaratna, Miss Gangadhari Yashodhara, Mr. Chatura Madhushan Veerasurya, Mr. Kanishaka Madhushan, Miss Kiribat Godage Kaushalya Rasindri, Mr. J.G. Sandaru Indra Deshit.
Thank you very much, sir, for joining with us to deliver the certificates. Thank you. And now I am honored to invite our chief guest, Dr. Mrs. Manel Pascal, to distribute certificates. She'll be accompanied by our sir, Chairman, Mr. Dasanta Fonseca. Diploma in Optometry, Lateral Entry Program, Miss Niranjala Vijayman. Mr. Samira Ratnavira. Diploma in Optometry, 2-year program, Mr. Dinesh Madhusankar. Miss Chandramohan Tilakshana. Mr. Dilshan Madhuranga. Miss Nipuni Sanchala. Mr. Nuan Priyamanta Pereira. Thank you very much, madam, joining with us. Thank you, sir.
It's time for the optometry oath ceremony. I invite Mrs. Oshadi Pires onto the stage. Also, certificate holders stand in front of the stage to pledge for the optometry oath.
will deliberate optometric oath. With full deliberation, I freely and solemnly pledge that I will practice the art and science of optometry faithfully and conscientiously and to the fullest of my competence. I will uphold and honorably promote by example and action the highest standards, ethics and ideals of the profession of optometry. I will provide professional care for those who seek my services with concern, with compassion, and with due regard for their human rights and dignity. I will place the treatment of those who seek my care above personal gain and strive to see that none shall lack for proper care. I will hold as privileged and inviolable all information entrusted to me in confidence by my patients. I will advise my patients fully and honestly of all which may serve to restore, maintain, or enhance their vision and general health. I will strive continuously to broaden my knowledge and skills so that my patients may benefit from all new and efficacious means to enhance the care of human vision. I will share information cordially and unselfishly with my fellow optometrists and other professionals for the benefit of patients and the advancement of human knowledge and welfare. I will do my utmost to serve my community, my country, and mankind as a citizen as well as an optometrist. I hereby commit myself to be steadfast in the performance of this solemn oath and obligation. Thank you.
Thank you, Mrs. Oshadi and our certificate holders. He graduated with BSc Engineering degree from University of Peradeniya in 1978. He commenced his career in 1979 as a mechanical engineer at Sri Lanka Sugar Corporation, Kanthalai. Afterwards, joined the Sri Lankan Engineering Service in 1980 as a mechanical engineer at Government Factory, Kolennava. Later, joined the Vocational Training Authority of Sri Lanka as the Director Training in 1995. He served as the factory engineer of the government factory Kolennava from 2003 to 2004. Also functioned as the additional secretary at the Ministry of Defense from 2006 to 2010. He was appointed as the secretary to the Ministry of Agrarian Services and Wildlife in 2011. Then retired from government service in 2015, completing 35 years. He functioned as the project director of the Korean Exim Bank funded project for the construction of Colombo Vocational Training Center at Orugotawata. At present, he is the chairman of the Tertiary and Vocational Education Commission. We are honored to invite Mr. Udeni Vikramasinghe to address the gathering.
Good morning, everybody. Dr. Manuel Pascual, Consultant Eye Surgeon, National Eye Hospital. Mr. Dasanta Fonseca, Chairman, Vision Care Group. Professor Madhuwanti Disanayaka, Faculty of Medicine, University of Colombo. Consultant Dr. Upali Mendis, and other distinguished guests, ladies and gentlemen. I would like to thank the management staff of the Vision Care Optical Services Private Limited for inviting me for this function. Vision Care Optical Services Private Limited has been renowned optician provider in our country for the last 30 years with over 60 branches island-wide. There are over 700 employees working in the Vision Care network guided by Mr. Dasanta Fonseca, Chairperson of Vision Care Optical Services Private Limited. Vision Care Academy was established in April 2008 and registered under the Tertiary and Vocational Education Commission (TVEC) in 2011, and Vision Care Academy was recognized as a full-time member of the Association of Schools of Colleges of Optometry ASCO India in 2015. Furthermore, under the registration number 467220, Vision Care is also an affiliate with the World Council of Optometry as a corporate member. Vision Care Academy provides both education and in-house training programs. Mainly, we have three separate faculties as Faculty of Optometry, Faculty of Audiology, and Faculty of General Studies. Optometry, commonly described as primary healthcare professional, is the study of vision and eye. Faculty of Optometry consists of 4 different courses conducted by many lecturers. Vision Care Academy provides the courses in Diploma in Optometry, Certificate for Ophthalmic Assistant, Certificate in Dispensing Optics, Certificate in Vision Therapy. Currently, Vision Care Academy has proudly hosted over 250 alumni who serve as professional optometrists and dispensing opticians in the country. They also serve as active participants of their annual and scientific day session as research and poster participant. After being provided with both education and extensive training period by capable academic staff, today they gather on the Optometry Day to award the certificates to new scholars for completing their education successfully. Under the new theme, Innovative World with Better Focus, Optometry Day and 12th scientific session program has been arranged today. I wish all success in the activities of Vision Care Optical Services Private Limited. Thank you.
Dear sir, kindly please remain on the stage. I would like to invite Mr. Dasanta Fonseca onto the stage to deliver the token of appreciation. Thank you very much, sir. She obtained her MBBS degree from Faculty of Medicine, University of Colombo in 1995 with honors, winning Drogo Austrian Gold Medal for orthopedics. Then joined her alma mater in 1997 as a lecturer in the Department of Anatomy and became a senior lecturer in 2008. She became the head of the department in 2012 and was promoted to the post of professor in 2017. She is the chairperson of the Special Senses module at the Faculty of Medicine, Colombo. Started her career in ophthalmology in 1999 at National Hospital, Colombo, and had further training at Sri Jayawardhanapura General Hospital and the Tennant Institute of Ophthalmology, Glasgow, UK. She was board certified as a specialist in ophthalmology in 2005. An active researcher in anatomy, ophthalmology, and medical education, she was awarded the BMJ South Asia Award for Excellence in Medical Education in Mumbai, India in 2015. She is a graduate of Leadership Development Program of Asia Pacific Academy of Ophthalmology and an awardee of APAO ZOC Travel Grant for Invited Speakers at APAO Congress, China in 2015. She has been an advisor and a visiting lecturer to Vision Care Academy from 2014. She contributed to the field of ophthalmology in Sri Lanka by serving as the president of the College of Ophthalmologists of Sri Lanka in 2017. And currently serve as the co-editor of the college journal. We are honored to invite Professor, Consultant Eye Surgeon, Dr. Madhuwanti Disanayaka to deliver the speech. Madam, over to you.
Thank you for that kind introduction. Good morning. At the outset, I would like to thank the organizing committee for inviting me for this important occasion. So, at this occasion, I would also like to congratulate the Vision Care Academy on this well-organized optometry day they are having for the 12th time in the midst of all the challenges that everybody is facing in the country. Also, we as ophthalmologists and eye care professionals, whatever happens, we have to carry out our day-to-day lives in making the vision of everybody around us better and better. So, with that thought, I would like to take you through another pandemic. Now we are fed up with the present pandemic. Now, the next pandemic would be very important to all of us, that is myopia. What is myopia? As you know, it is also known as short-sightedness. I don't have to tell you in detail, but just the basics. The incident parallel rays will come to a focus in front of the retina with accommodation at rest. And myopia, which is greater than 6 diopters, we call it high myopia, is associated with lots of complications. And we are worried mostly about these complications. So, on one hand, having myopia will make the individual handicapped. That is, the distant vision will not be clear. So, this will affect especially the children, in their educational programs, educational activities, as well as the workforce in attending to their day-to-day work. More than that, if they go into the category of the high myopia, then there are other complications that are associated with it. As you would know, retinal changes, retinal degenerations, retinal tears, retinal detachments, as well as glaucoma and other complications also will make them more problematic. So, why do we call this a pandemic? Uncorrected refractive error is the commonest cause of visual impairment in the world. And globally, myopia is the leading cause of distance refractive error, affecting 1.45 billion or about 27% of the world's population in 2010. In the Southeast Asia region, the prevalence of myopia in all ages was estimated to be about 1/3 or about 33% in the year 2000. And in Sri Lanka also the situation is no different. And the other problem is people are not aware of the condition of myopia and that it needs to be corrected. And also the people who are corrected with several methods, they are not aware of the correct method of compliance. Even we did a study among the medical students in 2020, and in that also we found out that even the members who are going to join the medical profession, even they are not aware of the correct situation in this ocular condition. So some people think that, some students thought that giving spectacles once will be adequate for the next 5 years. So if you think of the medical students that way, then you can think of the general public, what their attitudes and beliefs are. So we need to be proactive and we need to take this message across. So coming into the causation of myopia, going into a little bit into the academic side. When you say that the image is formed in front of the retina, what can cause that? It is either the axial length of the eyeball is too long, or the curvature of the refractive surfaces, the cornea or the lens is too much, or the refractive index is higher. So those conditions will cause the myopia or the image to be focused in front of the retina. Now when patients come to you, they would ask you, when you diagnose by doing a refraction, you diagnose that a certain child is having myopia. Okay, you tell the parents, now this your child is having a condition called short-sightedness or myopia. Now the parents are very anxious. They want to know what is the cause of it. Is it something that the child has not eaten, or is it genetic? Is it because the grandfather has it? So there are so many causes. It's a multifactorial disease. So there are genetic components, ocular components, and environmental components. Initially, when the patient is diagnosed, the parents are very anxious. You are the first person to break this news. So you have to be very understanding and explain the situation to them. The clinical symptoms, the features of this disease, as you would know, poor vision or blurring in the distance. As you know, the focused image is formed in front of the retina. So on the retina it will be a blurred image. And because of this blurred image, patients are trying always to get a very clear image. So all the mechanisms within the eye will be working. So therefore, the patient will get a lot of symptoms due to the tiredness, and we call them asthenopia. So it can be tiredness, it can be pain in the eye, it can be headaches, all that, the difficulty to continue working for a long period. So all these symptoms will occur because of this. Then sometimes patients may find their own ways and means of overcoming this disability. So the patients may have squinting the eyes, that is, they will make the eyes smaller so that the pinhole effect will work, as you know. And then they might half shut the eyes so that the eyelids will cover part of the pupil and they will kind of try to see better. The other thing is they will also have night blindness. When the pupil is dilated, then the peripheral rays will not be forming a image worse than when the pupil is small. So therefore, night blindness will also be a feature. More than that, the signs, what as an examiner we would see in the patient. So some of the signs will be the eyeballs will be larger, so prominent eyeballs, and you would see that the anterior chambers are deeper than normal, and pupils sometimes may be larger and sluggishly reacting. Furthermore, we are more interested in the fundal changes. It may be normal, but sometimes there can be changes, especially with high myopia. So the crescent on the temporal aspect of the retina, what you see there is the temporal myopic crescent. So that will show you a confirmation that it is a myopic fundus, and that we have to be very careful in following up these patients because they may progress further. Classification of myopia is diverse. So there are lots of classifications. You can classify them according to the age of onset. It can be congenital at birth, or it can be childhood or school myopia when they start academic work, or adult myopia. Then according to the progression, it can be slowly progressive or rapidly progressive. So we should be concerned about the rapidly progressive type, because what are the problems? Sometimes the rapidly progressive one may go into the pathological or the more dangerous type, and also if it is associated with other complications such as glaucoma, it can go into a rapidly progressive type of myopia. So we have to identify that and follow up and refer if necessary. Then the magnitude, less than 3 diopters is low, and between it's a conventional classification, 3 to 6 diopters medium, or more than 6 diopters is taken as high myopia. Then the mechanism. So we can have the axial length enlarging, or the curvatural, or it can be the index, the refractive index, or positional, the position of the lens. If it is changed, then it can, if it is more anterior, then it can cause the light rays to converge anteriorly. Also, it can be physiological. As you know, the myopia is different throughout the day. Which part of the day is myopia more? Yeah, at night it is less, right? So that's why the diurnal pattern is there, and that's why the sleep pattern is important. In the eye, it undergoes change. So we have to make sure that the children get enough sleep. And also the induced myopia. So induced myopia, such as in diabetes, when the blood sugar levels go up, it can induce a myopia. And also certain drugs, such as some drugs given to migraine headaches, such as topiramate, can induce a myopia. So you have to ask the drug history also. So it is very important, as Dr. Manuel Pascual said, the presence of or the history of diabetes is very important, and you have to make sure that the patient is diabetic is well controlled before you give the glasses. Otherwise, your glasses will not be the correct ones and the patient will come back to you saying what you gave me is not correct. So that you have been practicing up to now, so continue that. And there can also be accommodative. So when there is accommodative spasm, then it is always forming the image in front of the retina. So that's why some people, when they do close work for a longer period, then they cannot relax. And after doing some close work, it's difficult to relax and patients cannot see far. So you would have had experience like that, patients coming and telling you. So that is accommodative. And it can be associated with other ocular pathologies or not. So the simple myopia will be just only the refractive, the image forming in front of the retina. But if it is associated with other pathologies such as changes in the retina, it may be really dangerous. So you will have to identify. So you will have to check the fundus and you will see that the pathophysiology or the occurring of this is due to the increased axial length of the mainly the vitreous cavity. And then the stretching of the sclera will occur and the choroid cannot actually stretch, so it undergoes degeneration, and also there will be degeneration of retina and degeneration of vitreous. So there will be vitreous opacities, and the retinal degenerations will lead to other complications such as peripheral degenerations, or in the rest of the retina there are retinal tears. I'm sure Dr. Aruna will tell you more about the retinal complications in his speech later. So the retinal, as you can see here, the retinal tear, what you can see here in the picture in the center, is a very grave complication. If it is not immediately treated, it can go into a retinal detachment, and the patient will not get the vision back unless you are vigilant about it. So what are the signs and symptoms that you would get from the patient, the history? In the retinal retinal detachments, suddenly if the retinal tear, if it undergoes, if it crosses a blood vessel, the blood vessel can break and then the blood can leak. So the patient will see floaters. And if the retina is stretched, the patient will get flashes. So any patient coming with floaters and flashes, immediately you have to dilate and see. If you see something, immediately refer. Even if you don't see something, always better to refer the patient to the ophthalmologist, because at this stage it can be treated with laser and the complications can be reduced. Otherwise, if the patient undergoes further complications, the retinal detachment may not be, we may not be able to save the vision of the patient. Okay, right. Then you have heard about the macular degeneration. So what is the commonest cause of macular degeneration? Age, as you know. But what is the second commonest cause of macular degeneration? Yes, it is the myopia. So myopia is the second commonest cause of the macular degeneration. So in this picture, you can see a case of macular degeneration due to myopia. So you have to again see if a patient who is a high myope, having 6/6 vision all the time, and then suddenly you cannot improve the vision to 6/6, right? And then you have to dilate the patient and see under the guidance of an ophthalmologist, or refer the patient for further assessment if the patient is unable to see 6/6 vision with your correction. So so be aware of these complications. And the other thing is glaucoma. So because the sclera is stretching, it is not able to support the optic nerve, and that causes the changes, and the optic nerves start undergoing degeneration, and that causes the pathophysiology of glaucoma in these myopic patients. Next we have the treatment options. The conventional treatment, of course, is the spectacles. Then you also have the contact lenses. All you have been very well taught and discussed, and we are happy about the way you are prescribing, and please see that you continue your good work. Then if the refraction is not able to correct, or if the patient wishes to undergo a further treatment, you can refer the patient to the ophthalmic surgeon, and the treatment option we have now is the LASIK treatment. What is done is, on the surface of the cornea, a flap is separated with the use of laser, and then it is, with the computer assistance, it is curved, it is carved. Okay, so unnecessary bits and pieces will be removed, and according to the parameters given, it will reshape the cornea, and then the flap is put back, repositioned, and the vision is corrected. So patients may come and ask you, is it good to do, or what are the problems? So you have to know what are the problems. So mostly it is accepted practice, and most people are happy. But who are the unhappy patients? There are a set of unhappy patients too. So they may have not the expected refractive outcome. Also they may have the dry eye complications. So they may not be very happy. So you have to advise the patient that this procedure is an accepted one, and this is what you do, but there are complications. So the patient has to get all the details and then give the consent and then undergo this procedure. Then there are other procedures such as intraocular lenses. So we can have two ways. One is removing the patient's lens and putting a lens back into the eye. Then the other method is phakic intraocular lenses, that is, with the patient's lens intact, another lens is put in front of the patient's crystalline lens. So both methods are available, and those are options. So clinical management has been undergoing lot of changes recently. There had been so many experiments, animal experiments, laboratory experiments, clinical experiments, as well as epidemiological studies. So all these have given us these different management options. So in addition to the spectacles and contact lenses, and also we have the pharmacological and environmental changes that we can execute. So you may have heard of the contact lenses, not the contact lenses that we give for general correction of lenses, but as prevention of progression of myopia. So what are they? Bifocal, dual focus ones, and then also orthokeratology, where the patient or the child wears the contact lens at night and then removes it in the morning. So those are some of the newer advances. And then also we have the peripheral myopic defocus lenses. Okay, so they are also reducing the need for the growth of the axial length, because in the development of the eye, when the image is not focused, that is the stimulus for the eye to grow further. So when you remove the stimulus, they try and reduce the need for the growth. So they all have been practiced. And the other thing is pharmacologically using atropine. Atropine eye drops will reduce the accommodative need. So then they will reduce the accommodative mechanism, and then what happens, that will also help the correction of or the progression of myopia. But the problem is all these have been in the experimental stages. first year, second year, they have been getting good results. But the rebound phenomenon is now being studied. So now most of these newer methods, the rebound phenomena are now being studied, and now they are trying to combine different methods such as atropine and orthokeratology. So whatever happens, the jury is still out, but we have one thing. We have the one in the green. So that is the prevention. So you have to address the patient's problem, the blurring of vision. You have to address that first, and then try and prevent the progression with the things that we can do. So what should we tell the patients? We should tell all our patients, especially the children, to increase the outdoor activities. As we know, most of the children during the previous few years, 2 years, they were limited to their rooms with the computers in front, or do the good work and make everybody see better. Thank you for inviting me. All the best to you. Thank you.
Thank you very much, madam. Kindly please remain on the stage. I would like to invite Mr. Dasanta Fonseca to deliver the token of appreciation to Professor, Consultant Eye Surgeon, Madam Madhuwanti Disanayaka. Thank you very much, madam. And we are happily telling you that this program it's a live program, and all participants are engaging with the program. In the meantime, another participants are in upper floors. They are also engaging with us. And now we are going to tea break. And before that, I would like to announce the gifts that we are going to give you today. And we know, so all are in very happy mood to hear this. And best oral presentation senior category will be awarded with 20,000 rupees. And best oral presentation junior, DOP and CDA, and vision therapy and audiology, they are all having 20,000 cash prize. And best research of the year receiving 40,000 cash prize. And best post of the year 15,000 cash prize. And best innovation of the year 40,000 cash prize. And also best research presentation audiology department receiving 20,000, and best poster audiology receiving 15,000. And with that, we are moving to tea break. And the meantime, we kindly tell our live participant to be engaged with the program, since we are telecasting all these posters, and you may go through and see the posters. And we kindly invite you to have and engage with the tea break. And also we kindly invite our upper floor participant also to come for the tea break. And tea will be served in 8th floor. Kindly visit to the 8th floor. We will be returning to the sessions after 15 minutes. Thank you.
කොහෙද යවන්නේ? ඒකෙන්ද
Welcome back. Now we are going to start our scientific session today. Firstly, I would like to introduce our panel of judges. The presentations today will be judged by an esteemed panel of judges. Before we commence the first session, I respectfully invite our judges to take their seats. First, Dr. Pabakara Costa, Senior Registrar, National Eye Hospital. Dr. Dimudu Gunasekara, Registrar at Karapitiya Teaching Hospital. Today, Ms. Ananta Lakshmi, she'll be joining with us online. Ms. Ananta Lakshmi is the Head of Education and Professional Services for Asilo and Luxottica. And now, Dr. Pabakara Costa will be explaining rules and regulation of our scientific session. Sir, over to you.
Very good morning to all the honorable judges, CEO and the other members of the Vision Care team, and all the optometrists and all the participants. First of all, I would like to thank you for organizing and inviting us for this occasion. So I will briefly tell the rules and regulations. So each presentation will be of 10 minutes duration. There will be a signal given at 8 minutes and at the end of the 10 minutes. So we will be mainly assessing in 5 categories. First is depth of the content, and then the organization, and then the presentation style. Other 2 categories are verbal interactions and communication aids. So I wish all the presenters very good luck, and we'll see your presentations. Thank you.
And we would like to tell to everyone, our senior consultant eye surgeon, Dr. Kodikara, today we have a recorded speech today, and Malindu will do the keynote speech now.
He graduated MBBS from University of Peradeniya in 1982 and completed diploma in ophthalmology from University of Colombo in 1990 and MS in ophthalmology in 1996. He completed overseas training at United Kingdom in 1999 and obtained his FRCS. He was a visiting lecturer to the University of Sri Javardhanapura and a trainer and examiner for the ophthalmic trainees at the postgraduate institutes of medicine of the Colombo University. In 2013, he was the president of the College of Ophthalmologists of Sri Lanka and awarded the honorary fellowship of the College of Ophthalmologists in 2019. After 34 years of government sector service, he retired in 2016, presently practicing in the private sector and an advisor to the College of Ophthalmologists of Sri Lanka.
Good morning to all of you. First of all, I would like to thank organizing committee and the academy for giving me this opportunity to share some thoughts. At a stage like in this country nowadays, we are going through a hardship, and that people are thinking about system change. So in relation to that, I thought of discussing the professionalism and the spirituality. Before we talk on the main theme, I would like to draw your attention to some questions like, what is professionalism, what is spirituality, and what are your motives in your life, and what are your attitudes, and who governs you and what governs you. What are your targets in life? Say for example, what is your limit in earning and what is your limit in possessing things, and what is the most important thing for your life? What are you doing for others? What is the meaning of life and what is the purpose of life? Now these are some of the questions. Sometimes you may encounter these questions in your life one day. And before I go further, I would like to introduce what is profession. So how do you define profession? You know, now we are having job or occupations, but what is the difference between profession and occupation? Generally speaking, the fundamental difference between profession and any other occupation is that individual engaged in profession have an ethical obligation to whomever they serve or they do the service. So a profession is required to have code of ethics. It is correct that generally we say professionalism is where you maintain your competency and the skills up to date. There is no question about it that you have to maintain your competency. But if somebody who shows consideration, respect, dutifulness to his or her profession is the professionalism. Now we are in a healthcare field. So in the healthcare fields we have various guidelines, ethical guidelines that is applicable for most of the healthcare personnel in the system. Now you are also in the healthcare field. Now you as optometry, you are in a profession. So this profession also there are ethical guidelines, ethical principles that you have to abide with. So ethical codes contain guiding principles. But my question is, who is going to follow this? It is you, correct. Will you do it? To what extent you do it? What will happen if you do not follow these guidelines? It is up to the individual person to follow those guidelines. So it all depends on the inner man in that individual. Where that inner man stands. Of course we can set guidelines, but how you follow will depend on your inner conscience. That is spiritual in nature. Now we will discuss some basic ethical guidelines and try to link to spirituality. So in Sri Lanka we have general laws. If you break those laws, you will be challenged and then you will be punished in the court of law. Similar way, now you are in an organization. So in an organization, self has various rules and regulations. So the management, if you do something wrong, the management will find faults and sometimes they may warn or they will attend to it. But in guidelines, actually, now in optometry we have guidelines, ethical guidelines. Now in ethical guidelines, they are free. They are free in the sense they are flexible. So you have to follow, but it all depends on the individual person. Now what are the ethical guidelines for you all? We will just discuss little bit in detail. So there are main principal guidelines. These are all applied to the healthcare fields and for optometry. Now the first one is called beneficence. The second one, null maleficence, and then respect for autonomy. The last is justice or fair. Now what is beneficence? Now beneficence means a moral obligation to act for the benefit of others. Now in your case, you are getting a person, maybe a patient, or you can, on the other hand, you can say customer. For that person, you are serving for that person. So you have to always act for the benefit of that person. Now that doesn't mean that you are doing the perfect thing, but according to your heart, you are doing maximum for the person. Think about it. Think about your professional guidelines and do the best. What is non-maleficence? Now non-maleficence means while you are doing the good thing for the person, say for example if you make a mistake or if you inflict harm, now that is non-maleficence. So it is an obligation not to inflict harm on others. So intention to avoid needless harm or injury that can arise through acts of commission or omission. That means adding or omitting something you are doing. So in common sense, it is called negligence. This requires balancing risk and benefits of treatment or whatever you are doing, making decisions on that patient, so that optimize the risk of harm. Now for example, if you make an error, so if there is a small negligence, you can ask forgiveness. But in case of serious negligence, that will be challenged. The third one is respect for autonomy. Now this enable patients to make their own decisions. So as you are serving the person, you have to respect the choices and decisions that a patient makes about his or her own health. So in that case, you have to tell the truth and be informed of their condition, the pros and cons, the options of treatment or whatever you are doing. But the decision made are based on this. So the decision made are based on fact. The last one or the fourth one is called being fair. or the justice. Now that is marked by impartiality and honesty. So free from self-interest. Now if you are the person serving, now you have to be free from self-interest, in the sense selfishness or maybe self-interest or prejudice, right? You can't have predetermined things before you approach, and favoritism. So you can't favor. So you have to treat them equally. Every patient or every person is you have to treat equally. Now, in addition to all these important things, there are some other things that are in the guidelines, like confidentiality. So you can't divulge the things, private things, to others. Now that is specially applied in the medical field, and also protection of vulnerable people like children, women, or maybe elderly, or even sick people. The last one is collegiality, or that is you are having a good relationship with your colleagues. It's important. So you know that, as I told earlier, that unlike laws, regulation, these set of principles are flexible and depend on the individual practitioner. So who will follow these principles? Now remember that you are in the healthcare field, correct, but you are in the business field also. So actually you are sandwiched in between medical and business field. Now that is a problem. Now even in my experience, I know that there is something called commission. Now this commission, I am against commission. If you think about this country, now they say that we are bankrupt. Why we are bankrupt? Think about it, right? Because we have we have a lot of corruption. Not only the top people, top to bottom. You think about yourself, you just analyze and see what you have done in the past. Say, did you bribe anybody anywhere? Yes, commission is a bribe. If you are asking more money by doing some additional things, so it is not good. So if you can actually avoid this or balance it, that will help for the country. Actually we are thinking, we are telling people to be changed, system change, but actually individual person has to be changed first, then only the things will happen. I can give an example. In Singapore, Lee Kuan Yew developed that Singapore, what he did at the first selection, he selected the highest rank in the government, the previous government, and found guilty for corruption and sentenced for life imprisonment. Now that alone helped the country to develop. So now they are free of corruption. Anyway, generally speaking, professionalism is understood as some total of qualities required for efficient delivery of piece of work. Now we will think about the simple meaning of spirituality. Spirituality is understood as the condition of being concerned about the spiritual or unworldly aspect rather than the material or worldly side. Spirituality actually goes beyond the borders of academic disciplines, religions or culture. It is not a religion. So religious and spirituality, there are two things. At this stage, I will give you some valuable advices for your life, free valuable advices. First one is, whatever you do in your life, try and do it to the best of your ability. That doesn't mean that you are perfect, but try and do it, the best thing that you could do. Maybe in your family, maybe in your society, wherever you work, the working place is included in that. Then second one is, do it as you are doing it for your spirituality or belief system as a respect, so that you are focused on something. Third one is, always be prepared to help somebody who is asking help from you. Don't ignore. Maybe a small thing, but help. That is a blessing for you. Is spirituality relevant to professionalism? This is a question I am going to elaborate on that. A sound spiritual faith actually serves as a force for facing the challenges of life. That includes your time of work in your place. Actually, one realizes the time is limited. Say for example, somebody says your time is limited in this world. Tomorrow you are going to die. What do? You will try to do the best you could do. You think like that daily. It helps to keep your mind righteous, pure, and helps to develop divine qualities like faith, love, and forgiveness, which will in turn help to overcome the professional hazard. For example, we know that a lot of people are going through stress during work hours. Now that stress can be minimized, and depression sometimes, or maybe physical illnesses like, for example, hypertension, diabetes, hyperlipidemia, things like that, or stress related other physical problems. So these can be minimized. A strong spiritual belief helps to build a strong mind that acts as catalyst for work and build good relationship with your co-workers. This gives us strength to do our work justly and effectively and also confidently. And of course, you may get job satisfaction. Now I have seen, sometime I ask from people whether you are satisfied with your work. Some people are frustrated, not doing well. So spirituality is motivating power for an individual. It is an energy energy actually. To experience it, you will know it. Spirituality in workplace. Now it can be individual or organization. Now in an organization, if you have spirituality, actually it helps to build good relationship and good culture. Spirituality is not about religion. It could be from any background. Rather, it is recognition of people coming to work with their minds and spirit. So remember, in your case, you have body, mind and spirit. So what we see is the body. The mind is actually intellectual and the volitional part where you take your decisions. But more importantly, it is the spirit. Now spirit matters for spirituality. People neglect that. People don't care. Actually, that is the most important thing. It is connected to the activities involving personal growth, compassion to work with truthfulness. Spirituality in profession enables increasing joy, peace in workplace, enhances the level of mental and physical health. So see how much it works. So think about this. Actually, by doing this, I want to draw your thinking to a different level, and it takes you to a level where you think about meaning, purpose, awareness and value of life. Think about it. Now for example, if a farmer is growing something, say if a farmer grows carrot, he harvests carrot. So similar way, if you sow good things, you will reap good things, but if you sow bad things, you will reap bad things. So you do good to others so that you will be blessed. Thank you.
Thank you very much, sir, for your valuable thoughts. Let's begin the session with Mrs. Oshadi Piris on evaluation of changes in OCT parameters and visual functions in cases of optic neuritis and multiple sclerosis.
Hi, I'm Oshadi Piris from Vision Care Head Office. Today's my topic will be the evaluation of changes in OCT parameters and visual functions in cases of optic neuritis and multiple sclerosis. Introduction. First, we'll see the key words of the study, optic neuritis. Optic neuritis is an inflammation in the optic nerve which causes blurred vision and typically retroorbital pain. Generally, full or partial remission occurs within months on the onset. Approximately 50% of the optic neuritis patients will later develop multiple sclerosis. Multiple sclerosis is a condition that can affect the brain and the spinal cord, causing a wide range of potential symptoms including problems with vision, arm or leg movement and the sensation. MS is an autoimmune condition. This is when something goes wrong with the immune system and it mistakenly attacks a healthy part of the body. In here, MS, the immune system attacks the layer that surrounds and protects the nerves called myelin sheath. This damages and scars the sheath and potentially the underlying nerves, meaning that messages traveling along the nerves become slowed or disrupted. Most experts think a combination of genetic and environmental factors are involved for this. This layer, GCL, this layer composed of the retinal ganglion cells which received information from the photoreceptors via interneurons. Nerve fiber layer consists of the axons of the ganglion neurons causing on the vitreal surface of the retina to the optic disc. ONH perfusion is the blood flow in the optic nerve head. Angioplex. OCTA is a new approach to diagnostic imaging in retinal diseases. This technology uses amplitude and phase aspects of the OCT signal and novel algorithm to enable highly detailed visualization of the retinal macularization. Purpose. The purpose of the study was to evaluate the relationship between visual performance and the OCT parameters in optic neuritis and multiple sclerosis patients with compared to the disease-free age match controls. Justification. No research or study have been done with Sri Lankan sample regarding OCT parameters and visual performance in cases of ON and MS. Methods. A cross-sectional case control study, according to a convenience sampling, a total of 36 patients who were seen at Vision Care during the time period from 2022 Jan to 2022 April. Criteria for eligibility. Inclusion criteria. All the sample I have divided into 3 groups. Group 1, optic neuritis, but had no attack in past 2 months. Group 2, multiple sclerosis patients, but patients were not having optic nerve involvement. And group 3, disease-free age-matched controls who didn't have any history of ocular or neurological disease. And patients were controlled and differentiated based on neurological and ophthalmologist diagnosis. This is my exclusion criteria. Data collection methods. The visual functions included best corrected visual acuity using ETDRS chart, contrast sensitivity measured using Lear contrast chart, stereopsis by Rand dot test, visual field by Humphrey automated perimetry using HVF22 CITA standard protocol. RNFL thickness and the ganglion cell layer ONH portion was measured by using Cirrus 6000 OCT. Data analysis. All the data was recorded and statistically analyzed by SPSS software with ANOVA test. So we'll move to the best part of the study, results. This table shows demographic data of patients. Mean age of the participants were 26.94 plus or minus 12.32 years. Out of 36 patients, 21 patients were female and 15 patients were male. The mean time interval between the acute attack and the conduct of the study was 5.21 plus or minus 2.35 months. This table shows correlation of the visual performance in the sample. Here you can see the results of the study shows the ON group and MS group has significantly worse visual acuity, respectively P less than 0.001 and P equals 0.002. Contrast sensitivity respectively P equals less than 0.001 and P equals 0.002. Stereo acuity respectively P equals 0.001 and P equals less than 0.001. And visual field mean deviation respectively P equals 0.001 and P equals 0.001 than the fellow eye or normal control group. But there is no statistical significant difference in visual acuity. P equals 0.213, contrast sensitivity P equals 0.621, stereo acuity P equals 0.483 and HVF24 mean deviation P equals 0.321 between the optic neuritis and multiple sclerosis group. This table shows correlation in RNFL thickness in the sample. The mean thickness of RNFL average respectively P equals less than 0.001 and P equals 0.002 and the content-wise thickness are significantly thinner in ON group and MS group compared to the normal control group. But no statistically significant difference noticed in average RNFL thickness and content-wise RNFL thickness in ON group from fellow ISO MS group. According to the results, thinnest RNFL thickness noticed in temporal quadrant of the optic neuritis and multiple sclerosis patients. This bar chart shows correlation of RNFL thickness among the samples clearly. This table shows correlation of ganglion cell layer thickness and ONH perfusion among the sample. Result shows average GCL thickness is more thinner in the patients with ON group and MS group. Respectively, P equals 0.001 and P equals 0.002 compared to the normal control group and fellow eyes. The ONH perfusion shows statistically significant reduction in ON group and MS group. P equals 0.001 compared to the normal control group, ON group and fellow eyes. These bar charts shows clearly reduction of average GCL, ONH perfusion of central, inner, outer and full in optic neuritis and multiple sclerosis groups. Discussion. The optic neuritis group has shown poorer vision than either the fellow eye or control indicates that even though visual acuity is expected to recover in cases of optic neuritis, there is a residual loss of vision. There was a significant difference between contrast sensitivity and stereo acuity values of ON and MS and control group. Therefore, contrast sensitivity and stereo could be useful tools for identify and follow up ON and MS cases. The visual field in case of optic neuritis and MS also showed a high mean deviation as compared to the controls. The visual field correlated strongest with RNFL loss in optic neuritis patients and indicative of a post-neuritic sequence, possibly due to the permanent damage to the axon reflected in the thinner RNFL. Earlier, some studies shows that RNFL thickness is more or less in optic neuritis, and some other studies shows as MS RNFL thickness is less. But in my study, there is no significant correlation was noticed. In my study, both in the optic neuritis and MS groups, the maximum thickness was found to be in the temporal quadrant, indicative of application of the papillomacular bundle. MS and optic neuritis produce both retinal structural loss and decreased ONH perfusion. The combination of perfusion and structural measurements enhances the detection of optic nerve damage in MS and optic neuritis. Conclusion: RNFL thickness and GCL thickness was reduced significantly in the ON and MS patients compared to the controls. Lower visual function scores and associated with reduced average overall RNFL and GCL thickness. Contrast sensitivity and stereo acuity are useful tests to identify subclinical optic nerve involvement in MS. OCT angiography may be useful additional retinal marker in evaluation of ON and MS. So these are my references, and thank you.
Thank you for the informative presentation. Can you please tell us again about the RNFL findings? So is it reduced in the compared to the control group? Is that so?
Yes.
In all quadrants or in specific quadrant?
Mainly the temporal side is
mostly.
yeah.
Right. Okay. Thank you.
Thank you.
Thank you, Mrs. Oshadip. And our next presentation is the correlation between ocular pulse amplitude and macular pigment optical density by Ms. Pramodya Satsarani.
Good morning everyone. I am Pramodya Satsarani from Head Office Diagnostic Unit. I am going to present my research study regarding correlation between ocular pulse amplitude and macular pigment optical density. Ocular pulse amplitude is connected with the systolic and diastolic paces of the heartbeat, and it measured the intraocular pressure fluctuation originating from the pulsatile ocular blood flow. And this is an indirect measurement of choroidal perfusion. The contribution of the choroidal perfusion on the total pulsatile ocular blood is the highest and stands at around 85%. And also, it could be influenced by various factors and manifested as an ocular pressure pulse. Macular pigment optical density is a measurement of the density of pigments located in the macula, and it could be various among individuals. The researchers have found that the low MPOG level is a leading risk factor of ARMD. We call it age-related macular degeneration. Macular pigments composed of three types of carotenoid such as lutein, zeaxanthin and mesozeaxanthin, which act as antioxidative agents that will help to protect the retina by reactive oxygen species. Purpose of this study is to determine the correlation between macular pigment optical density and ocular pulse amplitude, and also to identify the risk of development of ARMD in healthy population. Justification: recent findings suggest that the optical density of macular pigment is significantly correlated with degenerative macular disease such as age-related macular degeneration. According to the literature, there were many factors that suggest the causes of ARMD. Still, the exact reason is unknown. To the knowledge of the authors, no studies evaluating the role of macular pigment optical density and ocular pulse amplitude have been carried out so far. Procedure: a prospective cross-sectional study according to convenience sampling carried out Vision Care head office between the time period of 5 months. The study group contains 112 eyes of 56 healthy subjects and the age group was 25 to 35 years. All the participants underwent a complete optometric evaluation including anterior segment and posterior segment evaluation. Those who presented with any type of refractive errors and subject with any ocular or systemic pathologies excluded from the study. Ocular pulse amplitude was measured by using dynamic counter tonometer, we called Pascal tonometer, and the reports with a quality value less than 1 were excluded. MPOD was measured by using Visucam 500 fundus camera by Carl Zeiss Meditech with acquired MPOD mode. To avoid the intra-observer variability, all interventions were done by single examiner. Data analysis. All the data analysis were recorded in a Microsoft Excel sheet and statistical analysis was performed with SPSS software and descriptive statistics were analyzed with Microsoft Excel statistical calculator. And to correlate a variable parameters, the person's statistical analysis was performed. In this image, you can see the method of the measuring of ocular pulse amplitude using dynamic counter tonometer, and ocular pulse amplitude was indicated over here below the IOP. This shows Pascal dynamic counter tonometer report, and this is how the ocular pulse amplitude was indicated in the report, and also it is necessary to check the quality value of the report before you finalize it. This is a diagnostic report of MPOD, we called macular pigment optical density, which is acquired by Visucam 500 fundus camera. The green and blue colors indicate the presence of macular pigments, which is dense at central area. Next, we'll move to the results. Age range of the study group was 25 to 35 and the mean age was 32.4 plus or minus 7.5 and the gender distribution was 1 to 1. This graph indicates the distribution of the MPOD within the study group. X-axis indicate number of eyes, Y indicate MPOD values. The mean MPOD of the study group was 0.144 and maximum value is 0.248 and minimum was 0.04. This graph indicates of distribution of ocular pulse amplitude within the study group. X indicate number of patients and Y-axis indicate ocular pulse amplitude. The mean OPA value was 3.062 and the maximum OPA value of the study group was 6.9 and the minimum was 0.9. This graph shows the distribution of MPOD and OPA. X indicate OPA and Y-axis indicate MPOD of the study group. According to the analysis, there is a positive correlation found between MPOD and OPA are equal to 0.0789 and P is less than 0.05. As you can see here in the graph, when the OPA of the study group increase, the MPOD values also significantly increases. The highest MPOD value of 0.24 was shown in the eye and the highest OPA value in the study group, which was 0.53 mercury millimeters. Conclusion: according to this study, there was a significant correlation between macular pigment optical density and ocular pulse amplitude. It was observed that the lower OPA levels could lead to reading the values of MPOD. Lower MPOD levels were considered to be a significant factor in the development of ARMD. Discussion. According to the study done in 2015, it was observed MPOD correlated with the axial length. They also state that the lower MPOD values could be a risk factor for ARMD. Another longitudinal analysis states that MPOD level significantly correlates with biological aging. Several studies were conducted to find out the systemic and ocular effects on MPOD, and there were several factors were not as risk factor for lower MPOD values. According to the knowledge, this is the first study that evaluate the effect of ocular pulse amplitude in macular pigment optical density in a healthy population. Here, there's a message for you. Clinically, OPA is an additional measurement that will be measured while performing tonometry using dynamic contour tonometer. MPOD tends to drop when the OPA decreases. If you observe a drop in OPA value, it is advisable to measure the MPOD of the patient, since it was prone that the lower MPOD levels could be lead to the development of ARMD in late life. These are my references, and thank you all for your kind attention.
Thank you for very informative presentation. So what does this previous literature studies say, similar studies of this category?
Previous studies says axial length and ocular pulse amplitude, not MPOD and ocular pulse amplitude, sir.
Right, okay, thank you.
Thank you.
Thank you, Ms. Pramodya Satsarni. I kindly remind that the abstract and the poster books can be seen through the YouTube description. So let's go for the next presentation. Manifestation of central serous retinopathy in patients with higher glycemic level secondary to SARS COVID-19 by Mr. Dinesh Madhushankar.
Good morning, all of you. Today my title is Manifestation of Central Serous Retinopathy in Patients with Higher Glycemic Level Secondary to the SARS-CoV-19. Introduction. Central serous retinopathy is a retinal disorder characterized by an idiopathic localized central serous detachment of the macular region, usually unilateral and more in male population, age group in 30 to 50 years. Most of the cases resolve spontaneously and gain normal vision. Glycemia. Glycemia is the presence of glucose in the blood. The normal blood glucose level for adults is 90 to 110 deciliter to milligram. The patient with higher glycemic level in the blood called the higher glycemia. So SARS-CoV-19, the coronavirus is an infectious disease caused by SARS-CoV-2 virus. The main targeted organ of coronavirus is lungs, and it affects more in ACE2 receptors present system in human body, such as cardiovascular, gastrointestinal, kidney and central nervous system. The ocular involvement of coronavirus is also present, and several researches done for that. I picked some researchers for an example. In Yang Liu, in 2019, in Hubei province of China, observed the characteristic of ocular findings of the patients with coronavirus disease. According to them, 1/3 of patients with COVID-19 had developed ocular abnormalities. And Santosh, in 2019 in India, conducted a review of ophthalmic manifestation of central serous retinopathy, and they states that is a direct involvement of COVID-19 in ocular surface and ocular structures. And Puig de Mel in 2020 in Europe, has conduct a research of endocrine system manifestation of COVID-19, and they states that there's a direct involvement of the COVID-19 in endocrine system, especially the pituitary gland. According to them, I set to my objective to find out the correlations between the manifestation of central serous retinopathy in patients with higher glycemic level secondary to the SARS-CoV-19. Justification: the manifestation of central serous retinopathy in higher glycemic level secondary to the SARS-CoV-19 have not been investigated so far in larger cohort. However, several researchers and authors have reported few case studies regarding the effect of SARS-CoV-19 in central serous retinopathy. So, due to the unrecognized role of the disease, the study was set to evaluate manifestation of central serous retinopathy in patients with higher glycemic levels secondary to the SARS-CoV-19. These are my methods and materials. This study was carried out at a primary optometric center at Vision Care. So data was obtained from patients who visited during the time period of 2020 September to 2022 March, and 30 patients were observed, and age group is 20 to 35. The patient who presented with had higher glycemic level before COVID-19 was excluded from this study, and patient who had any systemic and ocular abnormalities before COVID-19 was excluded from this study. And also, if the patient get any kind of COVID-19 vaccine, were excluded from this study. Primary eye examination with anterior and posterior segment evaluation and medical and ocular history was carried out in every patient. The visual acuity measured by standard 4-meter logma chart, and the retinal changes and average macular thickness variation were observed by OCT, macular cube scan, and macular line scan. Higher glycemic level variation were observed by using SBS test result in each and every visit. All the data was recorded in an Excel sheet, and analysis was done with the use of social science statistics software. Gender distribution of this study is 30 objects I observed, and 18% is male and the 20% is female. And the mean deviation of age of this study is 28.1 point plus or minus 0.7. And these are my results. The first graph shows the number of patients versus visual acuity variation. According to the results, the significant improvement of visual acuity with the recovery of SARS-CoV-19 and the treatment of high glycemia and the central serous retinopathy is present, and the p-value is less than 0.001, and the result is significant at p less than 0.05. And this graph shows the number of patients versus glycemic level variation. The result shows that there were significant changes of glycemic level after 3 visits with the treatment of higher glycemia and the recovery of SARS-CoV-19. And result, the p-value is less than 0.001, and the result is significant at p less than 0.05. The graph shows number of patients versus macular thickness variation was outcome following baseline visit, second visit, and third visit. The result shows that there were significant changes present in average macular thickness with the treatment of hyperglycemia, central serous retinopathy, and the recovery of SARS-CoV-19. I get the average macular thickness level because with the average macular thickness, I can found the recovery of central serous retinopathy, and the p-value is less than 0.001, and the result is significant at p less than 0.05. My discussion: The main targeted system of SARS-CoV-19 is respiratory system, and other systems such as cardiovascular, central nervous system, and kidney also affected with SARS-CoV-19. And also several researches done for find out the ocular involvement of SARS-CoV-19 with the changes of hormone level and blood glycemic level. But changes of the retinal layers due to the SARS-CoV-19 and the glycemic level changes is still unrecognized condition. So the future studies may need to clarify the validity of finding of the present study. In my research also I have a limitation because small sample size about 30 subject will be a limitation of this study, and also the study also done in limited location because the total confirmation cases of SARS-CoV-19 in worldwide more than 110 million. My conclusion: according to the findings, there is a possibility in manifestation of central serous retinopathy in patients with higher glycemic level secondary to the SARS-CoV-19, and additionally it was found that there is an increase of glycemic level secondary to the SARS-CoV-19. According to that, there is a possibility of glycemic level changes linked with the SARS-CoV-19, and also the higher glycemia linked with the central serous retinopathy in SARS-CoV-19 positive patients. My take-home message is a person with SARS-CoV-19 positive could be present with changes of glycemic level and the ocular structures, and there could be a ocular disease present secondary to the elevation of glycemic level due to the SARS-CoV-19. These are my references, and thank you for your kind attention.
Thank you for a very interesting presentation. After about how long these ocular manifestations occur after acquiring COVID-19? In roughly in your sample?
More than 3 weeks.
Yes. Okay. Thank you.
In the meantime, I would like to remind.
I also have a question. So you have done this study at Vision Care. You have mentioned the method you have detected the COVID-19 infection. How did you detect the COVID infection? What is the method you have detected? Whether it is PCR or rapid antigen only?
PCR test.
PCR test.
I'm not doing the PCR, but the patient already had
came
a COVID.
with the PCR.
Yes.
During what time period you have done this study?
2020 September to the 2022 March.
Right. Okay, thanks.
And I would like to remind Ms. Anantalashmi from India. She's with us online. Ma'am, whether you have any question to ask from our participants?
I just wanted to check out what was the frequency of these 3 visits, follow-up visits? What is the frequency?
I don't get it, madam.
So you said you had 3 visits with the patients, right? Follow-up visits.
Yes, madam.
So what was the frequency of visits you decided?
I decided that visits I want to evaluate the recovery of central serous retinopathy and also the glycemic level.
Okay. So what was the period? 1 week, 2 week, 3 weeks? So every week visits, or how was it?
I actually 1 month.
Okay. So first month, and then after the recovery of COVID. Okay.
Yes.
Great. Okay.
Thank you.
Thank you, Ms. Anantalashmi.
Thank you, Mr. Dinesh. The next presentation is correlation between the type of cataract and contrast sensitivity by Ms. Chandramohan Tilakshana.
Good morning everyone. I am Tilakshana. Today I am going to do a research about the correlation between the type of cataract and the contrast sensitivity. Introduction. Cataract is the leading cause of reversible blindness and visual impairment globally. Blindness from cataract is more common in developing countries than in developed countries. The only treatment for the cataract is the surgery. Phacoemulsification is the gold standard for the cataract surgery in the developed world. So this is a picture of the normal eye as well as the cataract eye. Then the contrast sensitivity. Contrast sensitivity refers to a measure of how much contrast a person requires to see a target. Contrast sensitivity measurements differ from contrast acuity measurements. Contrast acuity is a measure of spatial resolving ability of the visual system under the conditions of very high contrast. Contrast sensitivity is the measure of a threshold contrast for seeing the target. So there is a reduction of the contrast sensitivity to the patient with the cataract. That the picture of the picture represent the Lia chart that measures the contrast sensitivity. So there are some literature studies that states that pelliropsin chart provides a rapid glare disability which can be incorporated in the clinics with cataract patients. And there is also a study that evaluates the standardized techniques to assess the association between the type of cataract and the contrast sensitivity, and the study states that the pelliropsin chart is a good technique to measure the contrast sensitivity in moderate to advanced cataracts. However, the current study used the Lia contrast sensitivity chart for the measurement of the contrast sensitivity. So the objective of my study is to determine the correlation between the type of cataract and contrast sensitivity in the patient with more than 612 visual acuity. Justification. Few researchers have appeared in the past concerning about the chart to measure the contrast sensitivity accurately to the type of cataract patients. However, there is no any other researchers dealing with the relation between the type of cataract and the contrast sensitivity. The procedure of my study is, it is a prospective cross-sectional study which was conducted in the Vision Care Opticals Private Limited, Colombo 7, Sri Lanka, and the time span is from February 2022 to April 2022. And here in my study, the participants were 30 subjects with different type of cataract, and the age range of the patients were 40 to 75 years. The procedure, the cataract was graded by the prescription from the ophthalmologist. The primary eye examination followed by the Lia chart at 1 meter to measure the contrast sensitivity. The exclusion criteria in my study are the patient with any other ocular pathologies except the cataract, and the patient with the visual acuity less than 612. So the data analysis were recorded in the Microsoft Excel sheet, and ANOVA single factor test was used to analyze the data of this study. The result were, the mean age of the study group was 60.5, and the ratio of male is to female is 5:9 ratio. So this is a graph that indicates the distribution of the number of eyes with the type of cataract. So the x-axis indicates the type of cataract and y-axis indicates the number of eyes with different type of cataract, and the distribution of number of eyes with type of cataract are NS1 is 7.8%, NS2 is 36.8%, NS3 is 26.3%, NS4 is 10.5%, posterior subcapsular cataract is 15.7%, and the cortical cataract is 2.63%. This graph indicates the distribution of mean contrast sensitivity within the subgroups. The x-axis indicates the type of cataract and the y-axis indicates the mean contrast sensitivity. And here the distribution of mean contrast sensitivity in all the type of cataract is 1.25%. Conclusion: according to my statistical analysis, there is no any relation between the type of cataract and contrast sensitivity in patient with more than 612 visual acuity. The limitation in my study is contrast sensitivity was measured by the Lear chart at 1 meter distance. And the suggestion of the future work is to increase the sample size of the study and to include the patients with different type of cataract with a visual acuity less than 612. Discussion: there are several studies which says about the accuracy of the chart that measures the contrast sensitivity. They have used the Pellier-Robson chart, Vistec VCTS 6000 chart in their study. But in my study, I have used the Lear chart to measure the contrast sensitivity. There is also studies that says there is a relationship between the contrast sensitivity and the type of cataract. But according to my study, there is no any relation between the type of cataract as well as the contrast sensitivity with better visual acuity. And the take-home message is the glass sensitivity is a major complaint from the patient with cataract. So according to the study, there is no any relation between the contrast sensitivity and the type of cataract in the patient with 612 visual acuity. There could be no complaint regarding the glass sensitivity as the patient is having the 612 visual acuity. Even though there is no complaint regarding the glass sensitivity, but there could be cataract in the eyes. So we have to give instruction to the patients and give them the correct management. These are my references. Thank you.
Thank you for the interesting presentation. So in patients with above 612 vision, irrespective of the grade of the NS level, they have a similar sort of reduced contrast sensitivity.
Yes, sir.
Yes. Okay.
I also have a question. You mentioned 6/12 visual acuity. Is it unaided visual acuity? Or
it is an aided one after doing the primary eye examination.
And with refractive correction,
yeah,
the best corrected visual acuity of
yes,
6/12.
Yes.
So you had patients with NS5 cataract also with best corrected visual acuity of 6/12.
Yes, sir.
All right. Thank you.
Thank
okay, Ms. Anantalakshmi, whether you have any question?
Oh, it's fine. I think you wanted to ask the same thing. Right. Thank you.
Okay. Thank you very much.
Because I also had the same thing of acuity in NS5. Yeah, correct. Thank you.
Thank you, Ms. Tilakshana. And next, it's a case study by Mrs. Mahesha Nishadi, Effectiveness of Revital Vision in Visual Acuity of Amblyopia and Low Vision Patients.
Good morning all. I am Mahesha Nishadi from Mission Care 505. Down the line somewhere, I suppose you all know something about amblyopia and low vision. With that expectations, we'll move on to my case study, which I am going to be present today. The effectiveness of revital vision in visual acuity of amblyopia and low vision patients. First, we'll move on to the introduction. As we all know, amblyopia, the lazy eye, is a condition which reduces the visual acuity in one or both eye without any pathological reason. And according to the 10th revision of WHO International Statistical Classification of Diseases, an injury's causes of death define a person with low vision who has visual acuity less than 618 to light perception in the better eye after refractive correction and visual field loss less than 10 degrees to the point of fixation. So we'll move on to the previous research, what they said about the treatments of amblyopia. A meta-analysis based on the 29th articles that indicates that the refractive adaptation can improve visual acuity in amblyopic eyes, and it significantly decreased with the old age. According to the research done by the Pediatric Eye Disease Investigator Group, patching is usually an effective second-line treatment for amblyopia. And the pharmacological treatment is an alternative treatment for amblyopia when the visual acuity is not fully improved by the optical correction. According to the research which was done by Dr. Almas, almost 30% of the amblyopia low vision patients showed the improvement in visual acuity with the low vision devices. Now have a look at about the modern treatments of amblyopia. The interest and the technological improvements had been developed in different treatments for amblyopic patients. Currently, there are different ways to improve the visual acuity of the amblyopia and low vision patients using red reading glasses and shutter glasses, other polarized glasses. So vision therapy, vivid vision, and also the revital are mostly in modern treatment for amblyopia. Now we have the topic, the revital therapy. So what is this revital therapy? It's a software program clinically and scientifically proven to improve vision in adult amblyopia, eye diseases, low vision, visual impairment, and also retinal diseases, keratoconus, nystagmus, and more. It's a trains brain to better process blurred images into sharper ones, enabling vision to improve despite the absence of any anatomical improvement or changes during the course of the diseases. And it's a therapy training program in the visual cortex computer software, and it's non-invasive patient-specific treatment designed to improve by the modifying certain primary process of the visual cortex. Here in the software, we are using a GABA patch to stimulate and activate receptive fields in the visual cortex in order to improve visual acuity and contrast sensitivity. In the next slide, I have shown you the picture of a GABA patch. And during the training sessions, a series of visual tasks and repetitive images train the brain and improve the visual processing. We'll see what research says facts about the revital vision. There are around 24 articles regarding revital vision. Here I have mentioned you some of them. According to the research done by Minkali, included the analysis result shows that the GABA patch treatment improves best corrected visual acuity in Stargardt patients. And the study done by Donald reports the efficacy and the safety of neurovision correction technology in a non-invasive perceptual learning computerized program to enhance the uncorrected visual acuity and uncorrected contrast sensitivity functions in individuals with low myopia. And the mean improvement was 2.1 line logma. According to the study done by Lyer, shows the improvement in visual acuity and contrast sensitivity following perceptual learning treatments in persons with congenital nystagmus. I think now we'll have a look at about the objectives of my case study to investigate the effectiveness of revital vision in improvement of visual acuity in patients with amblyopia and low vision. This is the procedure. It's an interventional case study, 2019 December to 2022 June in Vision Care 505. 3 Sri Lankan subjects, low vision and amblyopia, and age 9 and up, best corrected visual acuity between 0.1 logma to 1.0 logma, and all amblyopia types. Age range was 9 to 20 years. Diabetes, diplopia, epilepsy, chronic migraines, pregnancy, and attention disorders were excluded. This is the method of my case study. There were 3 subjects including in this case study. All the subjects underwent through a complete eye examination including orthoptic evaluation and low vision assessment, and the amblyopia and the low vision condition was confirmed. After initial assessment, the patients were recommended for revital home therapy program. First review was proceeded by after sessions to inspect the 10 sessions to inspect the visual acuity, and the next reviews were done after each and every 10 sessions. After improving visual acuity up to the expected level, subjects were discharged from the therapy, and every 6 months they have had a review. So we'll move to the cases. The first case, a 16 years old patient, visual acuity with glasses, right eye 0.3 logma and the left eye was 0 logma. There's no deviation for the distant and also the near, for light with 4 dots and the 70 seconds of arc with random stereo acuity, and the deviation was 2 diopter base in for the distance and also the near. We'll see the improvement of the visual acuity. At the first visit, the refraction was plano, right eye plano minus 350, 180, 0.3 logma, and the left eye was 0 logma. After 70 sessions, she got her improvement plano minus 350, 180 up to 0.02 logma. This is my second case. Actually, she is a patient with low vision nystagmus. 14 years old, visual acuity with glasses, right eye 0.5 logma and left eye 0.52 logma. The alternate exotropia for the distance and also the near. Left eye suppression, there's no stereo acuity, and 16 diopter base in prism diopter deviation she has for the distance and also the near. This is the visual acuity improvement at the first visit. Plano minus 125, 15, 0.5 logma. And the left eye minus 150 with minus 170, 0.5 logma. After 80 revital sessions, she got 0.46 logma improvement in the right eye and 0.48 logma improvement in the left eye. We'll move on to the third case. He's a right eye amblyopia patient with macular scar. Visual acuity, right eye 0.9 logma and the left eye was 0 logma. No deviation for the near, and for the distance initially straight but right exotropia, 4 lights, and the poor responses with random test. There's a 4 diopter base in deviation for the near and also 2 diopter base in deviation for the distance. She's still doing the program, and this is her improvement after 40 sessions. She got her improvement 0.9 logma to 0.88 logma. So this is the result you can see in the bar chart. X-axis shows the number of logma visual acuity, and the y-axis shows the number of sessions. And the blue color line you can see the amblyopia case number 1 improvement, and the red line you can see that the low vision nystagmus patient's improvement, and the green color lines you can see the the macular scar patient's improvement. This is the discussion and the conclusion. According to the case study, revital therapy program improve visual acuity in amblyopia patients and low vision patients. According to my case study, 20% improvement in the case number 1 and 0.04% improvement in case number 2, 0.02 improvement in case number 3. Initially, there were 2.5 line visual acuity improvement according to the previous researchers. Using this therapy program, all the subjects have an individual attention. All the subjects must follow the program continuously and after each and every 10 sessions. This is limitations. Initially there were 10 subjects, but due to the pandemic they were not unable to do therapy well, and some of them were followed therapy continuously. The selection was limited due to the program cost. These are the differences. Thank you for the listening.
Thank you for the interesting presentation. Are they combined with standard occlusion therapy also, or only this?
Only this one.
Right, thank you.
Lakshmi also having a question for you, Nishadi.
Hello.
Yes, ma'am.
Hello.
Yes, ma'am. Hello.
Yeah. So, was this effective for strabismic amblyopia?
Yeah, ma'am, but for the not for the deviation more than 20. All the patients were deviation less than 20.
Sorry, 20.
Yeah, 20. Less than 20 I have taken.
Okay, so, what I mean? So you mean to say it was not effective for deviation? Okay. So in terms of prism diopters, how much do you expect?
I didn't get you, ma'am.
In terms of prism diopters of the spin deviations, how much do you? What was the level of spin deviation you had excluded in this?
Actually,
because you said it was.
Actually, according to researchers, more than 8 prism diopters we can't give the revital therapy program. But for the some patients, there's no need. If they have no any treatment, we have to give this one. So I have practiced 2 patients with 16 diopter base in prism and the 8 diopter base in deviation.
Okay.
But they got improved, not 2.5 line, ma'am. It's like 1 or 2 numbers from the logma chart, not line improvement.
Okay, okay. So maybe if you have high deviation, you may have to treat strabismus and then go into revital, right?
Yeah, but I don't think so for the huge deviations there's any improvement, because in according to my case study there's a small improvement only from the high deviations more than the less deviation patients.
Right. Thank you. Thank you. Good.
Thank you, Nishadi. With that, we are moving to the second session of today. Our second session today is binocular vision and vision therapy. For this session, our keynote speaker is today. He has been graduated his MBBS from Faculty of Medicine, University of Colombo. He completed his postgraduate degree in ophthalmology and obtained fellowship from Royal College of Ophthalmologists, Glasgow, United Kingdom. He is a council member of Association of Vitrio Specialists of Sri Lanka. Currently, he is working as a consultant vitreoretinal surgeon and head of the ophthalmology unit and a senior lecturer in Kothalawala Defence University. We are honored to invite consultant eye surgeon Dr. Aruna Fernando. Sir, over to you to deliver your keynote speech.
Good morning. Thank you for inviting me. Thank you to the organizing committee, particularly Vidya and Geeta has been behind me asking for this. I thought I'll address something clinically important and with a significant magnitude, which affects all of us in the coming years as well, with the aging population that we are having. So diabetes and the problem of diabetes in ophthalmology. So I'm going to be talking about diabetic retinopathy and how we basically manage it at the moment. So how bad is this problem worldwide? So the International Diabetic Federation has estimated that almost 10.5% of the whole population in the age group of 20 and 80 is going to be having diabetes. So you can imagine the magnitude of this problem. So that means 1 out of 10 people are currently having diabetes, and this problem is going to gradually increase in the coming years, and they have estimated that this is going to be the fastest global emergency that we are going to face in the medical world. Out of this, majority of the patients are type 2 diabetic patients. You know that diabetes has type 1 and type 2. Type 1 are the early onset diabetic patients, very young patients present with diabetes, and they are more insulin dependent. But the majority are type 2 diabetic patients who present a little later. So out of this large diabetic population, we can see that the majority, the higher percentages are detected in the African, Southeast Asian and the Western Pacific countries, and 1 out of 5 of all diabetics in the world are found in the Southeast Asian region. So that alone you can imagine how much of a big problem that we are going to be facing with diabetes. In Sri Lanka, the estimations are in the range of parallel to what we see overall in the world. So that's about 10% of our population. So if you look at 10 people walking in the street, one of them will be diabetic. right? You can see that in your families as well. You know how frequent and how common the condition is. So it's in 2021 the estimation was 1.4 million for Sri Lanka. So diabetes is a problem because of its complications. Not sure whether you can see it. Can you see? No. Right. So diabetes is a problem because of its complications. So when doctors manage it, we basically divide this into these vascular complications. When it comes to ophthalmology, the main problem that you have is diabetic retinopathy, and that's because it affects the small vessels of the eye. Diabetic complications are not related to the retina only and the retinal problem. So when you see patients in your practices, make sure that you have a look at these problems as well, right? You need to know that they are commonly having infections. So they can have lid infections called blepharitis. Blepharitis and other lid conditions can end up with more serious infections like preseptal cellulitis or orbital cellulitis. These can be even life-threatening. Then they are more prone to getting corneal ulcers. So as practicing optometrist, you know that you deal with a lot of contact lenses, ocular solutions. These things are there. So when it comes to diabetic patients and contact lenses, be very careful of prescribing and how you handle their cornea. So they can easily end up with corneal abrasions, which can end up with a ulcer. These are very difficult to treat. They are prone to get cataracts, so they will develop age-related cataracts at a younger age, and their cataract pattern is also different. The way the morphology of the cataract is different, so they need surgery early. Then they are more prone to develop various blood vessel problems, like the arteries and the veins can get obstructed. This is in addition to the retinopathy. And they are, you already know probably that they are very commonly having refractive errors which are constantly changing as well with their blood sugar levels. The shape of the lens changes, the refractive index of the lens changes, the corneal refractive index changes, and that affects the refraction of the patient. So diabetic control when you are doing a refraction and prescribing glasses is very important. So diabetic complications other than retinopathy affecting the eye. So don't forget these as well. So when it come back to diabetic retinopathy, so this is the problem now. Earlier I talked about the incidence of diabetes. Now this is the incidence of diabetic retinopathy in diabetic patients. So worldwide, diabetic retinopathy is seen in almost 1/4 of diabetic patients. So that's the significance of the retinopathy problem. And diabetic macular edema is seen in almost 6-7% of patients. Now in Sri Lanka we don't have a lot of data, but from what we have, this is the incidence that we have gathered. This data is quite old, 2014. And that has detected, these are done principally in the western, central and southern provinces, and that had shown that again almost 1/5 of the patients with diabetes are having diabetic retinopathy. Our incidence of maculopathy is a little higher, right? So how do you get diabetic retinopathy? So it's this process, very complex. So it's not a simple pathway where the high blood sugar levels end up with the retinopathy. Lot of issues are involved where the vessels get obstructed, the permeability of the microvasculature is increased, there's neurodegeneration, the nerves get damaged, then there's abnormal blood vessel formation. Finally, all of these contribute to the diabetic retinopathy. So this is what a normal fundus would look like if you take a picture with a fundus camera, or if you dilate the eye and have a look at the eye with a direct ophthalmoscope or with the slit lamp. This is what it will look like. So in retinopathy, you can have principally the macula getting involved, that is the central retina, and then if your central retina is involved, obviously you will understand that your vision will go down and the patient will present to you early. The patient will come to you early because the vision is affected. The problematic condition is when you have peripheral retinopathy. That is where the peripheral retinopathy, the macula may be spared to a certain degree, and the peripheral diabetic retinopathy progresses, which can end up with devastating consequences. So principally, when we manage diabetic patients, we kind of divide them into these two and manage them accordingly. Peripheral retinopathy also can be in an early stage or a bit more risky bleeding stage, where what we call the neovascular stage or the proliferative retinopathy. So these are terminology that eye doctors and other medical doctors use to manage patients. But so you will come across these conditions, these terms, and it may be useful when you know and are familiar with these to understand what stage or how bad their condition is, so that you will also be aware and educate them accordingly that they need treatment. So along classification, this is what we use to manage our patients, but I thought that it's best if we take a couple of patients and show you how these patients principally present. So I'll talk about 4 patients and what has happened to them. Right, so this is patient 1, 68-year-old female, had diabetes for 16 years, principally had no issue. The treating physician has asked the patient to go and see an eye doctor. So that is the routine thing that they do. Diabetic patients usually have to have a eye screening and a renal screening done once a year. So the doctor has correctly sent the patient. You can see that the medical history, patient has good control, blood sugars are okay, lipids, cholesterol, those are all okay. And the patient has gone to the eye doctor and so the eye doctor and the optometrist involved will be testing their vision. Everything else is okay, and we will dilate the patient and have a look. So if you dilate your patients and have a look, you will be able to see that these kind of changes in the retina. You have seen the normal retina. You are familiar with the normal retinal appearance, what the disc look like, what the blood vessels look like. But you can see in this patient, there are bleeding at various points. There are small bleeds at various points, and there are small white patches. So those are like lipids which have leaked out of the blood vessels, called exudates. Right? Other eye also has something similar. There are small dots in various parts. You can see those small dots. Those are called microaneurysms. Those are early stages of diabetic retinopathy. So this is an early diabetic retinopathy presentation. The patient is not affected regarding his vision. Patient is carrying on. So how do we manage this kind of patient? So still the patient is having diabetic retinopathy. That is the message. It's an early stage, but the patient is having retinopathy. So how do we manage these patients? Whatever the condition of the diabetes, whatever the condition of the retinopathy, if you do not address the diabetic control, none of our treatment actually work. None of our treatment will actually work. So all diabetic patients that come to you as well, you have to address these things over and over again. We have to tell these things over and over again. Optimal diabetic control. Avoid the sugars going too low also. Hypoglycemia is sugars going too low. That should also be. So fluctuations in blood sugar is also very bad. Right? Not the high levels or the too low levels. The fluctuations are bad. If they are anemic, particularly females who may be anemic, that needs to be corrected, because the diabetic retinopathy is progressing because the peripheral retina is not getting adequate oxygen. So if you don't correct the anemia, which may be a lack of hemoglobin, then retinopathy will progress. Smoking is obviously not good for blood vessels. And then in this patient, because at the moment we don't need to intervene, we may ask the patient to come back a little early, not wait for 1 year. We'll ask the patient to come back in about 6 months or 9 months to have another checkup. That's what we would do. So that's how this kind of patient will be managed. So our second patient, 59-year-old gent, diabetic, has been a diabetic patient for 11 years. The patient has now he has complaints of vision. He has problems in seeing distance as well as near. His findings, again, blood sugar, he is not a well controlled diabetic. His HbA1c is high. That means his average 3-month average is high. So he is not a well controlled diabetic. His blood pressure, hypertension is not controlled. He is having microalbuminuria. That means he is passing protein in his urine. You have heard of this test, microalbumin in the urine. This is a urine test that is done to check protein. So if he is passing a little bit of protein in the urine, that means he is having kidney problems as well. If you are having renal problems due to diabetes, chances are your retinal or diabetic problems in the eye are also there. His cholesterol is also high, lipids are high. So he is not a well controlled diabetic patient and he is having problems in the eye. So we have a look at his vision. He has impaired vision, distance and near, and we find that he has an early cataract also. So what is his retina going to look like? So the image you can see is not very clear as well. So this would be because of the cataract that he has. The fundus image is not very well focused. It's a little difficult to see. But you can clearly see these white patches which are involved in the macular region, the posterior pole. So the swelling in the posterior pole or the macular region as well as the exudates are causing the vision to go down. Right? Other eye, image is a little better. So he is having less cataract probably in that eye. And you can see that the exudates are very, you can see a large number of exudates, majority involving the central macula and the foveal region. There are lots of hemorrhages as well. So this patient in our classification would be having diabetic macular edema. That means he is having diabetic maculopathy. In addition, he is having a lot of this what we called peripheral retinopathy as well. We call it the non-proliferative stages of retinopathy. So how do we manage this? Again, ideal optimal sugar control is necessary. Without that nothing works. And then we do treatment of various kinds. If you have small areas which is leaking, we would be doing what we call the focal laser treatment, so that the leaking vessels are kind of burnt off. Now I told you the complex nature of the pathophysiology. So we address these processes at various stages. So these are given, these are managed with injections that we give into the eye. So the injections that are given into the intravitreal cavity, principally you have what we call the anti-VEGFs. That means there is this vascular growth factor which causes the edema to increase and the retinopathy to progress. So we give these antibodies into the posterior segment of the eye. You would have heard these patients getting multiple injections called Avastin, Lucentis, Petistra, all these things are Eylea. These are injections that are given to reduce the swelling as well as trying to reduce the progression of the other retinopathy. The inflammation inside the eye is also causing the macular edema to go. So then we give these various steroid injections also given inside into the posterior segment of the eye. These injections are repeatedly given also if the patient is not under control. So that's how you would manage this kind of patient. Okay. Right. Third patient, young fellow. Now this is a type 1 diabetic patient who had it for 6 years. No visual symptoms. Patient has been asked by the physician to go and see the doctor. You can see from the other parameters that his sugar level is very high. He is not a controlled patient. Right? Sugars have been in the 12.1 HbA1c. You check his vision. Vision is perfectly okay. Normal examination. But when you look at the fundus, it doesn't look very healthy, does it? Huh? You can see these are the abnormal blood vessels that have grown all around. So this is what we call this neovascularization of the retina. So these blood vessels in the retina near the disc and in the periphery are the new vessels. You can see that the macular region is reasonably okay, just a few small hemorrhages. His vision is 6669. He is perfectly happy. He is not going to complain about the vision. But this is looking very bad, isn't it? These blood vessels will bleed. It may be tomorrow, it may be the next week, or it may be the next month. But these will bleed inside very soon. His other eye, similar. He is having a little bit of more exudates, but you can see there are blood vessels near the abnormal blood vessels near the disc as well as in the periphery. So this is what we called proliferative diabetic retinopathy. So proliferative diabetic retinopathy patients are in a very advanced stage of diabetic retinopathy. They will bleed inside the eye very soon. But their vision is normal. That's the problem of diabetic retinopathy. Their vision is 6/6. They are not very badly affected, so they just carry on. So these patients, because of the bad stage that they have, will have to undergo treatment. So we usually need to do this, what we call the laser treatment. It's a different laser to the previous laser I talked about. This is called pan-retinal photocoagulation. We do a laser treatment burning the whole retina. This is what it will look like. So if you are looking at patients' funduses or fundus pictures, you will see these kind of things. And you don't need to be alarmed about these. These are healthy scars that have been treated with with laser. So this, hopefully, this will reduce the progression and the bleeding inside the eye. Sometimes it doesn't work. This is the fourth patient, a 67-year-old patient, had diabetes for a long time, severe visual impairment. Now the patient is followed up in a retinal unit. You can see his control is not very good, right? Sugar, pressure, kidney problems, lipids are high. Vision is very bad, 636, counting fingers. This is what his retina is going to look like. Right. So what are the things that you can see here? Quite a lot of problems, isn't it? You can see that the white parts, the white bands that you see at the top and the bottom are the fibrous bands that have formed, which are what we call the fibrovascular bands. They contract, and you can see that the blood vessel which should have been at the top has been pulled down. The blood vessel at the top has been pulled down. So this is a traction. So this is not just proliferative retinopathy, this is a traction. And there is traction on the macula as well. You can see that there is a fold of the retina which has been pulled up. So there is abnormal blood vessels, proliferative blood vessels all over, right? Very advanced stages. The other eye, if I can get it moving. This is a bleeding. There is a bleed that has happened. You remember the previous patient who had abnormal blood vessels. So after a few days, this is what's going to happen. The patient is going to bleed inside the vitreous cavity, and that's going to look like this kind of like a boat appearance. That's blood is just pooled in the vitreous cavity. So this is a vitreous hemorrhage, and eventually the vitreous hemorrhage the blood will get absorbed and the fibrovascular membranes will form and pull the retina up. So that's a tractional detachment. So this patient is having what we call a proliferative retinopathy with what we call tractional retinal detachment. Advanced stages of diabetic retinopathy. So how do we manage this? Again, the same issues. We have to do the laser as much as possible, but this amount of traction and this amount of bleeding will not go away on its own. We have to get the patient into surgery. So these are the patients that will end up with the retinal surgeons. So what we do is we will have to go to the back of the eye, we'll have to take out all these membranes off, we'll have to remove the blood, we will have to do the laser inside the eye, sometimes we have to put oil, gas, various things, and then come out. So no matter how much we intervene, still we will not have patients recovering the full vision. Okay. So if the patients are going into these stages, that means we as healthcare professionals are failing. That is the problem. Patients should not be going into these stages. They should be caught at the earlier stages and treated. If we are going into these stages and if more and more patients are going to the retinal surgeons, that means we are failing somewhere. Okay? Right. So I'm going to finish the talk. I think I skipped overshot about 10 minutes. No? Right? So these are the messages I want you to remember. All diabetic patients need regular screening. You are going to be, the patients that come to you will be a larger number than the patients that come to the doctors. So you have a responsibility whenever a patient comes to you to ask about the status of diabetes. Whether they are coming for a simple refraction or whether they are coming for just reading glasses, always ask about the state of diabetes. Diabetes is so common that you will be surprised to find diabetes in patients who are 20, 25 or even younger, right? So always ask for the status of diabetes, and if they have diabetes, ask them whether they had a retinal screening done, whether they had a screening done. So screening can be done in various ways. It does not need to be an eye surgeon that needs to screen. Sometimes you can have good quality imaging, right? Fundus photographs, if they are good quality and if it can be read by someone qualified, that is usually good enough. Fundus photographs are the way forward. In the Western countries, diabetic screening is done with fundus photographs, and in KDU we have adopted the same. We do not physically see patients. We take images, and they are screened by junior doctors. So we reduce the number of patient visits and time we spend to screen diabetic. So fundus images are good. But be careful, because sometimes if the image quality is not good, then you can't make decisions, and there are artifacts in the images which can mimic various things, so you need to learn about it. Non-proliferative diabetic retinopathy patients, they need more frequent follow-up, right? And if they are going into proliferative stages, they will obviously need urgent referral. And always encourage diabetic patients that you see to make sure that their lifestyles are modified, to make sure the sugars are under control, because the kind of patients that you saw in the latter stages are very difficult to manage, and they lose their vision. Sometimes they are very young patients, right? They lose their livelihood, they lose their license, they lose their jobs, they can't look after their children. So it's a very difficult problem to manage in the future. And because of the large scale of it, 10% of diabetics in the whole population, this is going to be a huge problem. So keep this in the back of your mind when you're looking after patients, right? Thank you.
Very much, sir, and please kindly remain on the stage, sir. And I would like to invite Mr. Dasanta to deliver the token of appreciation. With that, let's start the first presentation of this second session. Chanura Mahindapala, she's going to present about today acute acquired concomitant esotropia from excessive application of near vision during the COVID-19 lockdown. Chanura, over to you.
Good afternoon, everyone. Today my topic is acute acquired concomitant esotropia from excessive application of near vision during the COVID-19 lockdown. Let's see the justification about this study. The new coronavirus continuously spread across the globe. Many countries have instituted a range of the public health measures to slow transmission and ease the burden of healthcare system. Among these measures, school closures are affecting approximately 70% of the world's student population. Although these measures are necessary to deal with the outbreak, there are concerns that they might have negative effects on children's health, including weight gain, sleep disruptions, and psychosocial stress. Moreover, insufficient time spent outdoor and excessive near work might be associated with an increased risk of myopia. This is my objective, to evaluate the effect on excessive near vision during the COVID-19 lockdown period for the acute acquired concomitant esotropia. Let's see the introduction keywords. Acute acquired concomitant esotropia represents a relatively rare distinct subtype of esotropia which occurs in older children, adults, and even the elders. It was reported that acute acquired esotropia made up 0.3% of childhood strabismus, and this is characterized by a sudden onset of concomitant esotropia with diplopia. And the cause of this seems to be related with an inability to maintain balance between the converging and diverging pulses of the eye, particularly in patients with uncorrected myopia or after physical or psychological stress. Recently, this has been associated with excessive application of near vision due to the widespread use of the computers, tablets, and the smartphones. Acute acquired concomitant esotropia, we can divide three subcategories. Patient with unilateral vision loss, we call SWAN type, and next one, mild hyperopia in association with physical or psychological stress, it's Franceschi type, and uncorrected myopia is the Pilchowski type. This is the study methods. All the record describe 50 cases seen from August 2020 to February 2022 at the orthoptic unit, Vision Care Optical Services. And patients who met this criteria were included: concomitant esotropia with acute onset, and the age between 40 to 18 years. And patient experiencing diplopia or visual confusion, and the best corrected visual acuity of not less than 0.1 logma in each eye. Patient with history of eye surgery or those with a reduction of more than 10 prism diopter in their esotropia with a full hypermetropic spectacle correction for 1 month were excluded. And comprehensive medical histories, ophthalmologic and orthoptic examination were performed on all the patients, and deviation size was assessed using the prisms and alternative cover test in the cardinal gazes. And the orthoptic methods were used to evaluate 3 grades of binocular vision, and the neurological examination findings and comprehensive medical histories were taken. These are the clinical findings. All the patients had sudden onset diplopia for the distance and near, and they had no history of recent infection or recent infection for the physical or psychological stress. And all the sample cases reported an intense use of the computers for more than 8 hours per day, and visual acuity was 6.6 by each eye. And stereopsis, average 340 seconds of arc with Frisbee, and the worth lights also 5 lights. Cover test finding was moderate to alternative esotropia with good fixation for the distance and near, and the deviation equal amount for the distance and near. Ocular movement, very important thing. These all the patients they had no significant limitation and no significant overaction, underaction, or significant A or V patterns. Cycloplegic refraction done, but no any significant refractive error. And investigation, MRI, CT scan, and neuroimaging, everything is done, but everything was normal. We suggest first review Presnell prism for the temporary and the vision therapy to relax the accommodation, and second review Botox, and finally muscle surgery. According to the parents and the patient's feedback after the second visit, the squint and cosmetic appearance was improved after reducing the screen time, and diplopia and other symptomatic features significantly improved, and they are limited to screen time only for the homeschooling purpose. Some parents encourage the child to change the devices from the mobile phone to the widespread screen to the school lessons, and all the samples have increased their outdoor time more than 1 hour per day, and prism cover test angle was significantly improved. These are the results. The mean age of the study group was 12.86 plus or minus 3.97. The average screen time was 29.84 plus or minus 3.8. The maximum and the minimum deviation were 45 prism diopter and 16 prism diopter. Then here you can see the number of screen hours first visit and the second visit. Red color shows the after second visit, and the first one shows the first visit. This is the angle of the deviation. There was an average reduction of 8.9 hours in the study group after they get the proper advice and orthoptic management. There was significant change in the angle of the deviation, which was 20.94 plus or minus 0.95. This you can see the difference. They reduce in the screen time, and automatically deviation also get rid. There was a positive correlation found between the screen time and the angle of the deviation, whereas the p-value was less than 0.01 and the results were significant, p-value less than 0.05. Limitation. Initially, there were 80 subjects with this study, including this study, but due to this pandemic situation, I was unable to gather expected data for all the study. All of 80 subjects, only 50 cases were presented to the reviews because the cases are very recent. No follow-up visits to assess the cause of ocular deviation over time are available. This issue is represent the main limitation of the present case series. And main thing, everyone was not undergone surgery who needs to do the surgery or Botox injection. Discussion. All the cases had no history of physical or psychological stress, and all the patients spent 6 to 10 hours per day using computers, tablets, and smartphones to play, assess school lessons, and navigation the social networks. Neurological examination and neuroimaging were unremarkable, and no ophthalmological signs related with neurological involvement were observed. Although the etiology of acute acquired concomitant esotropia is still debated, it has been associated with the sustained near-point demands due to the excessive use of computers, tablets, and the smartphones. And they speculated that excessive smartphone use could lead to accommodation and vergence abnormalities, resulting in dynamic activation of the medial rectus muscle and thus in the development of the manifest esotropia. The ECG deviation improved in all the patients after refraining from smartphone use for 1 month. Prolonged school closure and home confinement during the current COVID-19 lockdown are associated with the important lifestyle behavior changes, including the significant increase in screen time. The excessive application of near vision might have other detrimental consequences, including the development of acute acquired concomitant esotropia. And this is very important point of my study. According to the patient's follow-up, no one improved 100% without muscle surgery or Botox injection. So all the patient underwent Botox for bilateral medial rectus or unilateral medial rectus, units 5, 7.5 or 10 units, or bimedial medial rectal recession 5 millimeter. There were no significant deviation and diplopia in post-op surgery. These are the conclusion of this study. Reducing the number of total hours of screen time and the number of consecutive hours without visual break should be recommended to prevent acute acquired concomitant esotropia. And also use of wide screen images display within high definition might be extend the distance of vision and prevent the onset of acute acquired concomitant esotropia. These are the references of this study. Thank you for listening.
Thank you for the interesting presentation. Is there any significant refractive component there? As you said, it's sort of a etiology is not really, we are not really sure.
Yes.
In your sample, is there any sort of refractive error like accommodative component is there?
Yeah, I excluded high refractive errors, sir. I get the normal sudden onset, complaint of sudden onset. They had no any significant refractive errors.
So any neurological?
Yes, yes.
Yeah, that's a very good study. You mentioned that in all the study cases, you needed to refer them for surgical management
correction
eventually.
Botox,
So they had residual esophageal after refraining of screens and all that. So for how long have you observed these patients with these non-surgical interventions until you decide whether to refer for surgery?
Yes, yes. Normally we have first review taken 1 month's time. Then after that we are doing a vision therapy exercises or Fresnel prism. Then after 2 months or 3 months time we are suggest this Botox or surgical correction.
Right. Thank you.
Thank you, sir.
Okay, Ms. Anantalakshmi, whether you have any questions?
Yeah, I have one basic clarification. So you said there was an acquired concomitant esotropia during lockdown or during the COVID thing. So my first question to you, or rather the clarification to you is, were all these patients fresh patients, or were there patients whom you have already seen? It was normal, and when you had seen them now, they had this COVID.
Sorry, ma'am, I didn't get
Where
your
all the patients whom you selected for the study were people whom you are seeing for the first time, or
first time patients,
old patients?
No, first time patient, fresh patients.
Okay. Why I'm asking you this is in terms of you said acquired, right?
Yeah,
so
yeah.
My main clarification was, did you have any baseline? Because they could be a latent thing, which could have got manifested because of new work. So that was my major this thing, because
yes,
if it is a first time customer or patients whom you're seeing, do you have a baseline? Do you have the reference of the earlier visits or anything like that?
No,
to
ma'am.
take ensure, to say that they had acquired now basically because of new work.
Yeah, sometimes they had latent squint earlier. At the
Yes,
moment, they
that's
can
right.
be manifest due to the excessive near vision. Yeah,
Yes,
I know.
yes. So that is exactly what I wanted to make it very clear, because there was a surge of all these binocular disorders post-COVID. So all these things got aggravated because of the use of near work to a greater extent. So that's why I wanted to ensure that because your topic says acquired concomitant esotropia, so that's what I wanted to check out, because it could have been latent and then could have manifested because of the near work.
Yeah, it can
right.
be.
So I got my point. Thank you.
Yeah, thank you, ma'am.
Thank you very much, Chanura. The next presentation is Effectiveness of Imaginary VT Among Convergence Insufficiency Patients by Dinumi Chamatri. Dinumi, it's over to you.
Good afternoon, everyone. I'm Dinami Chamatri from Vision Care Kids Unit. Today's my topic is effectiveness of imaginary VT among patients with low range of versions, fusion and accommodation. Introduction. Vision therapy is progressive program that aims to improve person's visual abilities. The main treatment for low range of versions, fusion and accommodation is vision therapy. Vision therapy uses various therapy techniques to train the connection between the eyes and the brain, as more than 50% of brain dedicated to visual function. Imaginary vision therapy is one of effective and attractive technique in these various kind of therapy techniques. The goal of this study is clinically analyze the effectiveness of imaginary vision therapy techniques for the patients of low range of versions, fusion and accommodation. Vision therapy, a progressive program of vision therapy procedures performed under doctor supervision, individualized to fit the visual needs of each patient, generally conducted in office. Home therapy is also included. Ocular asthenopia. Most patients of low fusion versions and accommodation getting ocular asthenopia. It is the more commonly known as eye strain or ocular fatigue. It's common condition that occurs when your eyes become tired from intense use. Symptoms of the asthenopia: pain around eyes, headache, blurred vision, dry or watery eyes. Methodology. The present work is case study. The informations are obtained by comparing the orthoptic assessment reports before and after vision therapy. The patients were selected from Orthoptic Unit, Vision Care 505. 2 samples of patients were selected and divided into 2 groups. Control group was given only the normal vision therapy, and for the other group, during normal vision therapy, specially given imaginary vision therapy. 24 sessions done for each patient. This is the summary of my methodology. Assess patients, set the goals, start vision therapy, orthoptic review, and last one is the improvements. Procedure. Design case study. Study area, Vision Care 505 unit. Time period 2 months. Sample size 20 studies. Inclusion criteria, patients with low range of versions and accommodation facility. Exclusion criteria, manifest strabismus and physiological anomalies. Vision therapy procedures. Monocular skills enhancement, anti-suppression, biocular motility and biocular accommodation, fusion range enhancement and biocular mobility and accommodation, accommodation convergence flexibility. First one is monocular skills enhancement. We can do lenses, sequential minus, near far hard chart, Michigan letter tracking, accommodative rock games and alternate rock. Figure 2 perform hard chart saccadic. Figure 3 Michigan letter tracking. Figure 4 shows near far hard chart for accommodation facility. Figure 5 accommodative flippers. Anti-suppression, biocular motility and biocular accommodation. We can do TV trainer, VO stars, base in and base out, gyroscopic tracing, split prisms techniques, split vectograms, Brock string with red-green glasses. Figure 6 shows red-green hard chart with red-green glasses.
Figure 7, mental minus. Fusion, range enhancement and binocular motility and accommodation. We can do vectogram sequence, Brock string, aperture rule and rotoscope. Figure 8 shows Brock string exercise, and the figure 9 shows single aperture rule for convergence therapy. Accommodation, convergence, flexibility. Live server cards, tranaglyphs, vectograms with flippers, eccentric circus, Brock string we can do for exercises. Figure 11 shows aperture rule with flippers, and figure 12 shows vectogram with tranaglyphs. What is imaginary vision therapy? Imaginary vision therapy is ability to use your mind's eye to create vivid image in your brain. Here we consider how to involve visualization technique to expand brain's ability to control and coordinate the way both eyes work together. Does not need any physical instruments. Imaginary VT procedure. First, the patient is taken to the calm environment. The patient is told to follow easy posture. Provides imaginary instruction toddlers to patient's age. Gradually increase the difficultiness of instructions. Do not require any instrument. Observations of my observations before therapy: convergence, fusion, accommodation facility and vergence facility. These are results of my study. Here we can see p-values are less than 0.005. So p-values are significant. It means improvements are significant. If we consider the p-values after normal VT versus normal VT with imaginary VT, we can see p-values are significant, less than 0.005. So we can see the improvements are significant. Comparison. Here we can see the comparison between normal VT and normal VT with imaginary VT. The red color bar shows the improvement after normal VT with imaginary VT. Blue color bar shows the improvement after normal VT. According to this, fast improvements can see after normal VT with imaginary VT. Conclusion. Imaginary VT can use for any age. The p-values indicate the imaginary VT with normal VT is significantly better than normal vision therapy. We can get fast improvements by adding imaginary VT technique to the normal VT procedures for patients of low range of vergence, fusion and accommodation. These are my references, and thank you.
Thank you for interesting presentation.
Is there any questions from Ms. Anantalakshmi? Okay, madam, thank you. So let's move to the next presentation. Efficacy of amblyopia therapy initiated after 9 years of age with active vision therapy by Ravindi Yakupitiya. Ravindi, over to you.
Good afternoon, everybody. I'm Ravindi Yakupitiya from Vision Care 505. My topic is efficacy of amblyopia therapy initiated after 9 years of age with active vision therapy. What is amblyopia? Amblyopia is also called lazy eye, is a disorder of sight in which the brain fails to process input from one eye and over time favors the other eye. It results in decreased vision in an eye that otherwise typically appears normal. What is vision therapy? Vision therapy is the art and science of developing visual abilities to achieve optimal visual performance and comfort. During vision therapy, patients gain greater understanding and control over their visual abilities and then develop the capacity of efficiently apply these abilities to relevant tasks and activities. Let's see. I have taken 2 types of amblyopia for my research. So the first one is strabismic amblyopia. Strabismus is the most common cause of amblyopia. To avoid double vision by poorly aligned eyes, the brain ignores the visual input from the misaligned eye, leading to amblyopia in that eye. This type of amblyopia is called strabismic amblyopia. So the second one is anisometropic amblyopia. Anisometropic amblyopia is a second cause of amblyopia. Anisometropic amblyopia occurs when unequal focus between the 2 eyes causes chronic blur on one retina. Anisometropic amblyopia can occur relatively small amounts of asymmetric hyperopia or astigmatism. What is binocular vision? Binocular vision may be defined as a state of simultaneous vision with 2 seeing eyes that occurs when an individual fixes his visual attention on an object of regard. So my topic is efficacy of amblyopia therapy initiated after 9 years of 9 years. So basically after 9 years, usually we do binocular therapy more than monocular therapy. So binocular therapy is amblyopia involves in any treatment whereby both eyes are being used, but the amblyopic eye is primary eye performing the given visual task. So my objective is to evaluate the efficacy of amblyopia therapy in patients over the age of 9 years. Here are my procedures. Design of the procedure was descriptive cross-sectional study according to the convenient sampling. My study area was Vision Care 505 unit. My time period was 1 year, 6 months. My sample size was 50 studies. The age group was 9 years to 35 years. My inclusion criteria was visual acuity less than 624 between the age of 9 years to 35 years, diagnosed with strabismico-anisometropic amblyopia, and my exclusion criteria was case diagnosed with strabismico-anisometropic amblyopia without any pathological issues. So management of amblyopia through active binocular therapy. What is active vision therapy? Active vision therapy is designed to improve visual performance by the patient's conscious involvement in a sequence of specific controlled visual tasks that provide feedback. These are the methods I used to do active vision therapy in office. VTS4. VTS4 is a computerized therapy program, and aperture ruler, variable and non-variable tranaglyphs, Burnless scope, anti-suppression therapy with red, green or red, blue glasses, and Marsden ball with visuomotor control bat. These are the instruments. First figure shows the aperture ruler. Second one, Marsden ball with visuomotor control bat. Third one is a Burnless scope. Fourth one is a VTS4 computerized therapy program. And the fifth one is a vectogram. These are the methods I used to do active vision therapy at home. First one is amblyopia iNet. Second one is HTS home therapy. Third one is our latest home therapy program, Revital Vision. And the fourth one, Brockstream. First one shows amblyopia iNet. Second one is the HTS iNet. And the third one is Revital Vision. My methods are 50 studies with strabismic amblyopia and refractive amblyopia were identified with visual acuity less than 624 vision. All 50 patients did minimum 20 sessions before doing the first review. After the first review, the patients was advised to continue the therapy for 3 to 6 months according to the diagnosis by the orthoptist. The refraction is done by the optometrist to get the optimal vision through the glasses before starting vision therapy. Visual acuity was assessed using Snellen's chart at 6 meters. Orthoptic was done at the first visit by the orthoptist. For examples, the orthoptist got the calculations of stereo acuity, accommodation, fusion, and mostly the visual acuity. And my results are: patients with strabismic amblyopia and refractive amblyopia before doing vision therapy, the total mean deviation was 2.276. After doing vision therapy for 6 months, for 50 patients, they did minimum 25 to 35 sessions according to the age and the diagnosis of the first review. The total mean deviation was 0.575. Out of all 50 cases, there were 25 strabismic amblyopia studies. From all 25 strabismic amblyopia patients, 9 of them did both office and home therapy equally. Others did office therapy more than home therapy. Out of 25 studies, 10 of them were improved more than 3 lines. 6 of them were improved 2 lines. Patients who did office therapy and home therapy both equally were improved at least more than 1.5 lines. From strabismic amblyopia cases, more than 50% has been improved. Out of 50 cases, there were 25 anisometropic amblyopia cases. From those 25 cases, 5 patients underwent home therapy, that means full-time home therapy. 20 of them were doing office therapy and home therapy equally. The patients who has done home therapy has improved 2 lines, and the ones who has done office therapy, 9 of them have improved more than 4 lines. Other 11 has been improved at least 2 to 3 lines. So my conclusion is, according to my study, active vision therapy is an effective treatment for amblyopia patients over the age of 9 in improving their visual functions. My take-home message is, through normal treatments, we suggest that active vision therapy should be only done up to 8 years. But this study shows that with proper home and office therapy, we can improve visual functions of the patients over the age of 9. Here are my references. Thank you.
Thank you for the interesting presentation. So what sort of therapy is most beneficial?
I think the more efficient is binocular therapy. More than monocular therapy. You mean home therapy or office therapy?
No, in overall. Yeah.
Overall, yeah. Binocular therapy is more effective.
Right. Yeah. So in this study, you mentioned that before 9, it gives the vision therapy gives a better outcome than after 9. So studies haven't been done for after 9, no? After 9 years.
Yes. Yeah.
Have you compared the outcome between these two categories before 9?
You mean after 9 and before?
Yeah, the improvement. Whether it is okay or equal or less than before 9.
Before 8, before 8 years.
Younger children, yeah.
Yeah. We do more monocular therapy than binocular therapy. So my study was actually binocular therapy. So after 9, binocular therapy is effective than monocular therapy because they'll get double vision because of monocular therapy.
Right, okay.
Ms. Anantalakshmi, whether you have any questions?
Yeah, I just wanted to check out in terms of after 9 anisometropia, anisometric amblyopia, what was the extent of anisometropia you had used in the study? What is the difference between the refractive error? What is the maximum limit of refractive error you had chosen for the study? Say 5 diopters, 3 diopters, 4 diopters. What is the highest limit of this thing? Because all your subjects had vision less than 624, right? So I'm quite interested to know what was the level of anisometropia you chose for the study.
I didn't get you, ma'am. Sorry.
So you said you had you chose subjects with anisometric amblyopia, right?
Yeah.
So it is difference between both the eyes. So I wanted to check. I want to know what was the level of anisometropia you have chosen for the study, the difference between both the eyes. What is the maximum limit? Because you have chosen the subjects less than 624, right? So what is the level of difference between both the eyes you chose? So right eye was -2, the other eye was -8. What was the difference? 6 diopters, 2 diopters. What is the difference between both the eyes? Maximum level. Did you observe that?
I didn't get the question.
No, the difference between the right eye and the left eye power. What was the difference you have chosen? The maximum level of difference between the right eye and the left eye power. You said anisometropic amblyopia, right?
In
so
anisometropic
for that,
amblyopia, maximum
yeah.
difference of refractive error between the
Yes,
eyes.
in terms of refractive error, correct.
Difference between the eyes, the refractive correction.
Why I'm asking you this is because anyway, if you're going to do a binocular therapy and if the refractive error is too high, I was quite
Excuse me, ma'am.
anxious to know how was the result. Because if you had
maximum
chosen a
power is,
very
I
less
think, minus,
anisometropia compared to a very high anisometropic prescription, so I wanted to
minus,
check if did you do that comparison also?
Yeah, minus, actually,
Not the minus, Ravin. It's different between two diopter to
2 diopters is
2.5,
anisometropia.
yes.
So
Yes, ma'am.
how much level you had gone to? Say 3 diopters, 4 diopters. What is the maximum difference you used in the study?
Yeah, maximum 3 diopter, ma'am.
Okay. So 3 diopters and visual acuity less than 624.
Yes.
Okay. Okay. Oh, yeah. So less than 624. Okay. I get it. Okay. So what do you
Normally,
suggest
ma'am, we are
in case
not,
you have higher anisometropia? So the difference is about 5 or 6. You know. So do you think this will work?
Excuse me, normally, ma'am, we are not taking more minus correction in anisometropic amblyopia in vision therapy. Normally, we take the between 2 to 3 diopter. It's that highly effective for the vision therapy.
Okay, right. Thank you.
Right. Thank you very much, Ravindi. The next presentation is Effectiveness of Vision Therapy, Patient with Learning Disabilities in Young Adult by Rashmi Abesena. Rashmi, over to you.
Good afternoon, everyone. I am Rashmi Abesena from Vision Care 505 branch. My topic will be effectiveness of vision therapy in patients with learning disabilities. Let's move to the introduction. Learning disability. Learning disability is a generic term that refers to heterogeneous group of disorders manifested by significant difficulties in acquisition and use of listening, speaking, reading, writing, reasoning, and mathematical abilities. About vision therapy can be defined as a science of achieving clear and comfortable vision. The aim of the vision therapy is to enhance visual skills, eye tracking, focusing, convergence, eye-hand coordination, visual precision, speed, and more. VT is a fully customized and personalized treatment program. VT is more than just simple eye exercise. It's improved brain-eye communication and the effectiveness operating of the child visual system. Vision therapy for learning disability. It is an undiagnosed vision problem that's at the root of the struggles to focus at the distance, maintain concentration, or skip lines while reading. If your child display poor attention in school, don't automatically assume that it's a learning disability. Vision problem in any of the following areas can significantly impact learning. Those are eye tracking skills, eye taming skills, binocular vision, accommodation, visual motor interpretation, visual perception. Any of these can lead a child to struggle to make the sense of the information taken in through his or her eyes. Visual precision issues such as dyslexia can cause your child to experience difficulties when reading, leading them to confuse words and words order. In my study, we are mainly talk about 7 visual perceptual skills. Those are visual discrimination, visual memory, spatial relation, form constancy, sequential memory, figure ground, and also visual closure. Those are the some figures about those visual perceptual skills. Objectives to evaluate the efficacy of the vision therapy patient with learning disabilities. About my procedures, the study includes disruptive cross-sectional study according to convention sampling. Study was carried out Vision Care 505 unit, and also data was obtained from the patient who visited during November 2021 to February 2022, and the sample size was 40 studies, age group 40 to 15 years. My inclusion criteria was patient with manifest learning disabilities and the latent learning disabilities, and my exclusion criteria was cases diagnosed with learning disability coexistent other pathological ways excluded. About my methods, firstly we should do a basic examination by qualified optometrist, then orthoptic assessment by qualified orthoptist, and before doing VT we should evaluate TVPS third edition and DEM test. Then we can perform minimum 20 VT sessions. After doing minimum 20 VT sessions, we can again evaluate TVPS third edition and DEM test. About DEM test, DEM is the developmental eye movement. It is a practical and simple method for assessing and quantifying oculomotor skills in children. This is the reports looks like. About my visual perceptions, about visual perception. Visual perception is the ability to perceive our surroundings through the light that enters our eyes. This picture shows you the example for the visual perception. About the TVPS3 instrument, TVPS means the test of visual perception skills, third edition. It's not a language based one. The test uses black lines with white background and also can be used on children with speech, cognitive, neurological and motor or other impairments. And also this is the TVPS reports look like. About the therapy technique I use those therapy technique. Firstly, Parquet dogs. I use this for visual analysis, eye-hand coordination, motor control improvements. The second one is lap tap, improve timing, rhythm in accuracy and automaticity. Also Michigan tracking for tracking improvements, flashlight walking, fixation and tracking, pegboard rotator for speed and tracking, geoboard for visual integration improvement, and also chalkboard circles for coordination improvements, military turns, directionality rhythm, and also angels in snow improve bilateral integration and body movements. Those are the pictures of some therapy techniques. This is the result. This graph shows you the DEM results. I compare learning disability patient with normal patient. Age is in learning disability patient 12.25 plus or minus 6.28, and normal patient 14.62 plus or minus 12.32. About the gender discrimination, learning disability patient in female 35% and male 65%. This graph shows you the gender distribution of those samples. This is the correlation of DEM test in each sampling group. In a DEM test, we mainly measure DEM ratio, substitute, addition, omission, and transposition. As an example, in learning disability patient, DEM ratio is 2.27 plus or minus 0.71. After doing VT, 1.82 plus or minus 0.87. As you can see, I compare those groups with each other. Their p-value also less than 0.001. It's a significant because as you can see, p-value was less than 0.05. Those are the graph comparison between learning disability patient and after doing VT. And this is the Correlation scale scoring TVPS3 third edition among the samples I get. As I before mentioned, we measure 7 visual perceptual scale. As example, DIS means visual discrimination. Visual discrimination in a learning disability patient 3.83 plus or minus 1.02. After doing VT, 14.23 plus or minus 6.82. P-value also significant, as you can see. These are the graphs shows you the learning disability patient and after doing VT patients. I also compare normal patient and learning disability patient after doing VT. This shows that graph. This is the one of my patients' report, subject scale report before and after doing VT. This is the final index overall score before and after doing VT. About my discussion, vision problem may have negative impact on learning, leading to learning disability diagnosis. Many learning disabilities are caused by vision problems that are undiagnosed and have some eye tracking that works perfectly. Also, we can reduce learning disability with doing VTA. My conclusion was the findings of study vision therapy is given along the occupational therapy has significant effect on the improving visual skills children with learning disabilities, resolving visual problems that interfere with learning, reading and other skills that support this process. My take-home message is early diagnosis and treatment of the children's learning disabilities is a necessary component to school readiness and academic learning. If your child is struggling at school, a learning disability test can help assess your child's specific needs. So these are my references. Thank you very much.
Thank you for the interesting presentation. Just a small clarification regarding your inclusion criteria. So, in patients with learning disabilities, do they have visual problems or only visual normal and other learning disabilities?
They have visual problems.
What sort of vision?
6x different from the patient to patient, 6 to 24, 36, like that.
Ms. Anantalakshmi, whether you have any questions to ask?
No, it's okay.
Okay, thank you very much. The next presentation is done by Roshani Ashka Jayasinghe. She is going to do about effectiveness of vision therapy. Effectiveness of vision therapy to improve binocular functions in patients with intermittent distance exotropia in young adult. Ashka, over to you.
Good afternoon, everybody. I'm Ashka Jayasinghe from Vision Care 505. My topic is Vision Therapy's effectiveness in improving binocular functions in patients with intermittent distance exotropia. Vision therapy. Vision therapy is an effective and recognized treatment modality for correcting and improve ocular motor dysfunctions, vergence anomalies, accommodative convergence problems, and visual perceptual processing deficits. There are 3 efficient visual functions involved. There are eye, brain, and motor outflow system. We can use vision therapy within amblyopia, strabismus, accommodative and vergence disorders, oculomotility dysfunctions, developmental visual information processing disorders, acquired visual information processing disorders, and sports vision. Then we can consider next slide about intermittent distance exotropia. It is a kind of childhood strabismus is increased when a youngster concentrates on distant objects, is fatigued or daydreaming, and may be accompanied by monocular eyelid closure when exposed to intense sunshine. Its natural history of unclear. My objectives are evaluate the efficacy of vision therapy to enhance visual functions such as visual acuity, vergence facility, fusion range, accommodation, convergence, stereoacuity, and strabismus deviation in individuals age 8 to 25 with intermittent distance exotropia. This is my procedure. In my research, I have taken patients in Vision Care 505 Union Place. The time duration was between June to December 2021. I took 20 patients to my research study. Inclusion criteria had visual acuity between 0 logMAR to 1.0 logMAR, age group 8 to 25 years, angle of deviation less than 45 diopter base in, diagnosed as in IDXT, no vertical deviation, no nystagmus, no concomitant deviation, no nerve palsy, no mechanical restriction in the ocular movement. And this is my exclusion criteria. Methodology. Methodology of in this research was take 20 patients were involved in this investigation. All of the patients were evaluated by a single orthoptist and were diagnosed with IDXT. After measuring the patient's visual acuity, convergence, stereoacuity, angle of deviation, fusion vergence, capability and accommodation, vision therapy was suggested for all of them. All patients had 30 consecutive VT treatment from the same visual therapist. Following 30 sessions, participants had an orthoptic examination. These are therapy sequence. First, monocular therapy and biocular therapy, binocular therapy, and finally accommodative vergence flexibility. This is a phase 1 in vision therapy procedures of IDXT therapy. We can firstly do motility and monocular accommodative rock, use FLUS and prism as appropriate. Phase 2, we can do binocular motility and accommodation, anti-suppression work if needed. Phase 3, build fusional ranges at near point with stereo targets and working through PLUS. Binocular accommodative rock with suppression controls. Pointer in straw at close and then move back. Phase 4 is we can do build flat fusion ranges at near point. Stress base in and out, work through PLUS. Phase 5, build fusional ranges at intermediate distance and work toward distance. We can do Brock stereo motivator, start close and move away, pointer in straw near to far, vectogram near to far, long Brock string. Phase 6, we can do accommodative vergence flexibility. This is therapy techniques. We can do Brock string exercise to improve coordination of both eyes and binocular functions, ocular Kruskin and Marsden ball to improve ocular motility, loose minus lens reading and accommodative flippers at near and distance to stimulate to stimulation of eyes, aperture ruler to improve by base out fusion demand, Bernaloscope to improve both accommodative and convergence demand, vectogram to improve vergence demand and stereo acuity, VTS4 machine to improve binocular functions. This is my results. This is a graph. It presents total number of patients of general distribution of sample. This is my result. Some values are significantly improved and some values are not significantly improved. You can see this is a improvements of visual skills. This is my discussion and conclusion. According to the study, vision therapy is an effective treatment for IDXT patients to improve their binocular functions and to improve their strength of eye muscles to reduce angle of deviation. In this research, there is a significant improvement in all binocular functions except visual acuity and angle of deviation. All the patients should follow vision therapy continuously. My take-home message, vision therapy has directly influence in IDXT. Any with IDXT condition are allowed to come and get to benefits. These are my references. Thank you.
Thank you for the interesting presentation. In average, how long it takes to improve these visual parameters? I mean, in average, how long it takes to improve visual acuity and these things after visual therapy?
Visual acuity ranges.
Yeah, visual acuity, stereopsis, how long it takes to improve?
30 sessions, I mean 3 months or 4 months like that. Sometimes get 6 months.
Right, okay.
It's depend on patient.
Ms. Anantalashmi, whether you have any questions?
Yeah, so I just wanted to check. So in terms of exo, they always say that patching improves the exo deviation. So how was this study carried out? Or was there patching done along with the regular vision therapy? What was that? Yeah.
Sorry.
Did the patients undergo patching also during this therapy?
No any occlusions.
Okay, why I'm asking you is because have you tried that? Because patching also improves the exo. Because here you talked about the effectivity or in terms of visual acuity and the deviation. So did we try that out in terms of patching?
Yeah, madam. Patching is effective, but I don't get that method.
Okay. And even the prisms, actually prescribing prisms could be either a Fresnel or a decentering prisms could also have an effect. So even that was not tried here, right?
Yeah, sure.
Okay. Because is it okay to give a combination of this and with the prisms? That's what I wanted to check out. Have you tried that? You've not tried that, right?
Okay, madam. Thank you.
Yeah, may I ask whether have you tried subjective myopic correction for these children also? Subjective myopic correction, have you tried whether there is is this? Yeah.
Okay, no issues.
We don't do occlusion also. We straight away start
No need of subjective myopic correction in that case, no? Minus therapy. Therapy. Okay.
We use the minus lenses and plus lenses to improve the accommodation flexibility.
Right. Thank you.
Thank you, Roshani. The next presentation is Effectiveness of Strobe Training Among Athletes by Ravindu Deshan. Ravindu, it's over to you.
Good afternoon, everyone. My name is Ravindu Deshan. I am from Vision Care Kids Unit. I am here to present to you about my case study of effectiveness of strobe training among athletes. First, we discuss about background of this study. Sport vision is a visual processing in a competitive environment. With sport vision training, athletes is able to increase and enhance their specific visual performance to next level. In this study, discuss what kind of impact strobe glass will have in this sport vision training. Here are the goals. With the sport vision training, our aim is to train athletes' brain, which not only impact their sport performance, but will also positively impact their inner work environment and even in a social environment. Strobe training improves visual performance of athletes in a short of time. Here we discuss about introduction of stroboscopic visual training. Stroboscopic training is a training part using for sports vision. Strobe glass is used for this training. Strobe glass are a state-of-the-art training device designed to strengthen the connection between an athlete's eyes, brain, and the body. This will help athletes to process vision faster and more efficiently. Through the use of liquid crystal technology, the glasses flicker from clear to opaque. This provides a unique edge of athletes to perform at a higher level more consistently with the better decision making. This is the strobe glasses. You can see it's blinking and clearing, and some player catch the ball with the using strobe glasses. And what is the liquid crystal technology? A pattern technology that allows each lens to strobe between clear and opaque, removing visual information, forcing the individual process to visual stimuli more efficiently. As the lens flicker on and off, it's harder to process information, which helps the brain focus visual task. And this is the flicker speed. You can see it has 8 levels, and frequency and clearing time and the opaque time. You can see clearing time 0.1% at the same time, and the opaque time gradually increasing. And this is the vision judging and space-time, some quote from the authors and the journals. And let's discuss about a process of this strobe training. There are 3 steps. Start dynamic drills without the strobe eyewear. Then after we have to perform the dynamic drills with the strobe eyewear with 15 minutes of time. Then after we perform same drills and more speed without strobe eyewear. As the mentioned here, dynamic drills are not specific type of training. They are simply some of training activities used by the coaches in the sports, such as the catching and striking ball, balance and prosperity skills like that. And here's the global settings for eye-hand coordination at the sensory station used to measure the improvement. You can see the settings of the sensory station, and this is the sensory station. And athletes perform eye-hand coordination activity in the sensory station, and the assess players on the sensory station. And the current situation is measured at the sensory station first before starting the strobe training, then again after the strobe training. The measurement allows the athletes to successfully measure reaction time and the accuracy within 1 minute. Once the measurement is completed, certified sport vision coach will analyze the data. Most athletes notice improvement after one 15-minute session. In the success in sports, we have 3 main crucial factors. That is vision, mechanics, and the mindsets. Here are the main purpose of this study. To show that the strobe training eyewear greatly improves reaction time of the athletes in a short of time. These are the methods I use for. First, select the 10 athletes and 10 non-athletes. Then first perform the sport vision zero measurement. That means first assessment of the sports vision. Then I have to perform the reaction, eye-hand coordination exercise with the sensory station. Then after dynamic drills perform 10 minutes of time. Then after we have to perform the using strobe glasses with 15 minutes of time. Again, without strobe glasses, we have to perform the same drills and play sports without the strobe. Then again, we have to perform the eye-hand coordination measurement. Then we can get result in the short time of period. After that, we start the training, 2 months of period. Then 2 months of end of 2 months of period, we have to perform the periodical assessment. That means the last sport vision assessment. Then we get improvements. This is the procedure we use for study design, cross-sectional, non-randomized study. Study location, sport vision, standard vision care. Sample size 20 athletes. Duration 2 months of period. Inclusion criteria athletes who are the part of the professional sporting teams. Each eye visual acuity 6/6. Non-manifest strabismus. My exclusion criteria is previous ocular problems such as strabismus and retinal diseases. And these are the dynamic drills for the strobe training. And you can see the some of kind video for that. This is performing walking rail with the strobe glasses on. It's harder to see. And we have to balance the rail like that. And this is the performance of the sensory station measurement. You can see how it's happened. After that, they give you a score, and we can analyze the data, accuracy, and precision, and like that. And here is the objective results for the sports athletes. My subject 1, professional cricket player, and this is the first measurement of his. And you can see overall accuracy 87% and reaction time 1.55 seconds. And this is the after 15 minutes of training, their results. And overall accuracy improves 90% and reaction time decreases 0.96% seconds. And this is the comparison of the first and last measurement. You can see the improvement of the accuracy up to 3.44%, and the reaction time is 0.59 seconds. And this is the after 2 months of period, first assessment and the last assessment. You can see the improvement within the shade part. And this is my subject 2, high school badminton player. And you can see first measurement and the final measurement and the comparison. Here the accuracy is 91 and 90 at the same time because of accuracy same, and the reaction time also increase. And this is the after 2 months of period. You can see second assessment, periodical assessment is improving. And this is my subject number 3, rugby division 1 hooker player, and the first measurement and last measurement and the improvements you can see in here. And this is the final result, zero measurement and the periodical assessment. This is my subject objective results for sport non-athletes. That means no sport in play, just recreational ones. And my subject number 4, football recreational. And first assessment and the last assessment, and you can see the improvements. This is the subject number 5, swimming recreational. And also they are improving, athlete or non-athlete, both are getting improving for this. And here are the subjective results for the athletes and non-athletes. After 15 minutes of training, they also said their reaction time was higher than before. And now everything seems to be slowing down for them. Mental relaxation, peripheral awareness, quickness, and increased focusing, and like that. This is the before starting the strobe training, their skills shows the bar chart, and the after strobe training. This improves only 15 minutes of time. And here are my conclusion. The players who took part in the above test involved various sports in Sri Lanka. It's clear from above information that all of them have reached a higher level than their visual skills level. Improvement is strobe glasses are limited to that time. Applying for this, the start of the match will increase the overall performance of the athletes. Long-term results can be obtained by training within 2 months. This study shows that after 15 minutes of training using strobe glasses, the reaction time and speed of the athletes increase significantly. I have a take-home message. In order to achieve the goal, The training should be continued for about 2 months and Sport Vision coach 100% responsible for results. Sport Vision is the use in the same technology as professional sporting teams in the USA, such as American football, ice hockey, baseball, and basketball. Any sports or athletes will get benefit from the Sport Vision coaching as well as their physical training. Please visit our Sport Vision Center at Vision Care, Union Place, Colombo 2. These are my references, and thank you for listening.
Thank you for the interesting presentation. It's a new area for us also. So, what sort of, according to the literature, in what sorts of sports this is most beneficial? I mean, which, according to the previous research?
Yes, previous research means I have regarding a lot of things at the liquid crystal technology, okay, and the Sport Vision journals. I get that information for obtaining this.
I mean, actually, what types of sports, like
any type of sport? I mean, not mind games like that. Any type of sport, and anyone can try it.
Ms. Anantalashmi, whether you have any questions?
Yeah, so I was just quite interested to know the impact of performance on this training, because we said that there's a lot of improvements in terms of the reaction time and all those things. So
yes,
overall, for any sports, all these things are key attributes, and if we are going to improve that, did we also go across and check the improvement in their performance? Maybe that can add a lot of value to this
yes,
test, this research,
yes,
or the study. So did we ever go back and check with the participants in terms of the improvement in the field or at the sports? Did we do that?
You mean the participant, madam? I didn't get.
Yeah, the sports athletes and whomever participated in the study.
Yes.
Did they come back and tell you in terms of their performance? Because you said some athletes were also part of the study.
Yes,
so
madam.
Did they come back and tell you in terms of their performance?
Yes, madam. They said to me, and they like to continue the Sport Vision more and more continuously.
Because that would play a very important thing to the study. We do the test, but we also look at their performance, because the actual performance plays a very important role. So
yes, madam, they are very happy for
to understand the performance also. Right, good, very interesting study.
Thank you, miss.
Thank you, Ravindu. And we have reached to the final presentation in our second session. Evaluation of acquired causes for binocular diplopia during the COVID-19 pandemic by Manisha Vitana Vasam. Manisha, it's over to you.
Good afternoon, all of you. I am Manisha. I am going to present my research paper on evaluation of acquired causes for binocular diplopia during the COVID-19 pandemic. Diplopia is simultaneous perception of two images of a single object. It can be divided by binocular and monocular diplopia. When patients see double with both eyes open, known as binocular diplopia. Diplopia may arise from ocular, neurological causes and extraocular muscle disorders. These are the most common causes: head trauma, systemic disease from diabetic mellitus, hypertension, eye disease and etc. Secondary diplopia, the most frequent diagnosis were stroke, multiple sclerosis, brain tumors and cerebral aneurysm. Diplopia is the main symptom for the nerve palsy. Nerve palsies are third nerve palsy, fourth nerve palsy and sixth nerve palsy. That cranial nerves participate in eyeballs movement by extraocular muscle disorder, extraocular muscle control. COVID-19 is a serious global infectious disease in the worldwide. COVID-19 can cause symptoms were similar to fever, such as dry cough, fatigue, aches and pains, nasal congestion and loss of sense of smell or taste. Severe cases can lead to serious respiratory disease and even pneumonia. During the COVID-19 pandemic, a lot of people used to stay in the house or work from home. Due to that, they involve less of physical activities. Objectives. The aim of the study is to evaluate the acquired causes for binocular diplopia during the COVID-19 pandemic. Justification. Coronavirus is a new experience to the world. Lot of people affected from COVID-19 in Sri Lanka. It caused to occur lot of side effect in the human body, and also any type of COVID-19 vaccine gives side effect into the body parts. Hence, this research is to find out the acquired causes for binocular diplopia during the COVID-19 pandemic. Materials and methods. A descriptive cross-sectional study according to the convenience sampling was carried out at Vision Care Optical Service Private Limited 505 Colombo 2 from August 2021 to February 2022. Participation 57 subjects who age ranged from 18 to 55 years. Every patient underwent primary eye examination, including visual acuity, subjective and objective examination, anterior and posterior examination. Comprehensive medical and ocular history recording was carried out in every patient to find out cause for the binocular diplopia. Binocular diplopia was measured with the use of Hess chart and orthoptic assessment. Exclusion criteria: history of diabetic patient, history of hypertension patient, past history of diplopia, strabismus and nerve palsy. Result: this graph is a distribution of binocular diplopia. X-axis is a systemic and ocular condition such as diabetic mellitus, hypertension, after COVID-19, after vaccine, acute acquired concomitant esotropia, unknown and near visual distress. Y-axis indicates the number of patients. Highest number of systemic and ocular condition is diabetic mellitus and hypertension, and lower number of systemic and ocular condition is near visual distress. Percentage of systemic ocular conditions are diabetic mellitus 31.5%, hypertension 21%, after COVID-19 8.7%, after vaccine 14%, acute acquired concomitant esotropia 12.2%, unknown 7%, and near visual distress 5.2%. This graph is a distribution of binocular disorders among the study group. Number of patients of binocular disorders are nerve palsy 30, strabismus 15, neurology 4, and unknown 8. Discussion. Similar case studies were conducted in USA, China, and Russia, etc. This study shows that the same factors such as diabetic mellitus, hypertension are the major cause of binocular diplopia during the COVID-19 pandemic. There is a bidirectional relationship between COVID-19 and diabetes has been mentioned in several researches. The virus that causes COVID-19 binds to angiotensin converting enzyme 2 receptors, which are expressed in key metabolic organs and tissues, including pancreatic beta cells, adipose tissue, the small intestine, and kidneys. Due to that, it is observed that systemic changes such as high glycemic level, high body pressure, and cholesterol have been increased. Lot of people used to stay in houses or work from home. Due to that, they involve less of physical activities such as exercises and walking. And also the dietary habit has been changed, and there were a lot of unhealthy foods intake was reported during the period. That was directly affected to the diabetic. Hence, as per my result, diabetic is directly affected to the highest number of acquired binocular diplopia. Second leading cause was the hypertension for the manifestation of binocular diplopia during the COVID-19 pandemic. It was noted that during the period, the mental stress of the general population has been and could lead to increased body pressure. Conclusion. The study concluded that the several factors such as diabetic mellitus and hypertension are the main factors of the binocular diplopia during the COVID-19 pandemic. Since the lack of facilities of the unit, many of researchers in several countries have been used either minimum number of samples or done this as a case study. But I could be able to find 57 patients as samples in the selected place. Since the lot of people who were used in the investigation will be continued in the future, I will be continue this study furthermore. Take home message. If your patient is presented onset of diabetic mellitus, hypertension during the COVID-19 pandemic, make sure the investigation of binocularity, since there is a possibility of getting double vision in the patient presented with those type of condition. These are my references. Thank you.
Thank you for the interesting presentation. So is there a difference between pre-COVID era causes and during the COVID era causes for diplopia? So now you have done this study during the causes of diplopia during the COVID pandemic.
Yes.
So if we compare that to the pre-COVID era, is there a change of pattern of causes?
I taken the all of patients history taken.
Right. No, I mean if you take the causes, is there a change of pattern when compared the pre-COVID era causes and during the COVID era causes for diplopia? No, I mean sorry. So you have analyzed the causes for diplopia during the COVID pandemic. So is there a change of pattern if we compare it to the pre-COVID era?
I exclude the all diplopia history of patients.
All right. Okay.
And I have to ask that you told that you wish to continue your study further. So the thing I think what I feel is better to observe what the long-term history in these patients. Usually in hypertension and diabetic patients, when they get diplopia due to nerve palsy, the natural history is it is self-limiting. Within 2 to 3 months it will resolve. We have to see in these COVID patients what is happening to their nerve palsy, whether the diplopia similar to these other hypertensive and diabetic patients, it is resolving. I think better to observe this patient for 2 to 3 months and see what's happening to their condition, whether it is self-resolving or getting worsening. Have you, at what time you have done this study?
2020, August.
Then do you have any idea about the long-term process of the natural history of these patients? Yes. What has happened? Was it resolved spontaneously or it was not in the presentation?
COVID-19 has affected the long-term side effect.
Yeah.
But I also think continue my research.
Yeah. So do you have the contacts with those patients?
Yes.
So the patients with hypertension and diabetes, their natural histories, it resolves. So better to look at these patients with COVID-19, what happened to them. Okay.
Okay, Ms. Anantalakshmi, I think you have a question.
I agree. I also second that because follow-up is very important for these cases. So I think if you've said that it has got, you've got it during COVID-19, and it is obvious that we need to follow up and see whether it's resolving automatically, after how much time it resolves. I think I also agree with that.
Thank you.
Okay, thank you, Manisha. Okay, so with that we conclude the second session, and this message is to those who are presenting your posters. And 2:10 we are starting to evaluate. The judge panel will be evaluating your posters. The next room. So please come to the next room. Who are going to do the poster presentation, and lunch break. We have to be here at 2:20. So third session will be starting 2:30. Please come to the room again at right time. So thank you very much, and we'll go to the lunch. Yeah, Marvis. I'm sure.
Optometry Day and 12th annual session. And it's our great pleasure to welcome our dear doctor, ENT consultant, Dr. Sanjeevani Rupasinghe here today. Welcome, ma'am. Okay. Now let's start our third part of the session on community optometry and dispensing. She is a qualified optometrist, graduated from Elite School of Optometry, Chennai, and holds a master degree in optometry. Along with that, she completed her postgraduate degree in human resources too. She has gained varied experiences from working in an eye hospital with an ophthalmologist to eye care corporates, and also over 2.5 decades of experience in eye care sectors in the field of contact lenses and spectacle lenses. Also has trained more than 5,000 eye care practitioners, including ophthalmologists, optometrists, and opticians through various training forums and workshops in topics related to ophthalmic dispensing and contact lenses. She won the Best Professional Services Award from AMERA twice in 2014 and 2015. She has been conducting dispensing courses for Sri Lanka Optometric Association and Vision Care Academy since 2013. Also is a certified ESLA Academy trainer for technical and retail business courses. Currently, she heads the education and professional services for both Essilor and Luxottica, handling India, Sri Lanka, Bangladesh, and Nepal. We are honored to invite Mrs. Ananta Lakshmi to deliver the keynote speech virtually.
Thanks. The screen. I can't share the screen. Excuse me, can you help me to share the screen? I thought one thing which is very relevant today is when we do dispensing, especially these spectacles or contact lenses, but more specifically in terms of spectacle lenses, we look at a lot of things, in terms of the attributes of these spectacle lenses. One important thing which is very vivid when you're dispensing spectacle lenses also, apart from correcting the refractive error, because all the spectacle lenses mostly are prescribed for refractive errors apart from other modalities. So apart from correcting the refractive error and bringing about the quantity of vision, we always believe that the quantity of vision, or rather the quality of vision, is always given by the spectacle lenses. So if you have to bring in that quality of vision, then you need to ensure that the spectacle lenses gives you all the attributes, not only in terms of the refractive error, but also understand. Hello. Hello. Is it audible? Hello. Is it audible?
Yes, ma'am, it's audible.
Yeah. So apart from the regular correction of refractive error, it is also equally important for us to ensure that we also bring in a lot of value in our spectacle lenses. So one important thing which we can look about while dispensing the spectacle lenses is basically looking at the lifestyle of the customer. I think lifestyle of the patient. So whatever we are trying to do is more internally in terms of the refractive error, correcting the pathologies, doing eye examinations. All those things are very good, but I think the next step in dispensing is also to give a relevant solution for their lifestyle problems. So what am I looking at when I mean by lifestyle problems? So today we understand that in fact most of your papers were showing very vividly on the impact of COVID in terms of near vision work, digital devices, and so on, right? So we do understand that even a normal life, when goes in through these lifestyle changes, has an impact. Now, can we give some solutions in the form of spectacle lenses? That is one way of looking at the value we can bring about in a spectacle lens. The other thing is also in terms of how much lifestyle changes are happening and how it is going to impact the comfort and convenience of a customer. So today I thought I will talk about one important topic, light management. We know that light is very, very important for our eyes. Light is life. Light is all about vision. You may have healthy eyes, but if you don't have light, the vision is not complete. So though we understand that light is a very important component for vision, we also need to understand that it is like two sides of a coin. You need light. At the same time, it has to be optimum. It has to come from the right direction, and it has to come from the right intensity. If it is over or inadequate, then it also has an impact on vision. So that is something which is very, very, very vivid in the current lifestyle. So today what we are going to look at is in terms of managing light, and also some of the reasons why we need to manage this going forward. So the first important thing when you're looking up in the light spectrum, or rather the electromagnetic spectrum, is you have a lot of harmful radiations, especially post COVID. I wouldn't say post COVID, I would say at least for the time being, COVID has subsided to an extent. So maybe after 2021, or rather 2021, what is the main expectation of all our patients is basically health. And when you're looking at health, it is just not the overall health. When they come to us, they also want some solutions for eye health. And when you're going to prescribe spectacle lenses for them, it will be a double benefit if you are able to bring that benefit onto the spectacle lenses also. So talking about the two important aspects of health, one is the UV radiation and the other one is the blue light. So we're talking about UV radiations. We know that sun is a major source of UV and blue light, especially in outdoors. The sun has a major impact, and indoors you have both indoors and outdoors, you have both blue light as well as blue light, both indoors and outdoors. So we need to find a solution in our spectacle lenses for these also. So how does these radiations or these light impact the eye? Now, as I told you earlier, light in adequate amounts is very good for the eye. If it is excess, it can create a lot of discomfort in our eye. So just to give you a snapshot, we talk about glare as a very common term. Actually, there are about 4 types of glare. We have the distracting glare, discomfort glare, disabling glare, and the blind glare. So basically, the level 1 would be a distracting glare. The second level would be discomfort. Third one would will create a lot of it's a disabling glare, and the fourth one would be the blinding glare. So anything from the lower level to the higher level, it depends upon the severity of the glare. So while we say distracting glare is basically just giving you a mild discomfort, that's all. It doesn't hamper your vision. Then going to disabling and blinding glare, wherein the level of vision impairment and the contrast sensitivity, all those things becomes a major issue in terms of these glare. So we need to understand and see the lifestyle changes, or rather the environment in which our patient survives, understand their lifestyle, their hobbies, their recreational activities, understand which type of environment does our patient survive in, and see if they are exposed to these type of scenarios. In case they are exposed to these type of scenarios, even though you may give a very good spectacle lenses, maybe you can give a very good spectacle lens, a very good brand of spectacle lens, and say that they will have 6x6 visual acuity, but then the environmental factors would not allow them to have that level of visual acuity. Basic reason is because of the glare in which they are normally existing in, or rather the excess of light which they are prone to. So having said that, how do we actually handle these type of situations? Just a minute. So today, what are we trying to do? Normally, nearly almost all our customers or all our patients, we try to give them a clear lens. No, so the question which we need to ask is clear lens an ideal for every patient who walks in? So are we doing anything more than that? Are we trying to see if they have some challenges in their day-to-day life? So we need to explore when we are actually seeing the patients. So just to answer in short, are clear lenses ideal in any environment? The first answer is in terms of vision. So in terms of vision, a clear lenses may not be very, very ideal. Why? Because we already saw that in case, let me give you an example. Suppose you're traveling in a hot sunny day, and what happens when you're traveling the hot sunny day? There is scorching heat. You are going to squint your eyes, and in case you're not wearing a good sunglass. So let us take for an example a clear lens. So when you're wearing a clear lens and going out in the hot sunny day, the best thing you can do to avoid the heat of the sun is basically to squint your eyes, or rather the intensity of the sun is to squint your eyes. So what exactly happens when you're going to squint your eyes? The level of visual acuity will automatically decrease, because your eyes are not going to be wide open. Okay, so it has an impact on vision. The second important thing is protection. Now, as I told you earlier, protection is something which every wearer would look across, especially after post-COVID. So in terms of protection, they are looking at maximum protection in terms of UV and blue light. And your clear lenses may not be able to give all these things in your spectacle lenses. And the third important thing is comfort and convenience. I'm sure all of you will agree with me that a white lens may not be as comfortable as a tinted lens or a polarized lens, because we understand that a clear lens can allow more light to pass through. At the same time, what will happen is it also impacts on the comfort and convenience of the customer, so of the patient. So what are we trying to do is we understand that when you wear a clear lens and go out, because of glare, you're not going to be very comfortable wearing those lenses, whether it's indoors or outdoors. So we clearly understand that we need to probe a little before suggesting a clear lens or a not so clear lens. So that is what we are going to look about, as to how do we identify whom to prescribe a clear, not a clear lens. Okay. So talking about light and sight, I would say this is the most important thing today. It's a universal need for any patient. So how do we handle both light and sight? So you try to give a light management solution without compromising on the vision of the patient. Let us have a few statistics. Let us go across some few statistics. Now, what does the worldwide statistics say in terms of light sensitivity? What do you mean by light sensitivity? They are not able to do their task in a normal situation, which is actually with a lot of excess of light, so it could be a normal working atmosphere, or it could be a situation when they are traveling. So whatever be the situation, they find that they are not able to adjust to the light in their environment. So talking about light sensitivity, I'm again telling you this is more based on the lifestyle issues. We are not talking about any ocular pathologies, because ocular pathologies and all those things are a very different way to deal with. I'm talking about the lifestyle issues. So in terms of the light sensitivity, what are we arriving at is basically that nearly 90% of our patients experience light sensitivity. So if you really probe a little, you will understand that yes, they do experience. And what do the patients feel is, they feel it is the normal pattern, and they don't ask us a solution for it. And if we don't offer them, they will never know about it. So moving across in terms of the acceptance of these solutions. So when we understand that 90% of our patients are light sensitive, and if we are ready to provide a solution, we find that nearly 80% of our patients would be ready to go for the solution. So that is where we play a very important role. Understand dispensing on the whole. You dispense the spectacle lenses or any other solution, both for I would say both on a refractive reasons, more for a pathological reason, for any other reasons which is more internal, but also understand the external reasons why a patient would be wearing these spectacles, because we need to blend it with the right, I would say, the lifestyle of the customer or the patient. Then only the spectacle becomes fully productive. So talking about the acceptance of these solutions, nearly 80% of the wearers really want to go in for these solutions. So what are they looking at in their spectacle lenses? They would like nearly 90 to 95% of the patients are looking for protection in their spectacle lenses. It could be either against UV, or it could be in blue light indoors and outdoors. So the next important question is, yes, we understand that light sensitivity is very, very important, and most of the people are light sensitive. So how do we assess, because it is all lifestyle. So we have a lot of modes of assessing things more internally, like doing an posterior examination, assessing binocular vision status, assessing the refractive error and all those things. This is something which we are very good at. I think the next level of prescription should be in terms of understanding the customer on the whole. So you need to question, or rather probe a little bit on your patients to understand the lifestyle of their environment. The simple way to assess some of the questions which I have just taken as an example. The first important question which you can ask your patient while you discuss about the various options is basically how comfortable they are when they go out outdoors, whether they possess a sunglass, whether they squint out when they go, and how comfortable they are. So in case they say, they don't have a sunglass and they're already wearing a clear lens, you need to ask them how comfortable they are. Now, unless we don't suggest this solution, they will never ever come to know about the solution which exists. So you need to probe a little bit and ask how comfortable they are with this clear lenses, whether they squint outside even with these clear lenses. And inadvertently, you will find that nearly 90 to 100% of the customers or patients would say that they're not very comfortable when they go out, especially with these clear lenses. So this means that these people are looking for a light management solution. The second important thing is digital devices. So again, a very important observation here is one could be in terms of the eye fatigue, which happens because of more near work. That is point number one. The second thing could also be because of the harmful light which comes, or rather the bright light which comes from these gadgets. So those could also affect the patient's eyes, and they're not very comfortable with the work. So the second way of probing is to ask whether they are finding it difficult to do prolonged work with their digital gadgets. The third important thing is driving. I think that is also a very important thing today. Today, if you actually probe people, when if you ask them, do you drive? Most of them would say, yes, I drive. I like a lot of driving. So you need to ask one more question as to how comfortable they are in terms of driving in the night. Now, why do we think we need to ask this question? Basically, because everybody loves driving, but everybody dread driving in the night. Basically, because of a lot of lights around them, which can lead to glare and all those things. So this is something which can also help you to move across the light management solution. Then you can have the other questions. Whatever I'm trying to give you is basically to give you a idea about how do we understand the light sensitivity of a patient. So the next important question which you can ask is if they have any difficulty adapting from different environments. Either it could be from a dim to a bright environment or a bright to a dim environment. So either ways, if they have a problem in I'm not looking at the pathological conditions. Again, I'm trying to say this. We are looking at healthy eyes. Okay, so you need to ensure that all those pathologies and all those things are being taken off. We are looking at, again, near healthy eyes. So in a healthy eye, if you feel that they are not able to sustain from a bright to a dim environment and a dim to bright environment, it's basically because their eyes are more sensitive to light. So this is again a yardstick for you to start talking about light management solution. Again, I'm just not going to talk about this further, because again, this is again talking about more of lights across them, either indoors or outdoors. So one more important way of adjusting is basically, normally when all of us use digital gadgets, how many of us keep the gadgets in an auto mode? Why do we do that? Basically because or maybe we reduce the intensity of the light screen on the displayed in the light screen. Why? Because we understand the light is the screen is too bright, and there are certain set of people who cannot tolerate bright lights. Okay, so these are some of the people who are looking for light management solution. So I have just discussed certain ways to question your patients when you are actually doing the examination. So you don't have to set a time across for questioning these. You need to do it as a part of your history taking, especially when you find that the patients are not having really great ocular problems. So you need to blend your solution along with the lifestyle solutions. So moving across, what are the solutions we have in terms of light management solutions? We have something called as a light management solutions called transitions, which is again a very smart solution, which is able to manage the light across the day as well as in the night. So I would say it's more of a day and night lens, which is commonly talked about by our patients. So what does this normally do? We call this as a light intelligent lens. Now, why do we want to prescribe this light management lens? Very simple. What exactly happens when you are exposed to bright light? I remember I asked a question of squinting your eye. So what exactly happens is your pupils try to reduce its size and then reduce the intensity of light and flow into your eye, right? So you already have a normal mechanism in your eye, basically your pupil, which controls the intensity of the light. Now what happens when you have to sustain your pupil for a longer time? So suppose you're traveling out in the sun for a longer time and you keep your eyes squinted, or rather the pupil is reduced for a longer time. What would happen when you come back to a normal situation? You end up with a lot of eye strain, eye pain, headache, and so on, because your eyes cannot, or rather your pupil cannot sustain for a longer time, right? So what would happen if the function of your pupil, is actually taken over by your spectacle lenses? And that is exactly what your light intelligent lenses are going to do. They try to understand the light outside and automatically change the intensity of the color according to the light and UV across. So what exactly happens? Your eye behind these lenses would be very normal. Your eyes will not feel the strain, nor will your eyes try to become small, or rather become myotic in terms of bright light, because automatically your spectacle lenses is going to take the job. So basically, these are called as light intelligent lenses, and they try to adapt to changing light conditions, okay, whether it is indoors or outdoors, and throughout the day. So it's a 24/7 lens. You can wear it right from the time you're waking up to the time you are going to sleep. So it is basically a lens which is going to adapt to all your lifestyle changes. The next important thing is it's an everyday care. Why do we call it as an everyday care? Because we understand that protection is a very important thing, 365 days, 24/7. So these lenses also do have an inbuilt property of they also have an inbuilt property of protecting from UV and blue light. So the protection is already got in these transition lenses. So it becomes an everyday lens. It's a 24/7 lens. What is the next important thing is the hassle-free. Now, what do you mean by hassle-free? Now, if you ask majority of the people who say that they're not very bothered by going outdoors, if you probe a little and you ask them, majority of them would say that they carry a sunglass. Okay. Now, the question which we need to ask is, say, example, they're going to drive or they're going to ride a two-wheeler or something like that. And imagine they're having a refractive error. And what do? They normally take a sunglass, which they like, and then they wear it when they go out. But one thing which we need to understand is they are going to compromise on their refractive error. Rather, they're not wearing their spectacle lenses with refractive error. So mostly, okay. Or even if they're wearing with a spectacle with refractive error, you need to check out and find out how comfortable they are. Are they looking in for two solutions, or are they looking in for one solution? So, and you also need to understand the frequency of indoor and outdoor, because certain professions would not be predictable in terms of how much time they will spend outdoors or how much time they'll spend indoors. So in those situations wherein they cannot predict how often they'll be moving from indoors and outdoors, you need to bring in a very good, or rather a hassle-free light management solution. So that is where these lenses would play a very important role. And last but not the least, I think especially when they wear spectacle lenses, flaunting your spectacle lens is again a very important aspect. If you find, I'm sure all of you will agree with me, the majority of time which is spent at your stores is basically in terms of selecting these spectacle frames. Apart from the clinical area, the next important thing would be in terms of the frame selection. So why do you think many customers or many patients spend more time in frame selection? Basically because it has got a cosmetic point of view, right? So whatever lenses you give, has to complement or supplement the expectation of them, of their, should fulfill their expectations. So that is where you have these light management solutions, the transitions in various colors. So it can fit with any frame shape, any frame style, and can complement to the frame which they have selected. So just to give you a short synopsis, or rather a key takeaway is basically that while we are more also involved in terms of understanding the refractive error, the ocular pathologies while prescribing a solution, once you decide to prescribe a solution in the form of spectacle lenses, okay, then you also need to understand how much more we can offer in those spectacle lenses. So today, the technology has grown to a greater extent that we are able to give more enhancements in a spectacle lens. Like for example, can give you a complete protection against UV and blue light. It can filter blue light, because we already know that you have good blue and the bad blue. The bad blue has to be filtered, and the good blue, that is the green turquoise, has to be sent into your eye, because it is very important for the sleep-wake cycle, the brain-based learning, and all those activities, right? So we understand that we need to allow the good blue to pass through. So the light management solution transitions help you to do that. And last but not the least, the I talked about different types of glare, right? Especially the glare, like your like for example, disability glare is a very extreme case of glare wherein your visual acuity, your contrast sensitivity, convenience, comfort, everything is getting compromised. Okay, so your to reduce those types of severity glare. Again, these lenses can help you to just do that and help you to have best of both worlds. That is, both whatever the main reason why these lenses are being prescribed, we understand, is basically because of various reasons. It could be a binocular vision disorders, or it could be an ocular pathology, or it could have some slight refractive errors. It could be anything, so whatever be the reason, the basic reason, you can take it up one step further and try to ensure that these lenses are optimized for their lifestyle changes. It's basically about optimizing the solution to make it work in all their working environment. So that is what is very important today. And this is just a summary of what I have told you across. So light management solution is about prescribing a solution which is light intelligent, hassle free. It becomes an everyday protection, and of course complements with the lifestyle of the customer, of the patient, in terms of and blends or complements with the frame he chooses. So that you have various colors which can blend across with the different shapes of the spectacle lenses which the patients may choose. So this is what I have to talk about today. And thanks a lot once again. Thanks a lot for this opportunity, and looking forward to more such sessions. Thanks a lot.
Thank you, ma'am. That was a wonderful presentation. Moving on to the first presentation of session 3, relationship between extended wear of soft contact lenses and central corneal thickness by Dilshan Maduranga.
Good afternoon, everyone. I'm Dilshan Maduranga. I'm going to present my lecture thesis. Its presentation is relationship between extended wearing time of soft contact lenses and center corneal thickness. Introduction. Soft contact lenses made out by soft flexible material that allows oxygen to pass through to the cornea. Present day soft contact lenses material including silicon and silicon hydrogel lenses. Most commonly, soft contact lenses prescribed for myopia, hyperopia, astigmatism and presbyopia. Most of the soft contact lenses should not wear longer period of, could not increase the risk of eye infection and corneal hypoxic conditions. The maximum wearing time can be vary by depending on the manufacturer, materials, type of the lenses, and the contact lens practitioner advice. In this case study, I mean by the extended wearing time of contact lenses is time period of continuous wearing time of 12 hours in one day, and the CCT is the measurement of the thickness of the corneal of the center portion of the human cornea. Average is 520 to 540. My objectives are the aim to study is evaluate the effect of the long hours of contact lenses wearing on CCT. My studies participants are prospectively observational study was out at Vision Care Optical Services Private Limited, Ward Place, Colombo 7. Data was obtained from the patient who visited the center during the time period of 4 month of period. Participants were 10 subjects from both males and females genders and in the age group of 15 to 35 years who are wearing using minus power contact lenses, only spherical powers, and same brand yearly soft contact lenses. All subjects are underwent a complete optometric evaluation. Each subject was examined with the all protocols mentioned in the instrumentation and clinical procedure section. Instrumentation and clinical procedure, measurement of CCT getting by the Zeiss 6000 angiographic OCT and Zeiss 5000 instrument was using for the measurement to the CCT, and procedure is the CCT was measured by optical coherence tomography at 2 times for same participant. At the first time we measured CCT1 after 12 hours of resting period, that means without wearing contact lenses more than 12 hours. And the second time of CCT measurement, that means the CCT2 is taking after the removing soft contact lenses, just after the removing. After that, we analyzed the 2 CCT1 and CCT2 measurements which measured in same participant. Data collection was done by in the Excel sheets, and statistically analysis done at all statistical analysis were performed by the social statistically package version 1.15.0. These are my results. The y-axis present by the number of patients, and x-axis mean the indicates the CCT values. CCT1 is the after rest time of period of 12 hours, and CCT2 is just after removing the extended wear time of period. This is a distribution of CCT versus number of patients. This can show the difference of the CCT1 and CCT2 values. The value of T is 2.97. The value of P is 0.0159. The result of significant because the P value is lesser than the 0.5. My conclusion is, after the extended wearing time period of soft contact lenses, there was a mean value of plus or minus 4.2 CCT microns changes. That means increased thickness after the extended wearing time of soft contact lenses wearing. Discussion is, there is a statistically significant changes in CCT1 and CCT2. The T value is calculation lesser than P is lesser than the 0.05. But clinically there were some changes. Sometimes there was not in changes in the clinically. Some of studies are evaluate the corneal status as well the CCT. The studies are describe the soft contact lenses usually cause stromal corneal edemas which increase spacing between the collagen fibers, and the effect of the biochemical properties. These corneal edemas and biomechanical changes are observed immediately after the removing contact lenses. These are the research references. My limitations is a relatively small sample size of the 10 subject will be limitation of this study, and since study was conducted during the period of COVID-19 pandemic, its participants were limited, and the most of the location were used to the limited for the collection for the data and were not operated in normal manner. Especially there was an issue in arrange a second visit or to our primary examination center, evaluate the second measurement. The further studies can continue towards the thickness changes regionally and how is changed according to the power. These are my references. Thank you.
Thank you for the interesting presentation.
Thank you, Dilshan. Moving on to the next presentation, awareness of common eye-related diseases among eye patients of Ruhunu Hospital, Galle, Sri Lanka by Kavindini Silva.
Good evening, everybody. Today I am going to present my main research on awareness on common eye-related diseases among eye patients of Ruhunu Hospital, Galle, Sri Lanka. I am Kavindya Navodani from Vision Care Karapitiya branch. At the present, a large number of eye diseases have been detected. Many of them are caused by our lifestyle. Even though the eye diseases are common within the society, there is a doubt whether the people are aware of such diseases. This was the main reason of doing such kind of research. For this study, I chose cataract, diabetic retinopathy and glaucoma. First, let's see about the cataract. According to the National Eye Institute, cataract is a cloudy area in the lens of eye. Looking into the risk factors of cataract, the main reasons are have certain health problem like diabetes, smoke, drink too much alcohol, have a family history of cataract, and also have spent a lot of time in the sun. Usually it has not any symptom at the first, but it may cause blurry vision. The most common treatment is IOL surgery. The second eye disease is diabetic retinopathy, and it is an eye condition that can cause vision loss and blindness in people who have diabetes. The main risk factor of diabetic retinopathy is diabetes. At the first, you may not notice that you have diabetic retinopathy. The most common treatment is laser treatment. Finally, it's glaucoma. Glaucoma is a group of eye disease that can cause vision loss and blindness by damaging optic nerve. The main risk factor is high eye pressure, and family history and aging are also in. As well, cataract and diabetic retinopathy, glaucoma does not have any symptom at first. Anti-glaucoma medicine are available for treat glaucoma. The main objective of this study to find out public awareness of eye-related disease of OPD patients Ruhunu Hospital Karapitiya, and the specific objective to describe awareness level of symptoms, risk factors and prevention of selected eye disease. I selected 50 eye patients of Ruhunu Hospital Karapitiya within the time period 2nd of May to 25th to May. My sample include both male and female within age group 25 to 17 years old. A questionnaire on eye-related disease was given to OPD patient who visit consultant of Ruhunu Hospital, and the questionnaire form analyzed and graded according to the answers. Finally, examination data recorded and analyzed using Google form. This is my questionnaire. And my sample average age size 31.7 years. You can see the male and female percentage on the slide. And the education level. Now I am going to present the result of my questionnaire. 78% of population had any vision problem, and out of them 18% of population mentioned that the vision loss is highly affected their daily performance. 48% perceive moderate level of disturbance in the vision loss, and the 8% of the population says that the vision loss is not affecting their daily life. Regarding the awareness of selected eye disease, 92% heard about cataract, 55.1% heard about diabetic retinopathy, and glaucoma it's 78.7%. From here, I assessed acceptable definition of such disease, and for the cataract, 36% provide the acceptable definition. For diabetic retinopathy, 16%, and glaucoma, it's only 26%. Considering awareness on treatment, none of the population not aware on the treatment of diabetic retinopathy, and only 8% know about the glaucoma treatment, but 68% know about treatment for the cataract. Looking into the awareness of symptoms, 25% know about first symptom of cataract, 14% know about diabetic retinopathy, but it's only 6% for the glaucoma. In my conclusion, although loss of vision was reported as major medical concern, there is a little understanding of the risk factors for the different eye disease. Out of selected eye disease, majority of the population are aware about cataract, and the awareness on the diabetic retinopathy and glaucoma is considerably low. My recommendation, first I suggest that innovative multilingual awareness programs in primary and secondary schools are needed to improve knowledge, attitude and practice about eye disease. Next, I suggest that to increase the knowledge about eye disease by conducting awareness program on the most prevalent eye disease and distributing leaflets on the patients who visit the ophthalmologist. Finally, I suggest that display posters about eye disease in the patient's waiting area. These are my referrals.
Thank you for the interesting presentation. So does awareness have changed the patients, how they seek treatment? Like if they know about the cataract or glaucoma, they have gone for treatment and screening earlier. Is that thing is assessed or not?
Yeah, I select the eye patients who visit the eye surgeon.
Right.
Okay, thank you.
Thank you, Ms. Kavindini. Next presentation will be on Survey on Consumer Awareness and Market for Blue Light Filter Lenses in Matara area during COVID-19 pandemic by Anusha Manel.
Good afternoon, all of you. I am Anusha Manel from Vision Care Mathura branch. My topic is Survey on Consumer Awareness and Market for Blue Light Filter Lens in Mathura area during COVID-19 pandemic. Introduction. Introduction of coronavirus disease is an infectious disease caused by the SARS-CoV-2 virus. To minimize spread of the disease over the entire population in Sri Lanka, the government took measures such as island-wide school closure, limit public gathering and finally deciding to impose island-wide curfew. Pandemic has impacted the education system and work culture in Sri Lanka, similar to many countries in the world. As a result, the mode of education shifted from conventional face-to-face classes to online mode and online work. Introduction of blue light. It's part of the visible light spectrum which comes from both the sun and artificial light sources like digital screen and fluorescent lights. Visible light of short wavelength may cause the photochemical injury to the retina called photoretinitis or blue light hazard. Lights of any kind can suppress the secretion of melatonin. Blue light at night does so more powerfully. Harvard researchers conducted an experiment comparing the effect of 6.5 hours of exposure to blue light of exposure to green light of comparable brightnesses. The blue light suppressed melatonin for about twice as long as the green light and shifted circadian rhythms. Introduction of Esila Preventia blue light filter lens. Crisal Preventia lenses are result of several years of researchers in collaboration with the Vision Institute in Paris, which helped us develop the first clear lens that selectively filter blue light and contribute the reducing its potential harmful effects on the eyes. My objective is to identify consumer awareness about effect of blue light in Mathur area, to identify consumer awareness about use of blue light filter lens in Mathur area, to evaluate impact on online education or work on sales of Preventia blue light filter lens in Mathur area. My method and materials: sample size of 25 spectacle wearers with Preventia coating who visit Vision Care Mathur branch during February of 2022 is selected for randomization for consumer survey. Consumers from both male and female from all age groups are selected for the consumer survey. 2,441 lens orders taken at Mathur branch from 2019 January to 2021 December from 12-bit ordering system is used for the sales analysis. This is my questionnaire format. As my sample, 9 male person and 25 female person. As my sample, 9 male person and 16 female person. This is my first question and answers from those 25 customers. In this chart, showing 40% of consumers were aware about blue light filter lens from word of mouth and another 40% from social media. %60 consumers purchase blue light filter lens to protect their eyes from the blue light rays from digital devices. In this chart, 48% of consumers aware about all the benefits from Preventia lenses. We can see 71% for patients claimed they had a better night vision with Preventia lenses. We can see here all people said they not waste their money. In this chart, most of people identify this lens from coating color. This chart will present progressive addition lenses and single vision Preventia lens movement of 2019 to 2021. As a result, analysis of lens dispensing progressive addition lenses with Preventia, growth from 2019 to 2020 in Preventia coating increased by 77.77%. Growth from 2020 in 2021 increased by 309.37%. 2019 to 2021 increased by 627.77%. Analysis of lens dispensing progression single vision lens with Preventia over the years 2019 to 2020 increased by 333.62%. Growth from 2020 in 2021, Preventia coating increased by the 226.24%. Growth from 2019 to 2021 in Preventia coating increased by 1314.65%. My conclusion, in COVID-19 pandemic period, the majority of the spectacle wearers had been aware about the harmful effect of blue light rays for the eyes, and they are aware of Preventia blue light filter lenses. Major source of awareness is from word of mouth and social media. Limitation. Sample size of consumer survey is small compared to total amount of Preventia lens purchases. Hope to continue this research. These are my references. Acknowledgement is Mathura Branch Manager Mr. Geet Veeraratna, my research supervisor Ms. Hirudini Patirana, and my colleagues at Mathura Branch. Thank you.
Thank you for the interesting presentation.
Thank you, Ms. Anusha. Coming up next is a literature review by Malindu Bandara on the correlation between keratoconus and eye rubbing.
Good evening to all of you. Today my review is about the correlation between keratoconus and eye rubbing. My name is Maldu Bandar Amrasinghe. So as my introduction, keratoconus is a non-inflammatory progressive thin process of the cornea. It is a relatively common disorder of unknown etiology that can involve each layer of the cornea and often leads to high myopia and astigmatism. So as signs and symptoms, double vision when looking with just monocular, objects both near and far that look blurry, bright lights that appear to have halos around them. Risk factors for keratoconus. There are 4 risk factors. It can be from genetics, chronic eye inflammation, eye rubbing, and age. As from genetics, patients with a family history of keratoconus or with certain systemic disorders such as Down syndrome are at a higher risk of developing keratoconus. And chronic eye inflammation, constant inflammation from allergies or irritants can contribute to the destruction of corneal tissues that may result in developing keratoconus. Eye rubbing, chronic eye rubbing is associated with developing keratoconus. It may be also a risk factor for disease progression. Age. With the age, keratoconus is often discovered in the teenage years. Generally, young patients with advanced keratoconus are more likely to need some from surgical intervention as the disease progresses. How is keratoconus diagnosed? We have testings like corneal topography, pachymetry, and the slit lamp exam. The pachymetry test, this test is used to measure the thinnest areas of the cornea. And the slit lamp exam, this examination of the cornea can help detect abnormalities in the outer and middle layers of the cornea. The corneal topography is the way to diagnose early keratoconus and follow its progression. A computerized image is taken that creates a map of the curve of the cornea. Definition and causes of eye rubbing. Eye rubbing is a common habit that occurs spontaneously before sleep, when awakening, and throughout the day as a response to ocular irritation, fatigue, and emotional stress. Eye rubbing as risk factor for keratoconus. Chronic abnormal eye rubbing is associated with keratoconus development. Repetitive, gentle, and vigorous knuckle grinding rubbing are associated with progression of keratoconus. As my main objective is to analyze how do keratoconus related to eye rubbing. So my methods, I have taken 15 articles from the time period of 2000 to 2021, reviewed time period from 10th May to 30th May of 2022. So as my research, I have taken 7 authors. So with the 7 authors, they are telling that eye rubbing is the main risk factor for keratoconus. The first author was Gordon Shag. It was published on 2013 from the country Israel. He has taken number of patients 140, and the study, he confirmed that eye rubbing, allergy, and education are also significantly associated with keratoconus after adjusting for other predictors. And the second one was Moran from Paris, France. Year published 2020. Number of patients 202. This study shows a strong correlation between eye rubbing and keratoconus, particularly when rubbing is performed with the knuckles. And the third, also, he has done another review about this, about keratoconus, and on 2007, 53 patients. Okay, so the last is from Australia. He has concluded that eye rubbing for 60 seconds increase the level of tear. This increase in proteus activity and inflammatory mediators in tears after eye rubbing may be exacerbated even further during persistent and forceful eye rubbing seen in people with keratoconus. This in turn may contribute to the progression of the disease. So the 7 authors have been told that eye rubbing is the main risk factor for keratoconus. So as my conclusion, eye rubbing is the main factor which is causing major number of eye injuries, especially keratoconus. The risk of eye rubbing, as the most of the persons are performing it as a habit, it is recommended to avoid eye rubbing to prevent keratoconus. My references. Thank you.
Yeah. So then, so it is keratoconus progression is related with eye rubbing, and you mentioned that you have found that it's better to ask them to avoid eye rubbing. So more than that, what we should do is we have to identify the reason for eye rubbing. We can't tell that you should not rub your eye because if the patient is having itchiness, so they are rubbing, right? So we have to find the cause and treat that. Usually allergic conjunctivitis, we have to detect by slit lamp examination, and we have to give antihistamines and avoid the allergens. So like that we have to treat. By that way we can avoid the rubbing, right?
Thank you.
Thank you, Malindu, and thank you, Doctor. That was an insightful information. Moving on to the next presentation. Investigation of effects on online education and employment on visual acuity during the period of COVID-19 pandemic by Sarina Ghafoor.
Hello everyone, I am Sharina Ghafoor. Today I am going to present my research on investigation on the effect of online education and employment on visual acuity during the period of COVID-19 pandemic. And first introduction. The COVID-19 pandemic is one of the most important social events of the last century worldwide. The outbreak of coronavirus disease, an infectious respiratory disease, was first reported in Wuhan, China. Since the first case in our country, the government has been taken serious measures to be reduced spread of the virus and impacts. Within the scope of these measures, schools, universities were closed, and online education training activities continue as initial step. This research aimed to measure effect of online educations or of employment on visual acuity of adults. In addition, it focused to look at the consistency of the scale and develop with the survey by applying questionnaires. Objective: The aim of this study is to explore impact of online educations or employment on visual acuity during COVID-19 pandemic. This pandemic situations on impact on students and employees, these using mobile phones, laptops and lots of electronic device for their study and work purpose. During that period, that time the eye is more vulnerable. Being in front of a digital device for many hours is a major problem with eye strain. And the symptoms of the eye strain is overworked eyes. This may cause decrease in visual acuity. It is also more likely to cause side effect as well as dry eyes, double vision and etc. Prospective observational study at Vision Care Optical Service and duration time period of 2022 March to 2022 May. And participations 100 subjects from both male and female genders in the age group of 20 to 25 years who were diagnosed with impact of visual acuity during the COVID-19 pandemic. An unaided visual acuity was measured before and after COVID-19 pandemic and according to the factors and the ocular symptoms for the computer usages. And subject who presented with any refractive error, any other ocular pathology, and those who presented with systemic vacuolar disorders were excluded from the study. And those who did not have records of eye examination before COVID-19, this is also excluded from the study. And data analysis, all the data was recorded in the Excel sheet. All of the participations managed LU of 22 and all the results are calculated by using baseline visit findings. And ANOVA independence was used to analyze the data of this study. Results, all of the participations is mean age of 22 and all the results are calculated by using baseline visit findings. First visit findings before COVID-19 and second visit findings after COVID-19. This is my first graph. This graph distributions of visual acuity from 2018 to 2022 who use the electronic device more than 6 hours. This x-axis is integrated number of subject and y-axis integrated logMAR value. This graph shows visual acuity decreased enormously for the patients who use the electronic device as more than 6 hours. That result showed that there was significant changes visual acuity before and after COVID-19. And this is second graph. This graph distribution on visual acuity from 2018 to 2022 who use the electronic device 2 to 6 hours. And that result showed that there was not significant changes visual acuity before and after COVID-19. And last graph, this graph also distribution of visual acuity 2018 to 2022 and who use the electronic device less than 2 hours. This graph also that result showed that there was not significant changes visual acuity before and after COVID-19. This table shows the association of different factors with various ocular complaints reported by the subject. It was also found the eye strain, headache had a significant association in subject not maintaining proper distance from the computer. Eye strain was less and had a significant association when subject maintained top of the screen level below the eyes. And discussion, the effect of e-education and work from home visual acuity in COVID-19 period was investigated. The COVID-19 pandemic has profoundly affected all society in the world. One of these results is the social isolation measures have been taken to slow the course of the disease. In addition to these results, in the COVID-19 period, a positive correlation was found between the detraction of visual acuity and eye strain in online education and vocation. Previous studies have shown that visual acuity related to screen usage may be seriously affected. Visual acuity can be negatively affected due to this increase. In other words, eye strain increase as the results of online education restricted to eye health. Digital screens like laptops, computers, and mobile phones can cause harm by radiating short high energy waves that may penetrate eye tissues, can finally contribute to photochemical damage to the retinal cells. By this way, harmful waves can cause a variety of eye problems ranging from dry eye to age-related macular degeneration. And my conclusion, according to the results for this study, the visual acuity decreased enormously for the patients who used the electronic device as more than 6 hours without using spectacles. However, it decreased generally for the patients who use electronic device 2 to 6 hours and less than 2 hours. The results of this study, major ocular problem is eye strain and dry eye, but it makes less impact on eyes. If so, we are continuously affected by electronic device, but it affects massively during the COVID-19. So the visual acuity decreased additionally for the patients who use electronic device more than 6 hours during the COVID-19. And take-home message, use of computer for long hours without spectacles may cause reduction in the visual acuity. As an optometrist, we instruct the patients to maintain the factors of using the computers, such as distance from the computers, duration of using the computers, and etc. And explaining about the 2020 rule and also suggesting them to use the computer protection glasses. Therefore, we can reduce the computer vision syndrome for the long-term computer users. This is my reference. Thank you.
Thank you for the interesting presentation. The visual acuity was unaided visual acuity.
Yeah.
Is there any change of refractive error?
Yeah, changes.
Changes.
Yeah.
What sort of like myopic?
I considered on the myopic patients, and before refractive error, increase the visual refractive error.
Yes. Okay.
Thank you.
Okay. Ms. Ananta, do you have any question to ask? Is Ms. Ananta there? Okay. Right.
Thank you, Ms. Sarina. Moving on to the final presentation of session 3, relationship between keratoconus and ultraviolet exposure by Kalpana Kaushalya. Pronounce it wrong.
Good evening, everyone. I'm Kalpana from Jaffna branch. Today my presentation is about a relationship between keratoconus and ultraviolet exposure. This is my introduction. In 1854 was the year that keratoconus was officially documented. This terms come from Greek, that is keras. It stands for cornea, and konos stands for cone. It in its etiology is complicated and involves genetic and environmental factors is yet unknown. If we define this more and more, corneal condition in which the central region of the cornea thins down and bulges forward in a cone-shaped pattern using myopia, uneven astigmatism, and finally vision loss. Environmental, socioeconomic, and familial factors are the things that affect to this keratoconus. If we turn to the key point in my research, excessive exposure to sunlight cause oxidative damage in keratoconus corneas. I have shown some example in this introduction also. We'll talk about this in detail in later. If you talk about more in keratoconus, after affect this keratoconus into a human, it progresses faster in men than in women because of the higher occurrence. If we talk about the UV, when we think that UV is the main part in the sun rays, but that's not the reality. It is a one minor part in the sun rays. Sunlight is the primary source of UV radiation. These various types of UV reach the earth in various amounts. From this UV, it gives the harmfulness by the intensity of rays, the length of time that skin or eye is exposed, and whether the skin or eye protected by the clothing or sunscreen. I'll give you more details behalf of these UV. Source of reactive oxygen species, it means ROS, and sunlight leads to oxidative damage to keratoconus corneas. The higher prevalence of keratoconus in hot, sunny countries compared to Europe and North America has led to the belief that high sun exposure in these countries accounts for the higher prevalence. Objectives. The aim of this study to find out that there any relationship between keratoconus and UV exposure. Materials and methods. This review includes 50 articles from the PubMed and Google Scholar electronic databases from 1970 to 2014. In results, in this chart shows the epidemiological studies conducted in hospital or clinic. A few years ago, most publications on keratoconus referred almost exclusively to one prevalence value obtained in Minnesota, USA in 1980, which had been found to be 0.054%. It means 54% out of 100,000 people. Diagnosis was based on a mixture of scissor movements in retinoscopy and keratometry, as were the majority of prevalence studies published prior to 2011. This fatigue was similar to those reported in Finland on Denmark, but much higher than those reported in the Urals, Russia at 0.0004% or 0.0068% in Skopje, Macedonia. Still, it must be noted that the more precise video keratopathy is likely to yield higher prevalence than the older methodology. Research studies using the method report higher prevalence or incidence, but the factors may confirm a possible correlation with the method used from the Middle East and India with different climates and ethnic groups that Europe and North America, even if merely diagnosed with a keratometer. In this table 2 shows all the modern studies result in a higher prevalence of keratoconus than previously thought, ranging from 0.9 to 3.3%. This table illustrates the population-based studies. As an example, Milodot et al. Describe how they diagnosed keratoconus with a combination of topographic pattern, dioptric power of the corneal apex and inferior and superior asymmetry to determine normal keratoconus, suspect and defined keratoconus. In discussion, when I analyzed these researches, there wasn't any significant cause that proved this one is the main reason to keratoconus. Additionally to rubbing eyes, atopy and familial factors, it means keratoconus in family or consanguinity. Exposure to UV light and geographical location is also getting a remarkable place in the causes related to keratoconus. According to results that I analyzed these researches, geographical location and UV exposure are also giving a noticeable contribution to keratoconus. In conclusion, in Sri Lanka, there is no any research belonging to this topic because there is no any seasonal changes in Sri Lanka. So I would like to continue this research from this with the upcoming upgraded world. All these things can change rapidly and how this scenario familiar with Sri Lankan conditions. These are my take-home messages. If we must avoid from the irabin, as my colleague Malinu says, we can avoid from the keratoconus. In family, have the history of keratoconus, we have to be more careful of the symptoms. If we can wear a cap or other related thing to avoid from UV rays, it will be a way to care from keratoconus as well. These are my references. These are my 50 references. And thank you.
Thank you for the interesting presentation.
Thank you, Kalpana. Now we have moved to the final sessions of our scientific day, hearing care. Ladies and gentlemen, Vision Care has been a pioneer in offering not just eye care, but also the greatest hearing care to the people. Vision Care's audiology division is known for providing the excellent hearing care services and has remained the #1 choice for several reasons. She attended Visakha Vidyalaya and she obtained her MBBS degree from University of Colombo, graduated as an ENT surgeon from PGIM Colombo, and received her MRCS from England. At present, she has been working as an ENT consultant at Sri Javadanapura Hospital since 2016. Her special interest in cochlear implantation for children. Ladies and gentlemen, I am honored to invite consultant ENT surgeon Dr. Sanjeevani Rupasinghe to deliver the keynote speech. Madam, over to you.
Thank you very much for your kind introduction. So today, first of all, I would like to thank Mr. Dasanta and Mrs. Kumari and all who invited me to grace this occasion. So my topic today is about hearing. So as we go on, I would like to outline the facts about how we hear. And then I will move on to the global statistics and the common misconceptions on hearing loss and the measures that we can adopt to protect our ears. So I am sure you all are familiar with the hearing mechanism. The sound signals are collected through the pinna, external auditory canal, and then the signals are transmitted through the eardrum to the middle ear and then to the inner ear. And the signals are processed, the canal, pinna, outer ear canal, middle ear, the inner ear. And then the signals are sent to the brain via the auditory nerve, where the signals are processed and then associated with the surrounding areas which is responsible for hearing and speech. So any interference, any disturbance in this hearing mechanism will lead to hearing loss in varying degrees. If we are to see the global statistics, the WHO has predicted by the year 2050, there will be 2.5 billion people with some degree of hearing loss. And also they say 1 billion young adults are at risk of permanent avoidable hearing due to unsafe listening practices. So it's not a rare thing, it's a very common problem that we all have to consider. So if you are to concentrate on common causes of hearing loss, people think that the hearing loss occurs after birth. No. Even in utero, the fetus, the developing embryo can be affected with various things which can lead to hearing impairment once they are born. So you have perinatal conditions like intrauterine infections, prenatal, perinatal, and then childhood and adolescence, where you have ear infections, conditions like meningitis can lead to hearing impairment, and old age group, age-related hearing impairment with associated smoking and other conditions. Across the lifespan, any age, because of anything obstructing the outer ear canal like cerumen or noise induced hearing loss, trauma, anything can affect hearing loss. So it's not only affecting who are living or born, but it can affect the fetus during the intrauterine life also. So there are a lot of misconceptions about hearing which I would like to highlight on my talk. One thing is, people think that there is no difference in treating hearing impairment early treatment, and there is no difference in the late treatment. No, certainly there is a difference, because earlier the treatment is better because you preserve lot of sensory tissue or hair cells in the cochlea, and that will certainly enhance or improve the treatment. And one other condition I would like to highlight is this sudden sensory neural hearing loss. I'm sure you have heard of it. It is sudden. All of a sudden a patient loses hearing, right? People have come to us and have told us they are sleeping and they are awake the next day, all of a sudden their hearing is gone. So it's sudden. There is no previous warning signs or anything. And if you diagnose this sudden sensory neural hearing loss, you have only a very narrow window period for treatment. It's only 24 to 48 hours narrow window period that you have to treat these patients and to recover their hearing completely. Otherwise, they are going to end up with a dead ear, which is disabling, and it's for lifetime. So in reality, earlier the treatment is better than late treatment. And also, people think that the hearing loss affects older people, right? Hearing loss is with age, you lose your hearing. No. As I told you earlier, it can affect the growing fetus in utero, right? That is why in Sri Lanka, all age-bearing women are mandatory to have this rubella infection vaccination, because intrauterine rubella infection can cause permanent disabling hearing impairment in children. So it's not only affecting older people, at any age hearing impairment can occur. Also, people think loud noise, loud music does not cause any hearing loss, right? So young adults, they are exposed to a lot of loud music. They are always with their headphones on, right? So because they think this loud noise is not going to affect their hearing. But in reality, this is what happens when you are exposed to loud noise. It doesn't happen in a day, not in a week, but if you are exposed to loud noise continuously, more than 30 decibels, you can have a hearing impairment with time. They affect the hearing sensory cells in the cochlea, and initially it's a reversible thing, temporary threshold shift, but later if you don't stop this loud music, this can go progress to a permanent hearing loss. So you see this this notch in 4000K, and it gradually develops, and this loud music, loud noise certainly have a impact on hearing. And the other thing I would like to highlight is people think that the ear canals should be completely free of earwax. So they try different methods, different cleaning methods to clean their ears, because they think that the earwax should be taken out. But people doesn't know that the ear is a self-cleansing organ. It has its own mechanisms to clean the ears. There is an epithelial migration process starting from the eardrum. It migrates outwards. It brings all the dirt, cerumen, whatever inside, and it puts out. It's a normal physiological mechanism. But by trying to remove wax, you disturb that physiological mechanism, and wax and everything tends to collect inside. So 90% of the population, this normal mechanism works perfectly, but in 10% of the population, the normal mechanism is disturbed. So in that 10% group, you have to go to a doctor to get the ears clean. But by using all these instruments, thinking that the ear canal should be completely free of wax is going to cause problems. So we have seen patients, simple cotton buds, earbuds has damaged the canals. Canals are swollen, intense, immense pain, fever and all. So signs of infection, discharging ears, causing lot of problems. So you don't have to clean your ears. Besides, wax is protective, right? It does a protective effect. So you don't have to clean your ears regularly. People do think that the hearing loss is always caused by earwax. As I told you, in reality, earwax is just only one cause. If the wax is impacting on the canal, it's completely blocking, the sound waves are not conducted through. So in that case only the hearing is impaired, but otherwise canal wax is not going to impair hearing. You must have seen patients with this ringing noise in the ears. We call it a tinnitus or tinnitus. It can be a ringing noise or a clicking, hissing, buzzing noise, whatever, a noise in the ear, right? So people usually disregard this as a mere inconvenience, right? They don't pay any attention to these noises in the ear. But tinnitus can occur for many reasons, right? I have seen patients complaining of tinnitus with ear completely obstructing canals with earwax. And tinnitus is a symptom which occurs in conditions related to inner ear, the auditory nerve and the brain. For example, conditions like acoustic neuromas, schwannomas, vestibular schwannomas can present with tinnitus. So, it's not a mere inconvenience. We have to look for a cause. So, you have to refer the patient to a specialist to find out the cause for this tinnitus. So, noise-induced hearing loss can cause tinnitus. Infections can cause tinnitus, diseases of the blood and blood vessels, and Meniere's disease. You all are familiar with this. Meniere's disease can cause tinnitus. So many things can cause tinnitus. So people think this speech discrimination, difficulty in understanding speech, right? If you don't have, I mean, you can hear, but this speech discrimination, I only have lost speech discrimination, right? So I don't have a hearing loss, right? That's a misconception. So the first thing you are going to lose is speech discrimination, right? You can hear the background noise, but you can't discriminate what the people are talking. So that is the first sign of hearing impairment. Okay, so in reality, hearing loss is not the total deafness, right? People think that if you are not hearing, you have to be dead, ear dead, has to be dead. It's not total deafness, right? So impairment can occur in various frequencies to various degrees, right? So speech discrimination is one of the main things that you have to consider in hearing impairment. Who are the people who can get this speech discrimination? Mainly old people with all sensory neural hearing loss. We have a name for that. Presbyacusis, right? So old people, presbyacusis, they have speech discrimination because the frequencies, only the high frequencies are going down rapidly, not the low frequencies. So in the speech banana, they cannot hear the high frequencies, so there's poor speech discrimination. So the hearing aid is going to amplify the signals, and they are going to give the clarity. It's not clear, the clarity. So lastly, how can we protect our ears? Firstly, don't do anything. Let the ear protect itself. Let the ear self-cleanse itself, right? So to protect your ears, it is again hearing, right? Hearing screening and intervention, so you can early diagnose any abnormalities. Then ear diseases, you have to prevent and manage ear diseases to prevent hearing impairment, disabling hearing impairment. Then access to technologies, as I said, hearing aids and all, amplification devices certainly can overcome your hearing impairment. Rehabilitation services, right? Like cochlear implanted children, you need auditory verbal therapy for their speech development and hearing improvement. So rehabilitation services, improved communication, noise reduction, because loud noise again can cause impairment. Greater community engagement. What is meant by greater community engagement? You have to have public awareness and public health strategies to improve awareness, like vaccination, perinatal care, genetic counseling, early detection and management, occupational health, everything. You have to have an awareness program in the community to identify problems early and treat them accordingly. World Hearing Day falls on the 3rd of March every year to improve this awareness among the community, right? So as audiologists, speech therapists, right, you have a role to play, because there are a lot of misconceptions in the community, right? If you can address these simple things, simple misconceptions in the community, in a long run, in a long way, it helps to improve the standards, living standards and everything in the community, in people. So it's very important to educate patients, make awareness, and to educate people how to look after their ear and the hearing mechanism. Thank you.
Madam, kindly remain on the stage to accept the token of appreciation, and I kindly invite Mr. Dasantha to deliver the token of appreciation. Thank you, madam. So now we are going to start the hearing presentations. Contribution of amplification to the development of auditory skills in children which serve to profound hearing loss assessed via Meaningful Auditory Integration Scale, MAIS, by Darunya Kamaleswaran. Darunya, over to you.
A very good evening, everyone. I'm Darunya. I'm an audiologist at Ward Place Vision Care, the head office. I'm here today to present my research, the contribution of amplification to the development of auditory skills in children with severe to profound hearing loss, assessed via Meaningful Auditory Integration Scale. I'll be talking under these headings. Let me start with the introduction. Hearing impairment is relatively common in children. According to WHO, nearly 32 million are having hearing difficulty around the world. The impact of hearing loss and auditory skill development depends on many factors, such as age of onset, degree of hearing loss, age of identification, and intervention. Interventions such as speech therapy, provision of hearing aids, as well as auditory verbal therapy. Individuals with severe to profound hearing loss, despite giving an amplification, initially they'll have the ability to detect the presence or absence of a sound. Assessing their behavioral performance is imperative in making decision regarding the amplification devices, whether to give a cochlear implant or a hearing aid. The ability to discriminate the sounds and identifying the speech sound develop with substantial amount of auditory verbal therapy and with some visual support. This hierarchy was developed by Dr. Norman Herber. This explains how the auditory skills develop in children. So initially, the children will have the ability to detect the presence and absence of a sound. That means when they hear the sound, they should show some response by turning their head or show some startled responses like that. And next, the discrimination. That means when there are two different sounds, they will be able to discriminate whether they are two different sounds. For example, if they hear a sound of a cow, moo moo, and the dog barking, they should detect, okay, those two are different kinds of sounds. And the next stage is identification. When they hear the sound, they have to exactly identify what is that sound. If they hear their mother is calling them, they should identify, okay, that's their mother's voice. Then the final stage is comprehension. That is associating the meaning with the auditory signal that they are hearing. The background of my study: early intervention begins with appropriate fitting of hearing aids, even with cochlear implant at a later stage. The provision of amplification provides access to acoustic information in the speech and eventually develops to comprehension of meanings, and this paves way for the development of language in these children with severe to profound hearing loss. My general objective of the study is to assess the contribution of amplification to the development of auditory skills in children between the age of 1 to 3 years of age with severe to profound sensorineural hearing loss using the meaningful auditory integration scale. And these are my specific objectives: to evaluate the overall significance between aided and unaided PTA thresholds of children with severe to profound hearing loss, to assess the relationship between the number of aided PTA transition and the MACE scores. I'll be talking about the transition in the upcoming slides, if you're wondering what is the meaning of transition. The third specific objective is to evaluate if there is a significant impact of age of hearing aid uptake on the development of auditory skills in children via MACE scores, to establish a hierarchy of early auditory skill development for children with severe to profound hearing loss following the hearing aid acquisition. The methodology: the study included 50 participants. Those children are children with severe to profound hearing loss. We selected them via purposeful sampling. In the inclusion criteria, we included all the children with severe to profound sensorineural hearing loss and who are using advanced or premium level hearing aids for more than 1 year of time in both years. And these children were attending the same intervention program. The intervention program I'm referring here is speech therapy. And we excluded all the children who are having other degrees and types of hearing loss and duration of hearing aid usage less than 1 year of time, and unilateral hearing aids with entry level or essential level category, and who are having lack of speech intervention or different speech intervention programs. The data was initially obtained by obtaining the unaided and aided PTA thresholds, and we used a standardized questionnaire, meaningful auditory integration scale, and we obtained the retrospective scores by interviewing the parents. The interview was carried out in 2 different timelines, immediately after the hearing aid uptake and after 1 year of intervention. And we also recorded the age attainment of each skill listed in the MACE questionnaire. The meaningful auditory integration scale is a parent report scale. It has 10 probes, and these questions explore the child's bonding to the hearing aid they are using, their alertness to the sound, and the ability to derive meaning from the auditory stimuli they are hearing in everyday situation. And this doesn't have a specific age range. And the MACE has the different rating of scale, whereas the 0 is never, 1 rarely, 2 occasionally, 3 frequently, and 4 always. And these are the components of MACE questionnaire. If you see the components, we can see the different stages of Erbers hierarchy. For example, response to name call defines the awareness, and discrimination of 2 sounds defines the discrimination. Identification to the auditory signals present in the environment, this defines the identification of auditory signals. And finally, the comprehending emotions by associating the sounds defines the comprehension skill. We analyzed our data with the Wilcoxon sign rank test, which is a test of significance between we analyzed our results, the test using the Wilcoxon sign rank test, and we found out there was an overall significance between aided and unaided PTA thresholds in these children with severe to profound hearing loss. And the results also show the significant difference with respect to the improvement between the aided and unaided PTA thresholds of these children, because the p-value was less than 0.001. And if you see the number of participants, there were 24 participants who came up to the moderate category with the aided PTA transition. That means the transition we are referring here is if their unaided PTA is severe category, and with the aided transition, if they are moving up to moderate category, we are referring it as 2 transition. And if they are coming up to mild category, we are referring it as 3 transition. And if they are moving up to normal category, we are referring them as 4 transition. So here, the majority, 96% of a proportion of children had 2 transition, and whereas the other two categories were coming under 48%. The significant difference between the number of unaided to aided PTA transition and the MACE scores were also evaluated with one-way ANOVA test. If you see this table explains from severe to moderate transition. You can see the mean score at the beginning and mean score after the 1 year of hearing aid uptake. So there is a significant difference between each of the transition. And this graph shows with number of transition how the MACE score improved. With 2 transition it was 55.41 and with 4 transition it was 97.5. So it was found that the MACE scores improved significantly with number of hearing aid category transition. And we also found out the age of hearing aid uptake of children is found to have a significant impact on the final MACE scores. That means if they had taken the hearing aids at an earlier stage, they had a substantial improvement with auditory verbal therapy compared to the people who had got the hearing aid at a later stage. And this was interesting findings from our study. We could develop a hierarchy for early auditory development for these children, because these are the questions coming in the MACE questionnaire. They did the nonverbal indications, that's the earliest skill in the Norman's hierarchy, that was obtained in 3.84 months after the hearing aid immediately after the hearing aid uptake, whereas the comprehension of emotions was obtained after 36 months since the hearing aid uptake. So you can see the graph is going up like this. So we were able to develop this hierarchy with the results of our study. The discussion. So this present study provides an important information to assist the clinicians as well as the parents to see the substantial development in the auditory behavior of their children. And also it emphasizes the need for assessing functional hearing when providing them with hearing aids. And it supports the notion that early intervention is a must for auditory skill development. And one of the informal outcome we found out was the involvement of parents in the assessment and therapy, provision of therapy for these children. So I would like to conclude my study with my presentation with these points. Superpower or ultra power advanced premium hearing aids elevate the aided thresholds of children with severe to profound hearing loss to a significant level. And particular improvement can be noted with the early acquisition of hearing aid, which defines the early improvement in the auditory skills. Moreover, the hierarchy of early auditory skill development established via the finding could provide a ground for what could be expected with respect to auditory behavior after fitting of hearing aids. And these are the references of my study. Thank you.
Thank you, Dharanya.
Thank you.
The next presentation is retrospective study on childhood hearing loss and risk profile in the Western Province, Sri Lanka by Dilshani Wijeratna.
Good evening all. My name is Dilshani. I am from Vision Care Audiology Unit. The topic of my study is a retrospective study on childhood hearing loss and risk profile in the Western Province, Sri Lanka. As an introduction to my study,
around 7% of the people with disabling hearing loss are children, and it's very worrisome to note that 5 out of every 1,000 infants are born with developing disable hearing loss in early childhood. Importantly, most of the people with hearing loss are found in developing countries, where it has been estimated that at least 2,000 infants with hearing loss are born daily, highlighting the grave need for more attention to hearing loss in these parts of the world. Another major effect of childhood hearing loss is the negative impact it has on the language development, cognition, and academic performances. Therefore, early diagnosis of hearing loss is crucial. Some of the most common risk factors for hearing loss are ototoxic medications, premature birth, low birth weight, and intensive care in excess of 7 days. As the number of risk factors increases, the probability of hearing impairment also increases. The objective of my study is to describe the associated risk factors and the nature of hearing loss in infants and children within the western province of Sri Lanka, diagnosed at the Department of Audiology in Vision Care. The methodology of my study is a retrospective review of clinical data was collected from total of 102 children under 3 years of age at the time of diagnosis. It was evaluated between a period of 2018 to 2022. The data collected included demographical information, risk factors documented on the pediatric case history questionnaire, test procedures conducted, the diagnosis, which includes type and degree of hearing loss, documented age of caregiver suspicion, age of first diagnosis, and co-occurrence of any speech delay. These data were analyzed to assist in sorting, analyzing, and organizing the data using SPSS software. Moving on to the results, of the 102 children, 50% of them exhibited some form of hearing loss, whereas rest of the 50% were found to have normal hearing. So, as depicted in this chart, sensorineural hearing loss was exhibited in 37.6%, which is shown in green color, followed by auditory neuropathy spectrum disorder, which was 3.9%, and a minority of mixed hearing loss and conductive hearing loss respectively. The rest of the losses were not specified, and it was 4.9%. As this table shows, the permanent hearing losses, which were sensorineural hearing loss, auditory neuropathy spectrum disorder, and mixed hearing losses, constitute 88% of the hearing losses, whereas conductive hearing loss was the least exhibited and was due to middle ear effusion caused as a result of cleft lip and palate. Bilateral hearing losses constitute a majority of 96% of the hearing loss population, and only 4% was reported with unilateral hearing loss. As shown in this chart, 40% of the hearing losses were severe to profound, in which greater proportion of sensorineural hearing loss were profound, which was 42%, while least was mild and moderately severe hearing losses, constitute of 5.3%. In auditory neuropathy spectrum disorder, 50% of the cases were profound hearing loss, and the remainder could not be specified. This shows the documented risk factors we could get from the pediatric case history questionnaire. According to this table, the most prevalent risk factors causing hearing loss were admittance to NICU for more than 5 days, which was 24%, low birth weight 20%, hyperbilirubinemia 15%, and ototoxic drugs 11%. It was also true for sensorineural hearing loss specifically. The least affecting was meningitis and asphyxia, which was 4%. For auditory neuropathy spectrum disorder, hyperbilirubinemia was the major risk factor, which constituted of 66%. This graph clearly shows all the documented risk factors and how often they have occurred. Considering the age of hearing loss suspicion and diagnosis, it was evident that the mean age of diagnosis of hearing loss was 35.8 months, with a mean delay of 11 months between age of suspicion and diagnosis of hearing loss. Average of hearing loss suspicion in cases of ANSD was 17 months compared to 23 months for sensorineural hearing loss, which was not statistically significant. The average age of hearing loss diagnosis in cases of auditory neuropathy spectrum disorder was 28 months compared to sensorineural hearing loss of 36 months, which was also not statistically significant. Coming to speech delay, most individuals with hearing loss exhibited a speech delay, with the highest proportion indicated by individuals of sensorineural hearing loss. It was 71%, and 50% of auditory neuropathy cases, and the only case with conductive hearing loss also indicated speech delay. 53% of individuals with normal hearing were also identified with a speech delay. Moving on to discussion. Within the sample population, the most prevalent risk factors causing hearing loss were admittance to NICU for more than 5 days. The 2007 Joint Committee on Infant Hearing position statement includes that neonates at risk of having neural hearing loss in the target population to be identified in the NICU, and there is evidence that neural hearing loss results in adverse communication outcomes. Within the sample population diagnosed with ANSD, the most prevalent associated risk factor was hyperbilirubinemia, which was 66%. This is in agreement with the multi-center study by Berlin, wherein 48% of ANSD cases presented with hyperbilirubinemia as a risk factor. Delays may result in low educational and employment levels in adulthood. To maximize the outcome for infants who are deaf or hard of hearing, the hearing of all infants should be screened at no later than 1 month of age. There was a substantial delay between the age of hearing loss suspicion by caregivers and the age of eventual diagnosis in the study population. This long delay evidences the limited newborn screening programs available in public and private healthcare sector. However, it was not significant in sensorineural hearing loss and auditory neuropathy spectrum disorder in the study. Most likely, this can be due to most of the children already being enrolled in early intervention programs. As a result, they are predisposed to be from more developed socio-economic settings, with newborn infant hearing screening being more likely and access to services being better, which allows children to receive optimal benefits from early detection and subsequent intervention. Coming into conclusion, the hearing loss across this pediatric sample was permanent with a high prevalence of bilateral sensorineural hearing loss, whereas conductive hearing loss was the least exhibited. Most of the children with sensorineural hearing loss had a profound degree and least of them had mild and moderately severe hearing loss. The most prevalent risk factors that cause sensorineural hearing loss was admittance to NICU for more than 5 days, low birth weight, hyperbilirubinemia, and ototoxic drugs respectively. The least affecting was meningitis and asphyxia. For ANSD, hyperbilirubinemia was the major risk factor. It was evident from the study there was a delay between age of suspicion and diagnosis of hearing loss. However, it was not significant in SNHL and ANST. In addition, majority of individuals with sensorineural hearing loss as well as normal hearing individuals here who had at least one or more risk factors exhibited speech delay. These are my references. Thank you.
The final presentation is management of sudden sensorineural hearing loss among general practitioners in northern and eastern province by Sindhuja Ramakrishnan. Sindhuja, over to you.
Which one? A very good evening, all of you. I'm Sindhuja. I'm an audiometrician from Trinco Vision Care. First of all, I would like to thank everyone for giving me this opportunity to present my research. This is my heading, Management of Sudden Sensorineural Hearing Loss Among the General Practitioners in Northern and Eastern Provinces. So before I'm getting to the presentation, I would like to explain why am I choosing this topic, as well what is the sudden sensorineural hearing loss. So very first I would like to explain what is the sudden sensorineural hearing loss. It's nothing but sudden, it is a sudden onset of hearing deafness. It is a sudden sensorineural hearing loss. Then why am I choosing this topic? As I'm an audiometrician, 2 years I'm working in this vision care. So I have met a lot of sudden sensorineural hearing loss patient with and without intervention. So that's why I'm very interested to do this topic. So these are the contents that I'm going to talk. First, introduction, background, and the statement of the problem, objective, methodology, result, discussion, and conclusion and reference. So introduction, sudden sensorineural hearing loss, it is a medical emergency that can be lead to the permanent and the devastating consequences if we left untreated. And the sudden sensorineural hearing loss is defined as a rapid onset of the hearing loss less than or equal to the 30 dB hearing level across the contiguous frequencies, 3 contiguous frequencies in 72 hours or less. And the patient, they almost they are complaining that they have the oral fullness, tinnitus, or it accompanying the symptoms. With some of them, they complaining that they have a vertigo as well. And the sudden sensorineural, it is unilateral, but the bilateral involvement is occurring the less than 2% of the time. And the etiology, it's unknown. It's a majority of the patients who have present with the sudden sensorineural hearing loss. Therefore, they told that it is a idiopathic reason. And background and the statement of the problem. Mostly the general practitioners are the likely to be the very first point of the contact for a patient. They seeking the attention for a sudden sensorineural hearing loss. So they have the crucial role of recognizing the potential cases in initiating the appropriate management quickly, because its delay it have the serious consequences to prognosis. And I have the 2 objectives. The very first objective is to gain insight into the current practice trends. It's pertaining to the diagnosis and management of the sudden sensorineural hearing loss among the family practitioners. And the second objective is to identify the perception in the general practitioners is regarding the awareness of sudden sensorineural hearing loss among the general public. So for that, to my research, this is my methodology. The study design is to study design is a descriptive cross-sectional study, and my study sample is the general practitioners who have been in the northern and the eastern provinces, and sampling method is purposive sampling method, and data collection instrument is close-ended questionnaire that was sent to the general practitioners, and data collection method is through the face-to-face interview, and data analyzing method, data was tabulated in the micro Excel, and the duration of my research is the April 2022 to May 2022. And the mechanism to assure the quality of the study, its consent was administered prior to the interview, and data saved and locked in order to access only by the researcher. And ethical consideration is the Vision Care Academy. And next I'm going to move on to my result. My questionnaire that was sent to the 17 general practitioners and received the consent form from the 14 of them. So the response rate is 82.23%, and demographical factors, the 50% of the general practitioners, they have got the 16 to 20 years of experience in their practice, and while 35.7% of they got them 20 years of experience, and 14.3 they with the 5 to 10 years of experience accordingly. So 11 general physicians from the northern province, and 3 of them are from the Trinco province, and all the participants, they provide the primary care is the suburban region. And this pie chart, it's described the came up the patient, it's they complaining the unilateral acute sudden sensory neural hearing loss. So it shows that the majority of 92% of the participant, they have met the sudden sensory neural hearing loss. They complaining they have the unilateral sudden sensory neural hearing loss. And next, this bar chart, it defined that the percentage of the referrals do you make upon the presentation of the suspected unilateral sudden sensory neural hearing loss. So this shows that the represent that the majority of 78.6% of them, they have referred to the audiological evaluation, and 35.7% of them, they refer for the ENT consultation, and 28.5% of them, they recommended for emergency department. And next, this bar chart, it shown the percentage of the responses on the pharmacological agent they prescribe as a treatment when they suspect is it is a sudden sensory neural hearing loss. So from that, it's according to the medical management prior to the confirmation is that is a sudden sensory neural hearing loss. From the audiological testing, 78.6% they are prescribing the antibiotics, while the 21.4% they prescribe the corticosteroids, and 21.4% of them, they respond they never prescribe none of them the pharmacological agents. And next, this bar chart is shown the number of the responses on topic. It's included as a part of counseling patient to presenting with the unilateral sudden sensory neural hearing loss. So from that, as the topics, it included the counseling to the patients with the sudden sensory neural hearing loss. 2 of them responders, they told they have the available treatment option and the associated risk and the benefits. And 1 of them, they told the rehabilitation options, such as it's a hearing aids like that. And some of them, the 10 of them, they told they do not counseling the patient presenting with the sudden sensory neural hearing loss. So rarely they certain they prescribe, and 1% they told that none of them they prescribe anything. And this bar chart, this pie chart, it shows that the awareness of the general public, they have the sudden sensory neural hearing loss as a medical emergency. So according to the perception of the general practitioners regarding the awareness of the general public on the sudden sensory neural hearing loss, that it is a medical emergency which need to get the early intervention soon as possible. So from that, the 64% of them, they have believed that the public, they have the fair awareness from awareness of the sudden sensory neural hearing loss, and 29 percentage of the responders, they consider that the awareness level is unsatisfactory, and the 7% of them, they admit the general public they have the satisfactory level is very low, like that. And now I'm going to move on to the discussion part of my research. The incident of the sudden sensory neural hearing loss, if we consider the 5 to 20 per 100,000. So the true incident of the sudden sensory neural hearing loss may be higher than this estimate, because considerable amount of the affected individual do not present for a medical care. So the majority of the general practitioners who participated in our study, they experienced cases of the suspected sudden sensory neural hearing loss, which reflect that it is a general medical condition that could be quite common. And Barry Ragan, 2019, he was mentioned on this study. The goal of the initiate the evaluation of the patient with suspected sudden sensory neural hearing loss is the urgent referral to the audiology for a rule from the conductive hearing loss to sensory neural hearing loss, and it refer back to the ENT. For the further medical management, the result is represent the general practitioners refer for a ENT consultation. So audiological evaluation or refer for an emergency department, which are the most appropriate referral source of the management pathway. So then Aaron Metterel, 2016, in his study on the management of the sudden sensory neural hearing loss, he concluded that the sudden sensory neural hearing loss is a otologically emergency. To appropriate counseling of the patient is necessary to make educated. From the result of the study, also it's referred as the general practitioners, they believe that the general public has only fair and unsatisfactory level of the awareness, which require to give more educated to the general public. So now I'm coming to the end of my session. This is my conclusion. So further studies is required on to identify the two incident of the sudden sensory neural hearing loss, as the majority of the general practitioners, they have met the patient suspecting the sudden sensory neural hearing loss. So general practitioners who participated in the study would make appropriate referrals and the treatment and decision in the management of the sudden sensory neural hearing loss, and recognizing it is a medical emergency, require it's a urgent care, like that. So this is my conclusion, and these are my references I use for my research. And thanks for being very quiet and listening my research, and thank you for everyone.
Thank you, Sindhuja. And we have reached to the end of the 12th annual scientific session, and it is the time that our esteemed panel of judges is going to talk to us. First, I would like to invite Dr. Pabakara Costa to address the audience with your thoughts, sir. Over to you.
All presenters, honorable guests, CEO and team of Vision Care team, all the presenters and all members join us physically and online. First, I would like to thank you all for inviting us for this occasion. There were a lot of good presentations, and it was really a difficult task for us to select few presentations among them. And we have mainly considered the novelty, the importance of the research work, and how you approach the problems. And the most importantly, for those who do not get a prize, do not disappoint, because you have all done a very good work. And you will get a reward in future when you keep up your research work. So please keep up on your research work and continue your good work. And I would like to conclude again by thanking Vision Care team for inviting us, and I wish all researchers best of luck, and all in this institute good luck for their future work. Thank
Sir,
you.
please remain on the stage, and I kindly invite Mr. Dasanta Fonseca and Mrs. Kumari Fonseca to deliver the token of appreciation. Thank you very much, sir. Thank you, sir. Thank you, madam. And now I kindly invite Dr. Dimuthu Gunasekara to address the gathering.
Thank you. Actually, Dr. Prabhakar said all the things that I should mention, and thank you for inviting us to join with you at this special moment. So, for all the students, all the lectures are good, all the presentations were good, and as beginning budding optometrists, we appreciate doing research for the upliftment of your field. Yeah, so continue your good work. I would like to emphasize on some aspects that you have not been fully aware in your research work. I mean, like case series and case studies, those words, right? So case series means if you see more than one cases, like a number of cases, if you study, it is a case series. If it is one case, one patient, it is a case study. So I found that some students has confused with these two terms. I just wanted to correct that just for your future reference. So case series is a number of cases. Case study is one case. You study one patient and that is a case study, right? So I saw in some presentations, so case series has been mentioned and only one case was there. So one case has been referred to as case series. So just small things, correct, and you can go ahead, right? So all the best.
Thank you very much, sir, for your kind thoughts, and please remain on the stage. Again, I kindly invite to Mr. Dasanta and Mrs. Kumari to deliver the token of appreciation to Dr. Dimuthu. Thank you very much. And now virtually, Ms. Ananta Lakshmi will join with us.
So, thanks a lot. It's been a great evening for me, a great day for me. I would say I've always been participating in these events, and year by year, I'm getting really astonished because by the type of topics you are choosing, I think you have a very good. You choose your topics are something which is very, very fantastic. Thanks to the entire team who are behind these presentations. As the other judges rightly said, you may have more participants, but winners may be very few. But then it is not all about winning, but it is all about going and facing the challenge. I think all of you have done your best. One more thing which I feel could be included most of your topics could be is what is the way forward, so I found some of the topics which is very, very good. How do you plan to take this forward? I think that is something which would be really very good, because end of the day, whatever we are doing now is to ensure that we bring about a change in terms of vision, in the way in which we are bringing about our solutions to our patients and customers. So if you really feel that you want to take it forward to the next step, I think that is something which we would like to listen. That will add a lot of weightage to your presentation, because you really believe that something good you have found out from those studies or for those presentations, you would like to take it further, and what would be the next steps. So you found something, what is the next thing you want to achieve? So this could also be a continuous thing which you can take it for a long time, and maybe you can also present it even the next year to show how you have progressed from studying to how you have progressed in terms of implementing it. So these are some of the few points which I thought would be very, very helpful for you. And again, I reiterate, thank you, Mr. Dasanta and Mrs. Kumari, for inviting me. As usual, I've enjoyed this day. You made my day. Thanks a lot. And good luck to all of you.
Thank you very much, Ms. Ananta, for joining with us. And now I cordially invite Madam Dr. Mrs. Sanjeevani Rupasinghe to address the gathering.
Thank you very much. According to what I have seen and heard today, I think research is very important for any field to develop, and you have to choose research topics which can change the management or which can improve. It's not a audit that we really require. Research is something that you can get a conclusion which can improve the management of your field. So what I have seen today is most of you all have done retrospective studies with close-ended questionnaires. So try and develop prospective studies with randomization and all, with so that you will have more information which will definitely improve the clinical outcome. And I wish you all success in future. Thank you.
Thank you very much, Madam, for your kind thoughts. And it's the time to you, sir. Being grateful for your strong leadership, which has made the way for us to stand our own. We are most honored to invite Mr. Dasanta Fonseca, Chairman, CEO of Vision Care, to enlighten us with your thoughts.
Thank you, Viranga. It's a very happy day today, especially in every year, second Sunday of the June, we are having this program. Except for 2020, 2021 is totally a virtual event, but this time it's a hybrid event.
Excuse me, Hari, you are right.
Event, and it's very important and happy day for us. We see our staff and our juniors are showing their colors, and that's very important. And this year is very special because we are doing it on our own premises, and that's another important in this year. And I have to congratulate the organizers and thank the doctors who helped us, staying with us, Dr. Pubudu and Dr. Costa, the whole day, and our madam for spending the whole evening with us. And again, the research for this is our 12th session, so we have to go for the next level. I'm sure now the new staff coming into the new premises and with these things, next year we should expect a better program. Not that this one is not bad, it is okay for the level of our diploma students, and we are trying hard to go to the not very easy, but to have a degree program in the near future. And while there is another message I wanted to tell you in these difficult times in the country, that is the technical part of our job, like doing a refraction or do a visual field is only a percentage of the success or what patients expect. So there is another part that you have to act, looking after the patients, asking them, are you okay? And then we have done the job proper and looking after the human side of the job, other than only to stick to I do the refraction and that's the end of it. It is not to do the visual field, not to fit an hearing aid, but see to that they are comfortable with what you have done. So they come from different places with lot of hopes. So you do 20-30 patients a day. but for them, that they spend the whole day coming to you, so you have to look after them from the technical side as well as the human side as well. So finally, this time there's another observation, that is a lot of juniors are doing the presentation, so we need seniors, because seniors to come up and do research. I'm sure they are guiding the youngers behind the scene, but I'm thankful for the seniors who has presented, but we would like to see more senior staff, more experience. They have more experience in the field, and for them to come up with some more things for the next year. And thank you very much.
Dear sir, please remain on the stage. And now we are going to start our awarding ceremony. And I kindly invite Mrs. Kumari Fonseca also onto the stage. Okay, now we are excited to announce the winners of the day. This is the most anticipated moment we have resulted. Now I have in my hand. Okay, and the first winner, Best Oral Presentation, Senior Category, goes to Chanura Mahindapala. Chanura, I invite for you to have your medal. The next winner is Best Oral Presentation, Junior Category, Diploma in Optometry, Chandramohan Tilakshana. Best Oral Presentation, Junior Category, Certificate in Ophthalmic Assistant, Pramodya Tatsarani. Best Oral Presentation, Junior Category, Certificate in Vision Therapy, Ravindu Deshan. Best Oral Presentation, Certificate in Dispensing Optics, Kavindi Silva. So now, the best research of the year 2022 in our optometry day goes to Ravindu Deshan. Best Post of the Year, Amila Chandrasekhara. Best Innovation of the Year 2022 goes to Suresh Sulakshan. And the Best Research Presentation, Audiology Department, Darunya Komaleswaran. And the Best Poster, Audiology Department, and Sureni. Heartiest congratulations to all the winners. Ladies and gentlemen, let us all treat the winners for this evening with a big round of applause. Thank you very much, Mr. Dasanta. Thank you, Mrs. Kumari. To conclude the event, Scientific Session and Optometry Day, I would like to invite Fatima Mufrisa to deliver the vote of thanks. Fatima, over to you.
Good evening, everyone. It's a great honor to deliver the word of thanks and acknowledge the contribution of those who really worked hard to make this event possible. On behalf of the Vision Care family and the organizing committee, I would like to extend my heartfelt gratitude to our chief guest, consultant eye surgeon, Dr. Mrs. Manuel Pascal, and guest of honor, Mr. Udeni Vikramasinghe, who actually spared their invaluable time despite their busy schedule to grace the event. I must mention our deep sense of appreciation to a special invitee, Senior Consultant Eye Surgeon, Dr. Upali Pendis, and to our special advisor, Professor Madhuvanti Disanayaka, for guiding us throughout. Further, we are grateful to the keynote speakers, Dr. Aruna Fernando, Dr. D.R.R. Kodikara, Dr. Mrs. Sanjeevani Rupasinghe, and Ms. Ananda Lakshmi for their deep and intellectual way of imparting knowledge that added glory to this event. I may like to express our sincere thanks to the esteemed panel of judges, Dr. Pabakara Costa, Dr. Dimuthu Gudasekara, Dr. Mrs. Sanjeevani Rupasinghe, and Ms. Ananda Lakshmi for your time and dedication that made it possible for us to reward the presenter for their creative efforts. I also wish to express my gratitude to Dr. Saman Basnaik and the entire crew of Mount Lotus INET Hospital for your tremendous support. Our sincere gratitude to Mr. Dasanta Fonseca, Mrs. Kumari Fonseca, and Mr. Janaka Fonseca for their immense support and guidance throughout. I am also thankful to the members of General Management Committee, heads of department, optometry developmental heads, and cluster managers for their presence in this wonderful event. Further, I would express my gratitude to the head of academy, Mr. Vidya Jaratna, Deputy Principal, Mr. Amila Chandrasekhara, all the lecturers, and the academic team for their ultimate support in organizing this event. And also, I extended gratitude to all the presenters and post-presenters for gracing their important work and sharing with your findings and opinions today. Finally, I would like to take this opportunity to place on record our hearty thanks to the marketing team, technical team, IT team, and finance department, and also the backstage supporters for their enormous cooperation in making this event a success. Ladies and gentlemen, once again I would like to say that we all are most grateful to all who have been with us, both physically and virtually, for their utmost support given to success the Vision Care Optometry Day and 12th Scientific Session. I would conclude my speech with the declaration of the next Optometry Day to be held on June 11, 2023. The next chairperson of the Optometry Day and the 13th Annual Scientific Session is Ms. Pramodya Satsarani, following the committee members, Mrs. Hasna Shafiq, Mr. Geeta Bekon, Ms. Chalani Nimesha, Ms. Lashini Kaushalya, and Ms. Sachini Niroshima. We'll all meet you on the next Optometry Day. Thank you very much.
And with that, officially we conclude Optometry Day and 12th Annual Scientific Session 2020. And thank you very much for your presence today, and tea is ready for you at 8th floor. Thank you very much. Have a good night.